Your event with Ayedi TV. Are you looking for ways to make your events more memorable? Contact Ayedi TV for professional event live streaming on Facebook and YouTube. Our package also includes photography.
So feel free, don't imagine that you're...
Wow, another hand clap for Professor Edgar. Thank you so much, Prof, for briefing us of what we expect in the day. And thank you so much for living up to the dream of innovation here at MAST. So I also want to recognize the counselor for the embassy, Ugandan embassy in Burundi, Mr. Wafula. You're most welcome. Yeah. Thank you so much. You're most welcome. So we request. I hope the moderators are all ready for us today. We should have, I think, the team constituted for the moderators. So as the panels get ready, we have two keynote addresses from our Vice Chancellor. I want us to, yes, we have DVC, who is representing the Vice Chancellor. Let's have a speech from Professor Charles Kazoba. You're most welcome. With a hand clap, please.
Good morning, colleagues. Good morning. Just before I say what I'm to say on behalf of the Vice Chancellor, Professor Celestino Bua, some of us walked in this room before some of you, so we never managed to say hi to each other. So I would like to request you to turn to the person next to you. Just listen for the kindly listen for the instructions, please. Wait for the instructions. Just look in her face or his face. Those are the instructions. And you smile, and then you can touch her or him. And now, thank you. A disclaimer, please. The person you looked through the face and you smiled, the person whom you touched, please, that is not your greeting. It's the greeting from me and from Bara University of Science and Technology. So, dear participants, those who have traveled, I don't know how many kilometers, those who have taken, let us say, 1 minute or 2 minutes or 5 minutes to reach here, those who have used border, those who have used vehicles, those who have come jogging, you are all welcome. But I do also recognize within us here, there are those who have traveled from far. Just our Mr. Wafula James, the counselor of the embassy of Uganda in Burundi. If I am to estimate, you may have traveled 536 kilometers if you used 0.8 kilometers from Bujumbura to here. And you may even have taken 9 hours and 51 minutes to reach Mbarara. That's very, very interesting. You can imagine somebody traveling such a long distance to come and be with us. That means you take this CamTech and it's part of you. You can imagine spend all that time. So you must say, welcome to Uganda. To you, my colleagues, Mbarara University is here because of you. And I sometimes want to use the example of a block, just a building like this one here. There are many bricks or blocks that were used. Even some are in the foundation, but they are also blocks. They are bricks. Some are in the outside walls. They are also blocks. They are bricks. Even some are in the inside wall. They are also bricks. They are walls. So we need to thank you as a university for what you are doing for this great institution, which was started in 1989, Mbarara University of Science and Technology. It is exciting to welcome you on behalf of Professor Celestino Bua, the Vice Chancellor or the CEO of this university. We are excited as an institution. And personally, I have no doubt in my mind that the output that are going to come out from the 3 days we are going to be here, today, tomorrow, and Sunday, the outputs are going to be excellent. And in particular for this summit, clinical summit, I was seated in front of my other colleagues and I was imagining, and I'm going to miss their presentation, which they are going to make, Professor Joram Joseph Ngonzi and scholar. Very interesting, topics which we are going to discuss. I'm going to miss them because we have got a governance meeting, a meeting of finance planning and development taking place at the town campus, and it is starting at 10. So I'm expected to be there on behalf of the university. You and me know our Vice Chancellor. He's a champion of research. He's a champion of innovation. He's a champion of community engagement at this institution. Can we give him a clap in his absence? Yes, in absentia, I know she is coming. Reverend Father Apollinari, the Vice Rector of Gonzi University, who was earlier on recognized, is warmly welcome to be with us. You can imagine to leave and you to come here to be with us. And this network, this partnership, some time back they used to say, either you publish or perish. This is what you would hear in the 90s, in the 70s, and even by the way, in the early 2000s. Either you publish or perish. I think that was yesterday. The slogan is now changing. Either you network or you perish. It's not publication, it's the networks. Whether you are young as a scientist, when I say young as a scientist, don't get me, we are all adults. But the most important thing in your individual, and I liked the comment by Professor Edgar Mologo when he was saying that when we are here, let us interact, let us network, let us discuss amongst ourselves, and by doing that, at point T, we'll be learning from each other, and later on we form networks. So it's not publish or perish, it's to network. And I believe by the end of the 3 days that we are going to be here, make sure in your asset, in your inventory of team member of the people you collaborate, in a list, at least 2 or 3, so that they become part of you. This year, 2023, we celebrate 11 years of innovation. And once we say 11 years of innovation, as far as CamTech is concerned, that's roughly equivalent to 132 months. Or if you want 4,015 days, you can imagine of excellence. And I was looking through the archives of the university. If Dr. Data, you know very well, when we had it was a summit, it was at Lakeview. It was not for 3 days, please. I was there. It was only from 2 to 5 p.m. Now you can imagine this was for a short time. But that was a summit. That was the celebrations. And I also looked through the records and I saw some of the letters which data by then. And even I looked at the picture which is on your file. I think you took it when we were even starting. I could see the young, data energetic, trying even to write, to ask. And I remember even I saw a letter which was written by Professor Frederick Kayanja, by then the Vice Chancellor. And you know, Professor Frederick Kayanja was one of the people who were pushing for CAMTech to be established in this institution. We also need to thank him. Data. You know, sometimes you have got champions. You have got champions whom you want to involve, you want to recruit people. And I believe, Dr. Data, I'm not blowing your trumpet, but you are one of the few staff we have in this institution whom we can call upon and we say, come and innovate, come and innovate, come and innovate. And we need to thank you with your team. I just was chatting with Bosco over. I see the number of jobs that have been created. I see entities and partnerships. You can imagine entities and partnerships that have been formed. And these are few. So we need to thank the vision bearers of CAMTech for putting Barra University of Science and Technology at the forefront of doing things, but doing things innovatively, doing things differently, not following others, but championing, coming out our own path as far as Mbara University of Science and Technology. Of course, some may not be seen, but the vehicle is running and it is very sound as far as I'm concerned. In this journey, there are those partners, those funders whom we have been with. Certainly we are grateful to all the funders and partners over the years. Our own Ministry of ICT and National Guidance stands out. The MGS stands out. The Ghana National Information Technology Authority stands out. USD stands out. NORAD, ERMA Foundation, IDRC Canada, Lendo Foundation, the First Mile Project, and WIZ Medical Foundation, among many, through MG. Now you can imagine, by the way, it's good. It's easier. You can attract a funder. You can write an excellent proposal and you attract a funder. But keeping that funder is another aspect. So you can imagine for us, CAMTech as an example, to have these funders and you keep working with them. You keep working with them for 4,015 days. You know, this is not good. I mean, this is an achievement. You can imagine the number of days we have been working with them, and they are still here with us, and we need to thank them. Let me turn to the vision bearers, the founders, those ones who are behind, who were in the foundation of CAMTech, who were there even designing. And you know, sometimes when you are coming up with something, before it comes out, people will not see the benefits, but they were there. And I want to borrow the wise counsel of Abraham Lincoln, the American lawyer, a statesman. He was the 18th president of the United States of America from 1861 to 1865. And I quote, "Give me 6 hours to chop down a tree, and I will spend the first 4 hours sharpening the axe. 2 hours to chop or cut the tree," end of quote. Now you can imagine, these are 6 hours, and now you use 4 hours, which is 66.7% of the time that is available. But the remaining 2 hours, it's for cutting the tree, so that you know the direction where the tree is supposed to be. So I believe in this summit, we have a number of you, and I'm not mentioning the names, who have continuously sharpened the axe and later cutting the tree as far as this project is concerned. as far as this program is concerned, and we need to thank you. You and I have sharpened the axe. We know the best direction where the tree is going to fall. We don't know how long it will take. Thank you, the team behind this summit. You have done a splendid job. Let me make a sample of roll call. I would have done a sample of roll call, but I want to limit myself on that and I go further. But you say sample, I would say, you know, Sikula, you know you were there, Rukundo, you were there, Nuriat, Martin, Mackenzie, and I can mention Jerome. There are a number of you who have been there. And keep fighting as far as CAMTech is concerned. Keep fighting from Bara University of Science and Technology. And my advice is this. When you go outside, whether in a workshop or you are walking on the streets and you are talking to people, kindly don't talk 10 words without talking Bara University of Science and Technology. But at the same time, even when you talk about Bara University of Science and Technology, one of the 10 words should be CAMTech, because it has done great for this institution. You know, and me know, that large items come in small pieces, or big things come from small pieces. Let me demonstrate this. MUST and CAMTech Uganda Innovation Ecosystem has a portfolio of innovative projects at different stages of the product development and commercialization pathway. This ecosystem has created some of the intellectual property and inspiring technologies that are sources by the local innovators. As I mentioned earlier on, jobs have been created. For example, if you are to document how many people are employed through CAMTech, those directly employment and indirect, and those who were here and have gone outside there. Oh, it's amazing. As I conclude, let me use the very powerful words of Ralph Emerson, and I quote, "Do not follow where the path may lead. Go instead where there is no path and leave a trail." End of quote. Therefore, you agree with me that generating innovative solutions to address neonatal and maternal health challenges in Uganda is a new path and is leaving a trail. With those many words, ladies and gentlemen, as Mbara University of Science and Technology motto is, in unison, succeed we do what? Second time? And finally, the third time? For God and my candor, and I thank you.
Thank you so much. Thank you, Professor Kazoba. I told you that when he speaks, it's like from a father's heart. Okay, challenging us to network, challenging us to sustain partnerships. You know, when you're young researchers, today you have one funder, the next you're jumping to the next. But those who have sustained funders have done a great job. So thank you so much, CAMTech. Thank you, Prof. Thank you, Prof, for that institutional memory of showing where MUST has come and where it is. Thank you. And also for the good dreams. He is already dreaming of business clinics. He's dreaming of great things, you know, innovation hubs. Thank you. Yes, and when a father dreams, what will the children do? As students and young researchers, we dream along. So thank you so much. And thank you, CAMTech, for this opportunity. For all of us who are here, you're most welcome. I take this opportunity to, Professor Kazoba, our regards to the meeting that you're going to. Thank you for representing MUST everywhere. And he has said that we should always speak MUST. Not 10 words should leave our mouth before MUST comes around. But again, don't start speaking alone, as you end up. Yes, mental health may catch up with you. So thank you so much, and we want to take this opportunity to invite our keynote speaker today is going to take us to the heart of the clinical summit. Professor Joseph Ngonzi, the Dean of the Faculty of Medicine and a champion of innovation and research, is always supporting research teams. He's already thinking of how research can be more simplified when everybody thinks that it is complicated. So you're most welcome, Professor Joseph Ngonzi. Let's give a hand clap as we welcome him.
Good morning. Good morning. My name is Joseph, and I've been given the task to say a few words. Right from the start, I want to appreciate the leadership of Medtech for putting this together and for inviting us to this great engagement. Thank you, Dr. Data and your team. Let's appreciate them. I kept thinking through what Dr. Data asked me to hint on, and I found it a world of many possibilities. And I also extrapolated my thought process to the audience, and I got a hint that the audience would be a multiplicity of people coming from different backgrounds. I thought about the sociologists. I tried to walk in their world, and I hit a wall. I thought about the politicians, the Dr. Sebutin Desir, and I also could not travel further. And I thought about the professors, public health experts. I tried to at least engage 1% of their journey. And when I was getting frustrated, I decided to think and also write listening to my heart. And I put a few things in these few slides to deliver the task that was assigned to me. Leveraging innovation to achieve equitable and sustainable healthcare. It's a full package, but nevertheless, as we get to the next slide, this confusion you see here explains the world I've been going through for the last 2 days. And there are many areas here that speak volumes of ideas that can come forth. Of course, being a gynecologist, I could not miss out the most important population in the world. But still, it was another area that was monstrous. When I read about healthcare innovation, there are many things that have been done, and still there are many gray areas. At the end of my very short talk, I'll draw us to the Ugandan picture, because I know 90% of the audience here are Ugandans, and it's good to know some of the things that the country is looking at. And you begin innovating locally, but with an international mind. Innovation is increasingly becoming or being seen as a form of currency, both today and where we are going. The future of affordable, appropriate, and accessible healthcare delivery process in the new knowledge economy will continue to depend on the ability, number one, to generate new ideas, two, processes and solutions. And through this process of innovation, there's going to be conversion of knowledge into the socio-economic good and wealth. I got to learn when I was attending Dr. Datta's informal lectures at the start that when you innovate, you need to have a sustainability plan in mind and a business model, or else you become irrelevant and the resources you've already put in get wasted. Next slide. Innovation has become a mantra. You either innovate or become irrelevant. And an institution like MUST or many others across the globe cannot outgrow their competition unless they are able to out-innovate. You get a successful innovation now, it's not time to sleep, but it's reason for you to keep thinking, what next? Corporate growth in different organizations springs from the world of innovation and invention. And you cannot continue to do today's job, even as a clinician, as a biomedical engineer, with yesterday's archaic methods, and you still expect optimal results. You need to enter into the competitive environment where new ideas improve outcomes. Next slide. Innovation, of course, this is knowledge that is available even on the web, but involves the process of designing, implementing new products, services or solutions that create new value. And for us today and this weekend, create new value in terms of healthcare optimization. Clinical innovation, which we are all going to be involved in this weekend, involves implementation of new care models that produce better outcomes and improved value. The ideas that will be coming forth, I'm convinced, will be hinged around this area. Let's keep moving together. I need to wind up. There is a concept of build, measure, and share. Build, get the ideas, develop them, and then measure and share. Do not keep them in your pocket. They need to go out there and they help out the beneficiaries. As we think about innovation, it's important to note, next slide, it's important to note that there are many stakeholders that contribute to the world of innovation. Different stakeholders, and each one of them has got their own unique contribution to the process of innovation. The government, in terms of framing healthcare policies and regulation, financing, and many others. Non-government organizations, quite many in terms of advocacy, pharmaceutical companies in terms of provision of drugs and consumables, research and development, medical devices and biotechnology firms, which also participate in research and also product development and cost control. Very importantly, the providers, like some of us who are clinicians, in terms of diagnosis, investigations, treatment, and monitoring health outcomes. There are health insurers who provide financial coverage and also mitigate risk exposure. Academia, where many of you are involved, in regard to medical education and training, and also research on innovation and best practices. And very importantly, the community. When we are innovating, it's not just for academic purposes, but we need to have the community in mind. When there is a mental health case, someone trying to cope with crisis of life following COVID, as I innovate in the mental health area, I need to be mindful of that young man, that young woman who is trying to fight through to earn survival. Community. I need to think about someone who is deep down Professor Kabachenga's village of Kaberebere, trying to access maternal health care. That one in the garden, digging. I need to think about people in air-conditioned offices. They also have needs that need to be met. So thinking through the continuum of community needs is very key. Innovations, like I said, are present across the healthcare continuum. And as we go through that journey, we need to think through the direct stakeholders, and there are those who may not directly be involved, but they are very important stakeholders. As we come up with new products, with new processes, with the new technology, the air device, and many others, I want to congratulate Data. Thank you for publishing some deliverable from your air device work. Let's appreciate him. As we think through these things, product innovation, process innovation, paradigm, many things, we need to always remember every manner of detail that pertains to innovations. Of course, as I thought through leveraging innovation to achieve equitable and sustainable healthcare, we cannot divorce ourselves from global goals set, such as the Sustainable Development Goals. And going through SDG 3, about healthcare, there are a number of targets. I'll not go through the details, but just to flash this for you to know that there are global processes in place where we need to hinge ourselves and not just innovate in solitude or in isolation. There are a number of strides that have been made. Next slide, have been made. And there are achievements that have come through from the different sectors globally. And as we narrow it down to Uganda, these are just achievements that have come through that particular SDG. And the next slide speaks about the picture of the Ugandan, next slide, of the Ugandan focus. Uganda Bureau of Statistics just released the Uganda Demographic and Health Survey statistics, and there are areas of focus that they highlighted. As we innovate things that are going to impact people globally, we also need to think about the local picture. There are areas around family planning, marriage. How do we reduce gender-based violence and many other things? Extrapolating your innovative mind about sexual activity. How do we get apps that are going to help teenagers who are app savvy be able to access sexual reproductive health services, even in their bedroom deep down in Kabuyanda? Okay? Maternal and child health. That baby who's not breathing well, what solution do we have for that particular baby born in Imbara Hospital, even when the supplies are very erratic? but there's something that is cheap, affordable, accessible, that can be able to help save the life of that future minister. Domestic violence, childhood and maternal mortality. Nutrition, very important. How do I help a lazy Ngonzi who eats everything left and right, and his BMI is approaching 50? How do I help him to know that healthy eating is important? What can I innovate around that process to convince this rigid eater? Malaria continues to be a very big challenge to our community and also much of sub-Saharan Africa. Child labor, discipline, HIV, AIDS still coming up. I thought that flashing this slide and the areas of focus for the Ugandan government would be very important as we innovate. I would feel I've done myself as a Ugandan justice to let you know what we are also focusing on as a country. So many words spoken. I want to thank you again and wish you a very successful hackathon. And thank you, Dr. Data, with your team for inviting me. Have a very good morning and a very productive weekend. Succeed we must for God and my country.
A big hand clap to Professor Joseph. Wow, thank you so much. I told you that he would bring us to the heart of the summit, to the areas where the gaps are. He has ended with the country focus. Where are we focusing as a country? Because we don't want to do innovations that are going to be redundant, okay? And not appreciated, not uptaken. So thank you so much, Prof, for that. Thank you also for challenging us to innovate locally, but with an international mind. Because you start with you think it's a local innovation, but if it's impactful, it will go beyond the borders. Build, measure, and share. I love the way when you go to the co-creation lab of Camtech, it's always, it's a whole process. They take through the entire cycle. And I want to thank Camtech for always thinking outside the box. I think these are people who thought they did the sign drop even before COVID. When COVID struck, it was very easy. We thought they were, these people who, they wish the worst. Eh? They're already thinking of the worst even before it strikes. And that sign drop, I'm telling you, for many people, it sold Camtech out there even to the shops, these restaurants, the supermarkets, the pharmacies, okay? As small as it may seem, and it has kept on the market. Most sanitizers, by the way, went off the market. The reason, the sustainability plan was not there. They didn't come to Camtech to be part of such developments that are going on. So thank you so much. We want to go to the panels. And want to take this opportunity to invite Professor Jerome Kabachenga. Oh my God, this one needs a huge hand clap. Yes. Yes, because most of these innovations, most of these units came because of the efforts, because of the strong foundation he left or he put and left in the Faculty of Medicine. So take your seat, Professor Jerome. I also request our panelists to take their seats. I request Mrs. Esther Bebwa. Is Dr. Barnabas here? Dr. Barnabas Atwine. I saw, are they the only? So I think Professor Jerome, you could constitute your panel and invite the people that need to be with you and take us through. Thank you so much.
Thank you, MC. Good morning, ladies and gentlemen. Yeah, you are all welcome to this session. As he has said, we would welcome the other panelists. He mentioned Dr. Barnabas Atwine. Maybe he's caught up in the hospital. Dr. Mutekanga, physician, you are welcome to join us. And there is Dr. Isaac. Are you around? I may not know you. Yeah, but maybe we are going to start. The others will join us. As you can see on the program, we are going to handle challenges and opportunities for effective prevention and management of non-communicable diseases. By way of introduction, you have heard my name. My name is Jerome Kabachenga. For those who are from outside Mbarara who may not know me, my first degree is in medicine and surgery, but the other postgraduate qualifications are in public health. I'm a lecturer at the level of a professor in the Department of Community Health at Mbarara University of Science and Technology. But I'm also a director of an institute focusing on maternal, newborn, and child health of Mbarara University. I would like now to first have the panelists also making their brief introductions.
Thank you, Professor. I'm called Esther Bebwa from Nursing Department. I'm a lecturer, and I did bachelor's in nursing, and then my master's I majored in surgery, and now I'm glad to be here. So please, let's work together, and then we see what we can do about non-communicable diseases. Thank you.
Thank you so much, Professor. My name is Andrew Mutekanga. I am the newest internal medicine specialist, product of MAST, and it is my pleasure to be here to share knowledge.
Thank you for those introductions. Now, non-communicable diseases. In our environment, we have mostly been used to communicable diseases. The most recent one is the COVID, where the whole world was put to a standstill, and it took us back to the basics. Although now, once the pandemic has gone down, we have gone back to our old ways. It is as if things have gone back. But there is something which is coming up, especially in our environment. And for these conditions, non-communicable diseases, you may not know, and they are usually referred as diseases of lifestyle. The way we live, the way we move, like on our roads, how we are losing people, or people are getting disabled, accidents. So, and the challenge with these non-communicable diseases is that they are very expensive to manage. Very expensive to manage. So it's better that we focus on prevention of these non-communicable diseases so that we avoid. We are still struggling with the communicable diseases where we even know the treatment. The tools used are there. We are still struggling. But now with non-communicable diseases, some of them, we do not know much about what causes them. We know some associated factors, but we know how to prevent them. The preventive methods are available, so we should try to focus on that. And how does innovation come in? We should look at other sectors, how innovation has improved our lives. The good example is like the mobile phone we have, nearly all of us have. Some years ago, people used to move from very many kilometers to make a telephone call because we had fixed lines. But now you can call from anywhere to any part in the world. Another innovation which we are very much used to is, for example, people used to come to travel and go to banks to make transactions, transfer money from one account to another, to send money to people. Now, anywhere you are able to transact. And from what I read is that mobile money was, the initial innovation was done by a student in one of the universities in rural Kenya. And you can imagine even the founder of Facebook, Zuckerberg, he traveled to Kenya to come and really see this place where they had innovated mobile money. So even in the healthcare area, we need to come out with innovations which can also help people to prevent diseases or conditions, to reduce accidents. There is another major problem we have here in our environment, alcoholism. Alcoholism. Also, how do we allow people to drink, but in moderation, not to reach the other levels where we end up in areas for rehabilitation. I was reading a minister's statement here, Honorable Kaduchu, who in 2021, it was a status report. He says non-communicable diseases are responsible for 30% of early premature mortality, death before 70 years. And he said once you add on road traffic accidents, then they constitute 40% of the deaths, of premature death. So today we are supposed to have had 4, but at the moment there are 2. I would like them to tell us about these non-communicable diseases because they are involved in work that is related to non-communicable diseases, whereby they will talk about, of course, challenges and opportunities. I will start with the physician, very fresh from the factory. Yesterday, there was some important funeral here yesterday. I saw him online. He was being tasked to explain how some of these deaths are caused. So here, Dr. Andrew Mtekanga, especially the cardiovascular diseases and diabetes. Thank you.
Thank you so much again, Professor. I have passion to see non-communicable diseases largely prevented, and When we talk about non-communicable diseases, we are talking about mainly four groups of diseases. And we are talking about cardiovascular diseases. These are diseases that involve heart health and vessel health. We talk about chronic respiratory conditions. We talk about cancer and diabetes. And these are growing challenges. I love to describe them as silent pandemics because they are not as pronounced and as compelling as COVID was, but they are killing more than COVID has done. Like we say, they are growing at a very high rate if you read reports and evidence, especially in our setting, in what people, I don't like that description, but I have to agree with it, in what people call low resource setting. Yeah, it's, I wish that one day they would call us another name. Yes, but I believe with innovation we shall reach there. So, about 33% of Ugandans are at risk of premature death. And when I talk about premature death, I mean death before 65 years of age. And this is very important for those that are not familiar with demographics of Uganda. We want people to grow old. It is a beautiful thing for our people to grow old. And for you who may not know, only 2% of Uganda's population is above 65 years. Only 2. And when you talk about those above 80, it is only 0.3%. That's why the president can give them a stipend every month, because he made his math and they don't hurt him. They don't hurt his pocket. But that's not a good demographic for a country, because we believe people who are aged have experience and the biggest enemy of the aging population is the non-communicable diseases. All of us are aging, and we need to know that our enemy is there. And when you talk about non-communicable diseases, people, interpret them in terms of the traditional risk factors, obesity, poor feeding habits, but those are not our problems actually here in Africa. For example, our people are not obese. If I want to, here, when you compare America, for example, and Uganda, people are not obese. So we cannot say that the drivers of non-communicable disease is obesity. Even nutrition, we don't eat badly actually. My grandmother in the village does not eat Rolex. She doesn't know chips. So I wouldn't say she eats bad. She eats really well, okay? She eats organic food. So when you interpret non-communicable diseases in terms of those traditional factors, physical inactivity, you miss the whole point. In Africa, in Uganda, we have peculiar risk factors. And innovators need to listen to these factors so that they could, and they are still virgin areas. We are talking about things like air pollution. Air pollution is one of the biggest drivers of non-communicable diseases. Imagine we have 1 million borders. Each of them produces fumes. And these fumes, you breathe them in, they enter. I have been fortunate to be one of the few researchers doing air pollution research. And these particles that you cannot see enter your lungs and sometimes diffuse into your blood and give you risk to cancer, to diabetes, to hypertension. And they are beautiful areas for you to start thinking about. We are looking at people who generate air purifiers, for example, for this room. We are looking for people who can, innovate for air quality monitors. I can tell you, before the Airco, there's a company called Airco in Kampala. Before them, we were buying air sensors from Canada, from the US, until one person in Makerere invented one, and we are looking for more people with the same mind. When I talk about risk factors that are peculiar to us, we are looking at things like obstructive sleep apnea. For those who may not know that, I will make it simple for you. I know you have met people who snore at night. Do you know that snoring could cause you diabetes, hypertension, and heart disease? Yes, it can. Yes, there's rich literature that can actually defend that. And simple is that if you cannot breathe in, some of these waste products accumulate in your body and in the long run cause your heart and your vessels to narrow and you get a cardiovascular disease in the long run. And we are looking for people that can, innovate things like sleep appliances. It's just a simple machine you can put in the mouth, maybe, and it could actually open up your airway and you breathe better, Looking at things, we struggled with, in COVID, we struggled with breathing machines, CPAP machines, positive airway ventilation machines. The people in the West, what we call the Wazungu, refused to give us their things. And if we don't wake up, we will continue to have the same problems. Before COVID, you remember that we struggled to get masks. I remember personally importing masks from China, And when we talk about non-communicable disease, especially lung health, we have people, our fathers that are suffering from occupational diseases. My uncle who works in his carpentry business is now getting lung disease. Your relative who works in a stone quarry. And we could innovate machines to help them, protect them. Respirators. I can tell you there is no Ugandan-made respirator, as I say. If you want, you can Google. Maybe you could teach me. But as far as I know, they are all made in China. And if you want one, you'll have to import one. And I think these are things, very simple things to do. Okay? So as I finish, you can see the problem is huge. And unfortunately, because we do not take good statistics, we can't rely on what is, they say 33%, but me, I believe the numbers are bigger. Yeah, because most of our people who die in the villages, no one ever knows what killed them. Yeah, and he talked about unhealthy consumption of alcohol. And our people, because we have not, studied enough to explain to them and contextualize the science to them. Me, when I was growing up in my village, I used to see men with, now I call it liver disease. They had ascites, a big abdomen with water. And my grandmother would tell me, this one was bewitched. Bakamorogami is Genyanja. In my language, that's how they would say. He was bewitched from the sea, Yeah, but it is liver, it's alcoholic liver disease. And leaving that alone, we are talking about, when we talk about alcohol, we are talking about our local drinks, bushera and tonto, and some of these things we have not innovated enough to help the producers purify them better. And then they produce things that already have impurities and toxins that actually affect our health. There's a lot I could talk about non-communicable diseases. But for now, it should be an eye-opener that you are aging and your enemy is the non-communicable diseases. If you don't act now, your days tomorrow will be very hard. Okay? Your days will be very hard. So I want to encourage innovators here. Think hard. There's a lot to do, and yes, we can do it.
Thank you, Andrew. Let me turn to Esther. Esther comes from the nursing side. And as you all know, the nurses or the nursing side is the one that takes care for most of us when we are not in good health. And two, she has been training nurses for many years. So let her take us through that side as far as non-communicable diseases are concerned. Thank you.
Thank you, Professor. As you have heard my colleagues, they have explained and exhausted almost everything about non-communicable diseases. But you are all aware that non-communicable diseases constitute a major global health challenge. And that one hampers the nation's economic growth and sustainable development. As they have said, it is growing, and many people and all the countries are affected. And non-communicable diseases, it does not affect only developed countries or other countries, but it affects developed countries and the developing countries, where Uganda is inclusive. And it also affects the countries where there is poverty. And you know, as my colleague has said, non-communicable disease is very, very expensive too to manage. So you can imagine if we get patients with non-communicable diseases in areas where there is poverty, what will happen? That's where the death rate will increase. And also, this non-communicable diseases affects the war-torn areas. So all those people are affected by non-communicable diseases. And as we are all aware, non-communicable diseases, they don't spread through infection or from other people, but typically it is caused by unhealthy behaviors. So if we could try our best to avoid these unhealthy behaviors, then maybe the chances of reducing these non-communicable diseases could be there. And as nurses, we always want to prevent and promote healthy behaviors. So that's why when we are teaching our students, we normally include health promotion and disease prevention. So that's why we give them knowledge, we give them skills, so that when they go in their communities, they know how to help these people. Because once they go with enough knowledge and they are confident, they know even if they ask them questions, they know what to answer. And you know, it is our role as nurses always to help these patients with non-communicable diseases. Because you know, they have stigma, and stigma can come from the patient, and stigma can come from the community. Because you know, once somebody has, for example, epilepsy, that one something that is going to be very, very challenging to the patient. So the patient is going to have stigma. Even socializing with other people, it is going to be a challenge. So we have to make this community aware that these conditions like epilepsy, it is not something that is going to affect the neighbor, to affect the members of the family. And also, as nurses, we have to encourage these people who come to the clinical area, whom we meet in the community. We encourage them to make sure they go for early treatment. You know, detecting these conditions is just a challenge, because as my colleague is saying that we are in a low resource country, it is true. We are in a low resource country, and detecting these conditions is not easy, because we don't have enough labs, we don't have even specialized people who are available all the time. Because when you go to a hospital, when you go to a health facility, definitely you have to need money. And most people who get these conditions, you find that they are poor. They cannot afford. So it is our role as nurses and other health professionals to help them to go for screening early enough. So that's why, as innovators here, we have to look for a way how we can get maybe something to screen, so that these people, instead of getting these illnesses and conditions, we screen early enough. You know, when you screen and get the diagnosis in time, there you are saving a lot of things, because people are not going to get these expensive medications. They are not going to go for diagnostic procedures, which are very expensive, because they're already aware. And once you get a condition in early stages, the chances of healing, for example, cancer, once it is detected in early stages, it is easily managed. So that is going to help us to detect early, and then we do what we are supposed to do. And also, we can make these people have increased knowledge. Because people, they are not aware. As my colleague has said, some of them think that this condition, they are bewitched. This condition, they think they are myths. When they talk of diabetes, when they talk of cancers, some of them feel they are bewitched, and which is very, very unfortunate. So that's our role as health professionals, also to help them to sensitize these people so that they know what it is. And once they get the condition, they go for health checkup, and then they are helped. And also, those ones who are already with medications, they have poor adherence because they don't take drugs as they are supposed to take. So it is our role as innovators. If you could do something, maybe we get like detectors, and then if somebody has medication, can be reminded that it's time to take your medication. Because you can maybe get something and you tie it on your hand. If it clicks, maybe there you can be reminded that you are supposed to take your medication. Okay, let me give chance to my colleagues as we continue. Thank you.
Thank you, Esther. Now, as Esther was presenting, we have been joined by another panelist, and I think he has come at the right time. At the right time. This thing now, cancer, wherever you go, at funerals, at in hospitals, the main hospital, referral hospital or unit in Uganda is overflooded. They have even started getting premises where they can put these patients because there are too many. Here in the neighborhood, in our hospital, it is full. So, Dr. Barnabas, I would request you to first of all give a brief intro of who you are. I know we're informed you had to first do your duty, otherwise your patients who now it is coming to a weekend would miss out on your reviews. And then tell members, here we have an audience mostly innovators or potential innovators. There are challenges and again opportunities in the prevention and management of cancer. But first of all, tell people what cancer is in the simplest way so that people can understand that. Brief intro, then what is cancer, then challenges and opportunities for innovators. Thank you.
Thank you very much, Professor Kawachenga. I'm Dr. Barnabas Atwine. I am a pediatrician and a pediatric, basically a childhood cancer and blood specialist. I teach in the University of Science and Technology and also treat patients mainly patients with cancer and blood diseases in the hospital. And I also have the honor and the responsibility of heading the cancer services of the hospital. Again, like Professor has said, one of the reasons I couldn't come in time is because I just wanted to overcome the challenge of managing NCDs before coming here. Because, yes, and as I said, being a weekend, coming to a weekend, and then the rain and everything, we had a ward, but also have a sickle cell disease clinic. And so I just needed to be sure that things are moving before coming. But my apologies, really my very, very sincere apologies for coming late, but I'm glad I came right in time. Professor Kawachenga has asked me to talk about what cancer is. Cancer is a disease that results from what I would call an accident in the body. As the body is doing its usual things, its usual processes, really the usual normal processes that happen in the body. it actually makes a mistake, and instead of making itself, I don't know how many of you remember cell division, but usually every cell, at the end of the day, all our bodies are reduced to cells. And cells are like bricks, like this building, or at the end of the day, this building is reduced to a pile of blocks or bricks, for that matter. And these bricks are the ones that make this building. So also our bodies are formed of very, very small bricks called cells. And the body is made in such a way that every cell multiplies, divides into two, and makes another cell. Like that, like that, like that, like that. There's a whole process that takes place. But sometimes there's a mistake, an error. So that instead of making a cell that looks like itself, it makes a cell that's fundamentally different in the way it should function. Just imagine if someone made an error on the plan of this building. Just made an error and made a line that came here. So this pillar would be reaching here. Just on the plan, if someone made an error in the plan of this building. So the whole building will grow up, will be built with that error. And that's what exactly happens in cancer. There's an error in the fundamental structure of the cell of the body. And the cell develops into a cancer cell that looks so different and behaves so differently from all the other normal cells. And one of the things about these cells is that they kind of like keep growing without the control of the rest of the body. The reason you keep in the normal shape of your body, is because everything that happens in your body is under very, very, very strict control. But these cells are able to work and live and do their own things without the control of the rest of the body. And that's why generally most of the cancers present with a lump or a swelling or a lump, a swelling on the body. It's because those cells are growing in a different direction from what you're supposed to, for your structure, really. I treat cancer in children mainly, and really there's nothing. Most cancers in children are what they call sporadic. They just come. Any child can get cancer at any time without any risk, without any warning. Most cancers in adults have risk factors, and risk factors are not the same as causes. Really, risk factors, it's just that your chance of the person's chance of getting cancer increases in specific conditions. But even people without those conditions can actually get cancer. And some people with those conditions don't get cancer. You all know that some people have smoked all their lives and they're now 100 years and no one has ever gotten lung cancer. And you've heard of young people, 20-year-olds that have never smoked and have lung cancer. Really, that is kind of like, it can happen to anyone, but it more likely happens in a certain population than others. Every vehicle can get an accident on the road, every vehicle, but there are more vehicles that have more risk of getting an accident than others. You know, old vehicles driven not very fast, driven by inexperienced drivers will be more likely to get an accident, but any vehicle can actually get an accident. I think that's really what I would, whatever. Yes, so we are so privileged to have support from the hospital and Uganda Cancer Institute to establish a cancer, and the university, Mbara University of Science and Technology, and Uganda Cancer Institute, and the Mbara Regional Referral Hospital, and also Massachusetts General Hospital via Global Health Collaborative to establish cancer services in the hospital that are comprehensive and that actually treat almost all cancers, all the range of cancers. And we have services that are available that are free. And so we are really privileged to do that, and we're happy to provide that service. So challenges and opportunities of effective prevention and managing of NCDs. I think I'm just going to paint a picture on what is really happening with NCDs in Uganda, and especially cancers. I think the problem is that we are still, as a nation, coming from a culture or a situation where we're used to only infectious diseases. And you know, when we've been able to overcome measles and and polio and things like that. And then HIV came, and all the resources and all the intention went to HIV. And unfortunately, NCDs kept increasing like an underbelly, really. And so the moment we removed HIV, then all of a sudden, the NCDs actually exposed themselves. And all of a sudden realized that people are actually dying of cancer at high rates. And of course, a lot of people who died and we thought they were dying of infectious disease actually had cancer. Really actually had cancer. Dr. Joseph Ngonzi remembers that when we were doing ward rounds many years ago, we never had a diagnosis of cancer. And everyone who comes with fever, we thought it was malaria, that kind of thing. But now we know that a lot of those people actually had leukemias and had so many other things that we do not really treat. That is one. And so the system, honestly, I think for me, the problem that the system is not yet used to managing NCDs. And managing NCDs is not the same as managing acute febrile illnesses. Because all you need for acute febrile illnesses are huge wards where people come very sick, they come, you treat them, they become well, and you send them home. You don't want to see them again. Cure someone of malaria, you've cured them, and you've solved their problem, and you send them home, and you're finished with them, honestly speaking. Now, NCDs present another problem that requires resources for early detection, early diagnosis, and secondary prevention, and follow-up, and reminding, and putting systems for reminding people, putting systems for long-term management, long-term management of conditions that keep changing now and again. I think I'll just draw what we do, for example, with a sickle cell clinic and also the cancer unit. We actually have to call patients to remind them that their clinic is due. And when they don't come, we actually have to call them again and find out why they didn't come. We have to sometimes visit and call the LC chairpersons to remind them, to call them and remind them. And also the society is not used, community is not yet used to people who look well, and then they have to come to hospital. So if the child came with a swelling on the face, we gave the first cycle of chemotherapy, and the swelling has disappeared completely, totally, completely. There's no more swelling, but the child still has cancer and still needs to finish 6 cycles of cancer chemotherapy. So the father is wondering, why? Why should I actually bring the child who looks so well when I have so many problems? You have school fees, you have food, you have whatever, all the things. And then this child actually does not have pain, has no complaint, does not have any problem. Why should I actually bring them to hospital? So I think that's really, there's still a problem with that communication of knowing that seeking care for a child is well. And to be honest with you, even the system itself is not yet attuned time. Yes, one last thing. The system is not yet attuned. So that's why on the hospital, for example, you have huge wards, but hardly any clinic, any outpatient clinic space. You get stuck seeing a patient in privacy in a clinic, but you have huge wards that are there for admitting patients who are very, very sick. So I think, to be honest with you, that's really, really part of the challenge. The challenge is we still have a system that is not yet attuned to continuous care, secondary prevention, continuous care of patients. And I think for me, that's where the opportunity lies in us changing our system to be able to provide services and conditions that patients will run to, patients will come to, even when they are well and they're coming to really come back. The system that keeps reminding them, providing them support, providing them support, both financial and psychotherapy and emotional, they can actually keep coming to the same system that is functional. I think I can just leave there. I'll leave it that for now.
Thank you, Barnabas. With cancer, maybe you can give you maybe 2-3 days because there is so much that really that can be covered. I've been warned by the timekeeper that time is up a bit, but maybe Andrew, you can talk about diabetes challenges as far as where do you see the innovators coming in? Diabetes is a major in 2 minutes.
Yes, so thank you so much. Diabetes, as I told you, is a growing disease, and there's a lot of opportunity for innovation, starting from screening, looking for better ways of identifying people early. Also in terms of, unfortunately, with diabetes, is that we have not much medication for our patients. It's not free. Okay, most of the communicable disease things are free, but for diabetes, they are not free. And we are looking for people to innovate. We would want a Ugandan innovated insulin molecule. And I believe that it's possible. It's possible that we can do that. Pharmaceutical experts in this place, you could start thinking, because all the insulin we have is actually imported. If one day they say we don't want to import insulin to Uganda, our people will die. Yeah, so I am tickling you. We also still have opportunities in terms of medication delivery systems. You know, people are still struggling on how to inject themselves. We could invent smart ways of injecting themselves insulin, smart ways of reminding them to take their medicines. And these are beautiful things that we could actually do. I want to agree with those people that have said we are a low resource setting, but we are not a low knowledge setting. I just want to repeat this. We are a low resource setting, but we are not low knowledge setting. And I believe knowledge always prevails. I am open for more talks on diabetes, even in the breaks. Thank you so much, Professor, for this opportunity.
Yeah, what we have received is a snapshot, but I've been informed that the audience may have some burning questions. Another microphone. If there are any issues you want to put forward to the panelists, this is the time. Yes.
Thank you. Please allow me stand. I am Dr. Septin De Peter, and the latest physician really is talking a lot of sense, and we want to applaud you for that. Aging is a way entire process, and we all go through it, and we are all aging, and we will get there. But there is a rich man called Richard Branson who put $1 billion challenge to innovators and scientists that whoever will discover an anti-aging agent, he is willing to pay. Look him up, you'll find that man is very rich, and he's fighting with the age. and sometimes when I think about aging, I pray silent prayer that you slow the process, Lord, if you can. But as innovators, in the context of Uganda, in the context of Africa, what is it that can help our aging population? I want to agree with you that the population of aging people in Uganda is increasing. In 2010, we were at 6.1%. 2016, we came to 2.2, and now we're at 2.8. Dr. Twine, you have said it is the system that is unable to detect the NCDs. But I tell you, the system are people. We are the system. And I think we can now begin to make the system responsive. What is it that we are doing for the aging population? You're engaging, the physician is not listening. What is it that we are going to do for this aging population? What is it that we can do with them? You rightly said that they are very rich in knowledge. The people in this house, in this room now, we are all aging, but we are very rich in knowledge. What is it that we can do with you, the young physicians and the young providers? Dr. Santorin has just gone out briefly. What is it that we can do with them and for them to improve their well-being. I think we need to think around that in terms of innovation. Professor Ngonzi, in your presentation, I kept thinking and I was thinking with you, you raised very pertinent issues. Every day I work with health workers and we collect a lot of data. Some of it we write on papers and the papers fly. The papers are beaten with the rain. These papers grow old. 10 years down the road, you cannot find them. People have come up. There's a forest of innovators who are thinking, how do we go EHMIS? How do we run away from paper and begin to use systems to capture and store this data? But there's a desert of people who are thinking safety. We are talking about the safety of the data collected. Many regional referral hospitals have electronic medical record systems, but I want to ask them, and as I ask you, how safe is this data? Safe from cyber problems, you know, now I'm getting vulnerable, this is not my area. But you know that data can be stolen, to be simple in the language. How is our data being safe? How do we transform the mindset of health workers to get used to a laptop? How do we keep the data safe? Innovation. Let's come to that. That arena is virgin, and we need innovative things, innovative ways of capturing, storing, and archiving our information on a day-to-day basis.
Thank you so much, Dr. Sebutinde, for the brilliant comments and questions and intriguing our minds. As far as I have come to learn, that health begins when you are not yet born. And I want to tackle your question on how to keep people healthy as they age. Some of the things I did not tackle, but we cannot stop people from aging, but we can actually slow the aging process. There is actually a lot of evidence that the aging process can be slowed. Okay? And I will just talk about one point, and it should, those who want to go read can go read about it. Africa is very rich as far as nutrition is concerned. We have a lot of food here, okay? Even people come to Africa to eat, okay? But unfortunately, we have not, and I believe we have all this knowledge, you know, we have not harnessed better ways of actually processing our foods to keep us healthy. Okay? I want to talk about gut, I want to talk about cardiovascular health, but I will start with the gut. For those that know, something that is actually growing in the Western world is gut health. That gut health can affect mood, can affect the heart, and they have started even crazy but beautiful things. They have started doing something called fecal transplants. They are getting fecal matter from people in the Amazon that have never taken antibiotics, that have never eaten chapati and chips, deep down, and then transplanting this fecal matter into the American people to give them very good gut health. And it has been something called the microbiome research, and it has been shown to slow aging, the aging process. You know, and so when I talk about these things, as I read them, I know we have nutritionists here. They can teach us better ways of storing our foods, for example. You know, making sure that it does not grow mold and aflatoxins that will actually cause us cancer and kill us before we enjoy our great-grandchildren. So the keeping people healthy as they age is a collective effort. It begins when we are children, avoiding and there's a big problem, and you are the DHO. We have seen a lot of antibiotics prescribed to young kids, even when they have simple ailments. And all these things kill their microbiome, and then it causes them cardiovascular disease later in life. So some of these things really need to be tackled collectively. Thank you.
Thank you. He's still around, so we can continue the discussions. Now, some 2 questions, briefly, and we move to the next.
Thank you so much, the panelists. Mine goes to Dr. Barnabas, and also to request the innovators. One of the things we've realized is that most of the vegetables on the market is full of pesticides, and this has been associated to causing cancers. I wish the innovators could come up with something that when I buy my vegetables, I'm able to detect what dangerous pesticides are there in these vegetables and fruits. For sure, you would have saved us, and we are going to live longer. And on the issue of aging, I'm looking for the innovator who will give us some masking new faces.
Hello, thank you. My name is Nkutu Sudais Faizo. Personally, I'm not majoring or studying in the medical field, but I have been doing research on products like industrial hemp, which is locally known as marijuana. Well, yes. Well, this product, personally, being in the engineering field, I have figured out that this product can be used to make things like bioplastics, biofuels. But then there is some new research, like based on the literature I have been having, showing that this hemp is having products like derivatives like CBD and THC. This CBD has shown potential clinical studies in managing diabetes, potential studies in managing cancer, and the CBD, like based on the research, it is also showing that it has anti-aging properties due to its anti-inflammatory and antioxidant effects. So personally, I'm not requesting for, I'm not asking a question, but I'm kindly requesting for your collaboration, so we can have the hemp planted on the university ground in Chihomoro, because we are having vast land there which can be used for further research. Thank you. I beg to submit.
No, thank you very much. Yes, I agree with you. I think a lot of the chemicals that are used to preserve, to fight pesticides, honestly are carcinogenic, and meaning that they actually catalyze the reaction of making the cancer process, really. And that's a very, very big problem. And I think it's an attempt at maximizing profits and minimizing, basically the whole capitalism thing, where the most important thing is profit and not the other round. Yes, I agree with you that an innovation that would actually either detect or formulate pesticides that are not carcinogenic, or in a way that can be made in a way that are less carcinogenic, would also be very useful. The other innovations that are meant to detect cancer early and other NCDs would really actually go a long way. The ones that would diagnose without, now it takes about 2-3 weeks to get the cancer diagnosis. If we can get technologies that would make diagnosis faster. Safe delivery of chemotherapy. Some patients actually during the time of chemotherapy actually is extremely dangerous. So innovations that would actually ensure safe delivery of chemotherapy. Innovations that would teach health workers en masse This whole thing of bringing health workers in one place to teach them about cancer is extremely expensive and not working. But if there's a way we can actually teach health workers about cancer, detecting cancer or suspecting cancer en masse without them coming, technology that would help in following up patients, reminding them of their appointments and also making sure that they are taking their medicine at home, those technologies also would help. And the other thing is Dr. DHO was thinking about, Dr. Sevtinde, medical records. Yeah, medical records. Technologies that would actually make it easy for us to be able to capture medical records in electronic ways and retrieve them so easily and review them and communicate between health workers so easily in that way. So I think those are the things I can add on the technologies. Thank you.
Thank you for those questions. Time up. We have even gone beyond, but his hand is stuck up. So what do I do?
I know Ngatu is very short and precise. A second.
Thank you very much. Good morning, colleagues. My name is Ngatu John Mary. I'm honored to be here today. To our panelists, 2 issues.
One.
There is what we call the One Health agenda.
Yes.
I'm very sure we have all heard about it.
Mm-hmm.
And we've realized that because of antimicrobial resistance, you have a patient with septicemia, but the same patient is battling diabetes, cancer, hypertension, to mention but a few. The other thing is when you go to our markets now, you see very nice things, very nice looking cabbages, very nice looking tomatoes. But I have bad news for you. Most of these are GMOs, genetically modified organisms. And it is alleged, or we need to confirm, that they are actually contributing to issues of nutrition, issues of obesity, issues of NCDs. So as innovators, we have some thinking to do together. Thank you so much.
Thank you. But you have scared us that the tomatoes, what? Shouldn't we go now for break tea? No, really? Mm-hmm. This is scaring. But I would like to thank the panelists and for you, the audience, for this session. Time is not on our side. Maybe you ask Dean Ngonzi, we need a whole conference on these NCDs because it appears there is a lot that we can share. Yeah, that marks the end of this session. Over to you, the timekeeper.
Thank you so much. Thank you so much. Let's give another hand clap to Professor Jerome. Yes, and to our panelists, thank you for casting the gaps, where the gaps are for our innovators. Thank you so much. Aging is a good thing, but we must slow it. And we must give it a good mask. Yeah, thank you so much. You know, it makes science look so palatable. When you think about innovations, we know that there are things that are hard, but again, we want to go through them conveniently. So thank you so much, the NCD panel. We will request, our time is fast spent, we request them to take their seats, and it's time for break. We have 15 minutes to do our break. We have 2 serving centers, so I request that we'll use that time profitably. But just before we make it for our break, I want to recognize the NITA team all the way from Kampala. Let's give a hand clap to them. And yes, Mr. Newman, who is heading the team, thank you so much, and we hope we are going to have you for the entire 3 days. Special recognition to Assistant Inspector of Police, Christine, who is also the OC Traffic. Thank you so much. I hope we'll have you because some of the innovations may be how to prevent or fasten crime detection. Okay? So thank you so much. Yes, as we go for a break, I request for a group photo. We stay here, downstairs, after the break or just before now? Now, okay. Let's go downstairs. We take a group photo as the clinical summit for the 9th hackathon. Yes, you'll be in the history books of innovation at Mbara University. So kindly take the steps and let's use this time very profitably. Thank you so much. And make sure that you come back after break. We have 2 panels to go. And then we'll have a few remarks. Thank you.
The Medtech Hackathon is here. This is 2023, and we are here at Silverback Hotel to have great minds speaking their own innovations, speaking their own ideologies, speaking their own solutions to the healthcare challenges that we are having. This is the Camtech Uganda Medtech Hackathon 2023, and it is the annual. This has been annually. It has been hosted annually, and we say that this is the 9th Camtech Uganda Medtech Hackathon. Yes, we are looking at global health challenges. Generally, this is focusing on 4 main areas, and these are the health challenges that I really want to bring to you. We are looking at the non-communicable diseases. We are looking at mental health. We are looking at issues to do with road accidents. We are looking at issues to do with the non-communicable diseases, the pandemics and endemics. These are just problems that have been there. But then today we want to find alternative solutions. Yes, it has been there and it has been affecting our health. It has been affecting our people. Many people are facing mental health issues because we see that in Uganda, actually, according to the Uganda Counseling Association, we see that together with Ministry of Health, we see that there are 14 million people in Uganda facing the challenge. That is the mental health challenges. But then how can we find a solution to this? We have very many issues in the maternal health care system as well. We have heard that the maternal mortality rate has decreased at least a little bit from the 336 deaths per 100,000 live births to 284 deaths per 100,000 live births. That is a great move. But then we still need more innovations to how can we decrease this. Something interesting that I learned today. People were talking about the aging. How can we get an aging, innovative idea? Yes, they still want to keep with their beautiful faces looking young. They do not want to age and age and age. So how can we find these solutions? All this is there just today in this summit. Talking about Camtech, this is a consortium for affordable medical technologies. We are talking about an entrepreneurial society that is going to find solutions. These are the solutions to the medical field, to the medical world. How can we be innovative to create these new ideologies that are going to change the healthcare system? The healthcare system is broad, and here we are looking at a very big ecosystem, a very big healthcare ecosystem with very many parts, with very many functions. We are looking at the government, we are looking at the NGOs, we are looking at the pharmaceuticals, we are looking at the service providers, we are looking at the innovators, the people in academia. We are looking at a very broad aspect of life. And here all come together as a multidisciplinary to find a clear solution to the challenge in your area. What is the challenge in your area? Maybe you could let us know, because I know that you are watching us at AET TV. Yeah, you are watching us, and you are watching us maybe from Facebook or YouTube. Just get onto our pages and tell us which challenges in your area that you would love to be addressed. And as you know, that always, as usual, we find challenges. We present challenges, especially after this clinical summit. In this clinical summit, we are having people or innovators being enlightened about the whole project, and that will be taking 3 days, and we shall have people having problems, sorry, in their areas. They will bring problems and not solutions at the moment. It is now about problems. What is the problem in your area? So you could also just inform us what is that problem in your area, so that by the end of these we could find a solution that will be addressed through technology, that will be addressed using technology, because people are here. Yes, they will later form teams, especially the participants. They will form teams, they will team up, and they will be able to address the challenge and also finally present the solution. Yes, who is not waiting to see the person who will take the award home? I am eagerly waiting. My name is Bridget Cimenta, here until the 30th of October to bring to you live this event with my team, AED TV.
the Vice Chancellor for Ngozi University in Burundi is here with us, Professor Reverend Father Apollonia Banganyibanga. Let's give a hand clap as well. You're most welcome. I hope the name I've been able to. You're most welcome, Prof, all the way from Burundi. And you're seated next to the embassy counselor, our embassy in Burundi. Thank you so much. And Camtech, we are grateful for those partnerships. We never thought that we would rub shoulders with diplomatic missions. Okay? It means our innovations can easily go beyond the borders. Okay, so that's a very good, it's a very good encouragement for our upcoming innovators. So you're most welcome, Prof. So we have 2 panels remaining, and the immediate panel is moderated by Associate Professor Edgar Mulogo, who is a senior lecturer in the Department of Community Health. Barra University is also the co-PI for First Mile, and he has done a lot of community health researches. He has been part of the innovations and also the users of the innovations from Camtech. So I'll take this opportunity to invite the panel to take their seats, and then we'll get back. We have, immediately after this, there will be a Q&A and another panel just before our lunch. So we can redeem the time. Thank you so much.
So thank you, Peter. I would like to welcome everybody to the session that we are going to have at this time. It is panel number 2, and if you look at your schedule, the panel is going to deal with pandemics and epidemics, what we have learned, what has changed, and what can be done better. So I would like to welcome you all. In my remarks in the morning, I said that we need to listen intently, because these panelists, like those from the morning, are experts in this field, and I will introduce them shortly, and then I'll allow them to say something about themselves. So I am Associate Professor Edgar Mulogo from the Department of Community Health. I'm a public health specialist with a passion for health systems. So together with me are the panelists who are my colleagues. I'll start at the far left. We have Valence Nyozima, who is from the Department of Nursing. He's a lecturer in the Department of Nursing, and he's been involved in care, in ICUs, in the Mid-Regional Referral Hospital. On my immediate left, I have Dr. Peter Sebutinde, the District Health Officer of Mbarali District Local Government. Dr. Peter Sebutinde will say a bit about himself. But on my right, I also have his namesake, Dr. Peter Kawungezi, who is with us in the Department of Community Health, but also he's at the moment attached to a field epidemiology program at the Ministry of Health. These panelists that we have the opportunity to interact with this morning are people who have been involved in epidemics and pandemics at the front line, okay? Not seated in offices, but at the front line. So it is a great opportunity to have you panelists. You are welcome, and would like to engage you on some of these things that we have seen and lessons we've learned, we realize for all of you that it is now just slightly over 3 years when we first had COVID, the third anniversary. COVID, of course, had different impacts on people differently. There are some people it left in a lot of pain. There are some people in the business world who saw it as an opportunity and it changed their business. Others, for those who are in academia, maybe some of you who are students here, probably you lost a couple of years. So these are things we don't want to see again. We need to be better prepared. And who is in the best position to ensure that we are better prepared than the innovators? That we can get early warnings, we can get solutions to some of these things that really bogged us down during the pandemics. But really to give you an indication of how serious these pandemics can be, I will just highlight for you the 5 top pandemics that we have had in the world, because some of you may think COVID was the first big thing and probably imagine that we will not see anything else like that in the near future. But we are likely, it is a possibility, there is potential to have something like that again. Because these pandemics, for example, there was a pandemic of a plague in the year 500 AD. Can you believe it? Okay, 500 AD, a pandemic. And it really had a lot of mortality associated with it. We had another pandemic, again of plague, bubonic plague. Okay, and this was more severe. Actually, it's ranked first because a number of people died as a result of this pandemic. Then we had the Spanish flu, okay, which was a type of a pandemic from influenza. And it was pretty surprising when I saw people, when we started putting on masks because of the COVID of 2020, we imagined that we were seeing masks for the first time. But the people of the Spanish flu that happened, I think in 18-something, were actually putting on masks. They had cloth masks, okay? So the innovators here, because we have moved centuries on, if we can get a digital mask, I don't know what it will look like. But yeah, so then we've had also the HIV pandemic. It's also caused a lot of issues, and of course, we've had COVID. So these pandemics, ladies and gentlemen, are around us. Experience is the best teacher. If we don't learn from that, then we probably will face very difficult circumstances. And you all know that the COVID pandemic started in China. I mean, that is all the information we have, and people have linked it with bats. But surprisingly enough, I was reading a news article in BBC, and there was this truck in China. There was a truck based on some information that was stopped by the police because they got some kind of information. And do you know what was in this truck? There were 1,000 cats. These cats, you know, like domestic cats, which were being transported to South China to be processed into meat, 2 different types of meat, and it wasn't to be cat meat. But you can see that people are still engaging in some of these things that risk us getting infections that we probably can't explain quite clearly. So with that context, I am now going to move over to the panelists. I will ask them to say something about themselves, and then we will move into the discussion. Thank you.
Thank you, Professor. As already introduced, I'm Valence Nyonzima from the Department of Nursing. I'm mainly involved in critical care, and it is an important opportunity for me to share some lessons learned and what we need to do as a nation so that we are better prepared to handle these pandemics. Thank you.
Yeah, thank you very much. I am Dr. Sebutin Peter, like I was introduced. I oversee health service delivery in Barara district. And like Professor pointed out rightly so, when you look for me in an office, you will not find me there. For example, people who are looking for me now at the office, they are waiting. But when we go to the field, you'll find me there. And in there, we learn and do so many things, as we'll be sharing in the next few minutes.
Yes, thank you, Professor Edgar. Maybe for those who just came in, I'm Peter Kaunges. I'm a field epidemiologist with a clinical background. And I don't want to add so much, but I want to say that I have had an opportunity to participate in the national rapid response to support the investigation and attain control of the most recent pandemic and epidemics that we have dealt with. The most vivid one is the recent Ebola outbreak, which we had focused in Mubende, Kasanda, then later spread to a total of 9 districts. So I'm also here to share with you on yet another platform because I've worked with you on other kind of fora in the community. But now here I want to translate our experiences down there in the community to see how we can get our own solutions to our own problems for the better future. Thank you.
So thank you, Dr. Peter. Maybe let's start there. So we, as panelists, we can start our discussion with a general overview of the recent pandemics that we've had within our Ugandan context, okay? And so that we, as participants here, can get an understanding of the risks that we are facing. I know, Dr. Peter, you've been part of a response to EVD, and you could really share with us a little. And also, Dr. Peter, you've been part of the COVID response and Rift Valley fever in this area. Thank you.
Thank you, Prof. I will start with re-echoing this. It's commonly said by most of the people in the community that it's not my responsibility, it's their responsibility. Now, that is the mindset that we need to change in this discussion and as we come up with innovations. Uganda is prone to outbreaks. This I can't explain any better because all of us here have been culprits in a way. I remember my psychiatry teacher when he told us that when you have a brain, you are a psychiatry candidate anytime. So when you have a body, you are a candidate of these epidemics we are talking about. You are not any exception. After the COVID, several lessons were learned and several actions were taken. COVID really checked our systems and checked ourselves. We learned a lot, but we are forgetting very fast. COVID showed us that at any time, the normal business can come to a standstill with very enormous impact. At the national level, several interventions were done, including decentralizing some of the response structures. We have the Public Health Emergency Operations Center, which is hosted at the Ministry of Health. It really helps in detecting and coordinating the response. This has been now decentralized to several regions. We had the One Health that was, I think, in its really junior stages, but COVID again strengthened it. We have realized that One Health is actually an approach that we need to strengthen, and we all have to know what our role is. COVID has also showed us that it does not only depend on the health kind of care that you receive, but we also have other and yet very important activities that we need to do at the community level. Checking our social life at individual level, at community level, because when these epidemics happen and pandemics, the life does not stop at that point. Life continues moving. I remember people were hurt, being stopped from going to church. All of a sudden, children have to come back home. Your trade cannot continue anymore. So it really shows that things have to continue moving. So it is important that we don't only look at the clinical bit of it, because clinical bit of it is treatment. But much of the work has to be prevention, which is in the community. If I borrow from the illustration of Professor Kazova, if you are given 6 hours to cut down a tree, spend 4 hours sharpening the axe, and 2 hours cutting the tree. In this case, we have to spend a lot, whether money, whether innovations, we have to spend them at the level of prevention. We shouldn't get this in the first case. Or if we get it, now let's look at the detection. How fast are we able to pick up this? When we detect, how fast are we able to report? When we report, how fast are we able to respond? All of those lessons were clearly learned from COVID. But after COVID, we have again continued experiencing our outbreaks because we are prone to them. We know about, okay, we may have heard about anthrax. I don't want to generalize. But this is a problem that we have stayed with, especially those who stay in the cattle corridor. But people lose their cattle on the farm and they will not report. Why? They think, for me, I'm okay, and that is it all. They don't know that when the neighbor is affected, they are also affected. So we have to have that collective kind of response. So we've had these outbreaks. We've had in Kazo, we've had in Chiruhura, we have had in Ibanda, Nimbarara, and then we also have this ongoing Rift Valley fever outbreak. The same thing. We have these problems in the communities, we are living with them, but we don't report. When Dr. Sebutine mobilizes a team, or when a team comes from the national level, try to give us guidance, give us approaches we can use, we just ignore. We prioritize other things, we forget what is going to affect us. Like Dr. Barnabas said, if I am well, then I'm not concerned. But we define that wellness, I think, at a very superficial level. We need to go deep. Don't look at the physical health only. Look at the social bit of it, look at the mental health bit of it, and that will really enable us to collectively respond and prevent these outbreaks. I think the details we shall keep sharing as the discussion goes on. I have a few areas that I will highlight later where we can focus. Thank you.
Okay, thank you, Dr. Peter. Maybe we'll start at my far left.
Okay, thank you, Professor. So in addition to the contributions from Dr. Peter, one of the things we learned from the recent pandemics is that preparedness and resilience of a healthcare system is the key if we as a nation must respond to a pandemic or an epidemic appropriately. And so if we have challenges as far as preparedness and resilience of the healthcare system is concerned, then our response will not be appropriate. Secondly, is that from the recent COVID-19 pandemic, we were able to witness that the public health measures such as testing, contact tracing, isolation, quarantine, vaccination, among others, were very key in containing this epidemic. However, important to notice that the public perception towards some of these measures was negative. You will bear me witness, for example, what the public could perceive if the response team went up to the village to pick a victim. Their perception was sometimes negative. In some villages, they ended up hiding some of these contacts. And so, as innovators, is there a better way we can actually do contact tracing rather than going to these villages physically, so that maybe some villages end up hiding some of these contacts? Then what we also realized was that these pandemics have enormous mental health challenges. And so as we prepare to handle these pandemics, it is also important to make appropriate mental health considerations so that these people affected differently by the pandemic can be supported in various ways. And so in these epidemics, you'd realize people have mental health challenges, but they have no one to attend to them. So the attention was, how do we control COVID? But actually, the effects of COVID were not considered. And lastly, is that there are social and economic impacts of COVID. And like Dr. Kaunges mentioned, we saw businesses closing down. People were no longer able to go about their daily routines, and so their sources of income were affected. And eventually, these have an impact on health. All of us are aware that there are social determinants of health, and so if people are poor, then there are things they are not going to afford. So is there a mechanism you can put in place so that people can still continue generating some income amidst these pandemics, so that they can be able to support their own health? A case in point is some of the musicians whom we thought were doing well financially when they came out during the COVID pandemic soliciting for assistance. So that means that each of us can be affected negatively, and so we need to think of innovative ways of supporting income generating projects, even amidst these pandemics. I think that is what I can highlight for now.
Yeah, thank you. Thank you, Prof. Ladies and gentlemen, there are so many things that we have learned, particularly from COVID. In December 2019, I was privileged to be one of the DHOs who was called to go and participate in the planning and budgeting. You know, you budget and make a response plan. At the time, we were anticipating that, oh, you know, COVID is there and it is coming, but how would we prepare? And so they called us up and we went and sat in a good hotel. And man, we were thinking we will need this amount of money, we'll do this, we'll do the other. And so I came up with a district-specific budget, 550 million. I submitted, and I waited. And before we knew it, the first case of COVID came. And I was like, yeah, now it has come. And from the 550 million, when I got the first case of COVID, I got 120. The mathematicians in the house, you can calculate. And so we always have these expectations as managers, as people, but we do not quickly think about the resource envelope that we have. Now, that was for Mbarara district specifically, but it was also true for the country. If it were not for our president, who called people, individuals, called companies, called groups of people, and said, people, we are at a crossroad. As a country, we need money, and we don't have this money. And I like that man. He's always, he's always honest with himself. Said, we don't have money. If you have money, bring it up. And so he rallied people and he brought resources. So one of the things that we have learned is that we must think as a country and as a people about the resources to respond to these pandemics, because it takes money. It takes people. I saw the president put together a task force to respond, and he included all the people, including the army men. Everybody in a pandemic, in an outbreak, is important, and they make a contribution. So when we did the response plans, what did we learn? As innovators, we need to think and aggressively think about the following as we think about our innovations. One, that coordination and communication of these pandemics, yes, but outbreaks is important. People understand the situations differently. People in this house, if I'm going to explain H1N1 as a pandemic and as an outbreak, I'll use fewer words because you know. When I am talking to a crowd of border riders or people in the village, it will take me time to explain. So as a people, as scientists, as innovators, we need to think about the communication of the risk so that we improve the risk perception of our people. Phase one or round one of COVID-19, people were panicking. People were fearful. Round one came, round two, third round, it was common business. We all know it's okay. We have not died. We shall make it. What do you have to say about COVID that I don't know? So risk perception and risk communication is very important. Surveillance and diagnostics. We got a breakthrough as a country when we started to be able to test. Those who were in the fields know that it was difficult. At first, we were sending samples to UVRI, and then you wait. Now, the breakthrough came with the rapid COVID, RDTs, rapid diagnostic tests for COVID-19. And thankfully, this test was a brainchild of a Ugandan in Makerere in Uganda here. And WHO was there. You know, it has to be validated, it has to be approved. And our president, I love that man. He quickly went to them and said, you people, this thing can help us. What is it that you have to validate again? We want to use it. And I think he quickly pushed them. They validated the thing within 1 month. For the very first time. Professor, you know these validation things take months and years sometimes. But it took 1 month. WHO validated the test kit and we started testing. It went in the region, not only Uganda. And that was a breakthrough. So as we think of innovations, the thing that we need to do, let us think about surveillance, let us think about case management, risk communication, I've already said it, but risk communication and community engagement helps to bring the community on board. These pandemics do not happen in hospitals. They happen at household level. They happen in the marketplace. They happen in the field. So we need to think of something that will accurately communicate the risk. You remember with the WhatsApp, everybody became an expert of COVID-19. And they were treating COVID-19 on WhatsApp. This doctor said this, you give chloroquine, you give quinine, you give the other. And everybody was an expert. But what did we do? We said we are going to stay calm. We are not going to start a battle in the media. But we are going to stay calm and go to the people and explain the science. So risk communication and community engagement is key. We need to find an app, something that we can easily communicate this. Infection prevention and control. My, in these hospitals, in these facilities, it was disaster. You know, we lost very many health workers. We lost DHOs. We lost nurses and midwives. Why? Because of the infection prevention and control measures. They were not adhering to them. Can we have something that can help us to improve this IPC at the facility levels, in the theaters, in all these places where we see portals of entry for infection, that can easily trigger thinking and change the way people think about this infection prevention and control. The last thing that we need to think about is research. Second last, actually. Out of the pandemic and the response plans that were drawn, now, teams like the Kaunge's teams. Kaunge's is a product of that research aspect that came as a result of COVID-19. We discovered at the moment that we did not have good epidemiologists who understood exactly what to do. It is one thing to be a doctor. It is another thing for you to understand exactly what to do when it is required. And that's when we needed epidemiologists. And we said, you know, we are going to have them now go back to school. Once they are out of school, then they come and translate the knowledge into practice in terms of epidemiology and outbreak control and management. So research picked, and now we are reaping. The last thing is more a social, we have social scientists in here, but it is called the pre-deployment briefs on prevention of sexual exploitation and abuse. When you deploy a team, you equip them, you give them information, you give them even money. Yes, even money. And now that money in their pockets can become a problem. That they go in a place and in the dark hours of the day, during the day they are epidemiologists. In the night, they do another different kind of epidemiology. Now, before you deploy these teams, you sit with them. Tell them what is at stake. There's HIV, there are these pregnancies, there are all these things. Please take caution. And it is important. We discovered that many teams that did not have these briefs had problems. In the recent outbreak of Ebola in Mubende, it happened. It happened, and we had to come up very fast. We had to change teams. That for you now, this team, you cannot continue. Let's take you to another place. Or, take a Katebe. That one for Reverend not to know. So these things are important that for us, we think about them. The other thing that we need to know about these outbreaks, the effect of you communicating an outbreak to the community and their livelihood. We recently had Rift Valley fever. in the district. And you know, Rift Valley fever is a zoonotic thing. Before I got to know, many farms had been affected. Now, these are huge farms of huge men and women. When I say huge, you know what I mean. And now I was fighting Rift Valley fever in the population among human beings, but it was coming from animals on big farms of big men. And I had to go and confront them and tell them, you people, this thing is coming from here. This person who is sick worked here and did the following. There's a problem. And one of them told me, you man, every morning I milk up to 2,000 liters. Do you know how much each liter is? I said, I have a rough idea. No, you don't. So the man told me, 2,500 shillings times 2,000. How much money is that? And that money is for every day. How much do you earn? I looked down. And now, this is a person I am supposed to tell that, look here, this milk is what? Is not fit for consumption. But he has already calculated for me and is looking at the profit margin. And I have to convince him to do otherwise. It is an uphill task. That when one of them lost a huge heifer, about 350 kilos, and he instructed his workers to go and bury it. They dilly-dallied, and towards 5:30, they carried it away off the farm. And these boys did not bury the animal. And they went and slaughtered this animal. And all those who slaughtered, unfortunately, the head boy of the slaughterers, head boy in quotes, the head boy died. All the team members became sick. But that comes from the farm. So that effect must be figured into what we're discussing in this house. That is not just about the science, but the end users of the science we're talking about, and the effect of this science onto their livelihood. So these are things that we must consider and we think about aggressively. The last bit that I need to, we all remember, if we can remember Ebola. Uganda is now a country that is familiar with outbreaks of Ebola. We have had 6 outbreaks in the last maybe 10 years. So the recent one, people died. And when you communicate death, dying causes people to respond quickly. It somehow touches our minds to think that if so-and-so has died, maybe next it will be me. But that fear that we create in the public, in them, causes them now to retract and run away and hide. And it is very difficult for us to deal with a community that is in fear and in hiding. How do we deal with that? How do we now best communicate even the worst news? Those are areas that we must improve. Can we have a better behavioral scientist who will come up with a mode of some mode of communicating this bad news? How do we handle, how do we deal with the community? Finally, yes, what are the challenges? How do we deal with them? There are delays, always delays, in the detection and the reporting of these outbreaks. The Mubende Ebola that my colleague alluded to took up to 42 days before R1 was identified and reported. Now, 42 days of an outbreak of that nature, and you have not detected it, you have not understood it properly, is disaster. Then how do we improve our surveillance? We need to think of an innovation to do the facility-based surveillance at the health facilities. Before you come to the national surveillance table, let the service providers be on their tenterhooks to look out for these outbreaks and to report immediately. The other thing we need to be careful, even as we do the surveillance and reporting, not to say this Mubende team. Such a statement is unfortunate. It is not Mubende. It is our outbreak. Because when you say the Mubende team reported late, you are actually blaming them. You are blaming them. You are portioning a blame to them and say, okay, next time I will not report. Or if it has happened and I have known late, I will not even say the original time when the thing happened because I will be blamed. That is important. Poor mobility and data capture at the health facility. Data capture, data storage, data analysis, I had alluded to this thing earlier, but it is very important that we are able to capture the information, but also keep it. Allow the teams to move. Let them be flexible. The president called the Ugandans together and asked them to give. And people were giving double cabins. They are giving vehicles. They are giving whatever they could. And the teams were able to move. Mobility is key because the outbreak will run like a wildfire on dry grass. So you have to catch up with its speed. If you are unable to do that, you will be in trouble. That's an area that needs to be tackled. Training of experts. We now have a bank of epidemiologists to call upon, but it's not just epidemiologists. There are other expertise that we need to come on board, especially with the data analysis, making sense out of the data that is captured. We need to bring all these people on board so that we are a robust team. I had alluded to the weak IPC measures, particularly for health workers. It is painful for you to lose your colleague and you cannot do much about them. And yet, infection could have been prevented at the level. And then the last, we have the low risk perception in the community. We need to find champions. Now we have a Mama Mabida. Can we have a Tata outbreak, a Mama outbreak prevention and control, a Mama COVID, a Tata Ebola? Somebody, when they speak, they are easily heard but understood. When they speak, people respond and do what has been asked. I think those are key important things that we need to improve as we get along. Thank you.
Thank you, Dr. Peter, the DHO. So clearly from what we have discussed, we have opportunities for innovation at different levels of the process, starting right from detection through the response and eventually to the care, and then in surveillance. We all remember that when we had COVID and the number of cases started rising, the health system, our health system, experienced quite a number of challenges with regard to the response to COVID and the response now to these other outbreaks that are a bit scattered, but they are persistently present. So the issue is what lessons in our response to these outbreaks or pandemics have we learned, and probably what innovations do we see? And it would be good to structure the discussion around the health system building blocks, you know, in terms of leadership and governance for pandemic response, okay? What have we learned, okay? In terms of human resource, what have we learned? In terms, you touched on it a bit, in terms of financing options, what did we learn through the experiences? In terms of the information systems, okay? What did we learn, and what are possible areas for innovation to ensure that our health systems, both at the national and subnational level, are able to respond promptly and appropriately to some of these pandemics. Thank you. So we could have a discussion on this.
Thank you, Prof. Leadership and governance. This is actually very key, and it is at the center if we are to control any outbreak. There is a tendency of us, first of all, not knowing the existing structures. So if we have an innovation that can inform the community of the clear reporting structures, this would enable us to maintain appropriate coordination and hence offer leadership and guidance. When I talk about the structures, Dr. Peter, the DHO, has highlighted how the president used to come in COVID, and I'm sure most of you used to listen to his speech, and you'd wait for that statement of therefore. When he used to mention that, because of his position, we would respond. What does it show you? Leaders have a role to play. But from the president, there are structures that go up to the community, which sometimes we don't know or we don't just respect them. It's not right for you to rush to Dr. Sebutinde's office and forget your local leadership. We have now incident management teams from the national level, regional level, district level, sub-county level. We go down parish up to village level. And I like the way they were structured. They are existing on the leadership structures that are in place. Actually, the president appointed people who have authority. Now, health workers, epidemiologists support them. They feed them with the right information. But because of their position, they are able to speak and influence the public. But I'm calling upon us to develop innovations to allow the community follow these reporting structures. They are existent. At the National Public Health Operations Center for Emergencies, we follow the 717. If we are able to detect an outbreak within the 7 days of occurrence, and we are able to report within 1 day, and then the response is done within 7 days, chances of us controlling this outbreak are high. But like Doctor mentioned, Ebola, when we did investigation, interacted with the community, actually cases started much earlier, in July. First cases reported in September. The community had a role to play, but maybe they didn't know or they were not supported how to report because they actually lost people. You would stand at a household and they just start pointing. There, we lost someone. There, we lost someone. There, we lost someone. So for us, we think this is witchcraft. And if they have already that mentality, you cannot bring your response kind of measures and they are respected. So let's have those innovations in place. Then We need to have innovations that help us to control the infodemic. I'm using infodemic because it's like an epidemic of wrong information. Whenever something happens in the community, there are theories that come up because these are our problems. I remember Dr. Andrew here mentioned to us that if someone has ascites, it is referred to as what? Disease of from the sea, you know? And that's what they believe. So this is worse to an extent that even these very infectious diseases are categorized in that form. And when they have their own theories, it means they will have their own solutions. They will start hiding sick people, and you know what happens? Spread continues, because these are really diseases of social interaction. So it's important to come up with those innovations which will help feed people with the right information through the entire response and even after the response. People need to know some of these common signs and symptoms. They need to know where do we report. They have to stop taking things for granted. You see some unusual thing happening, your child out of the blue blacks out, starts bleeding, and you're like, no, I think maybe this child fell. No, I think my neighbors cursed me. I think, no, people need to know that when some of these signs and symptoms happen, we have to take action, because it will actually have impact beyond yourself. We need innovations to support our human resource. Those of you participated in the response, you clearly saw that COVID found us when I would say we were not so much prepared for it. Now, the very, very thin structure of the human resource that we have was overwhelmed. I like the fact that my colleague Valence brought out the issue of mental health. People worked extra hours. People worked with fear. You know, for us health workers, we know that the disease that I'm treating, I'm also a potential candidate. Like the Baganda say, we can also get this what? These conditions. So you work, but with a lot of what? Of fear. IPC measures, infection prevention and control. People, even this mask that you can underrate, in a clinical setting at that time, you would struggle to get a what? A mask. But again, you are looking at people suffering. These are your relatives. These are your employers. So you are somehow compelled to face. But it is not also right. Because if we lose you, again, it is worse. So we have to come up with innovations that enable continuity of these services, but as well as protecting the already thin structure that we have. When I was in Kigali, I loved the innovation by the Rwanda Biomedical Center. During that time of COVID, they had robots. These robots would do the screening. They would guide the community. It looks at you, you are not putting on a mask, it tells you. It looks at you, your mask is on the chin, it tells you. You just face it and tells your temperature. And for us here, we are using our already thin structure. If we have robots, this can also minimize and also enable continuity of delivery of these services. The robots would serve medication within the isolation units. It just knows that patient A is supposed to receive A, B, C, D. It delivers. Food, the right time, it is delivered. So these highly infectious diseases, if we have some of these innovations, we can really minimize. Because in that case, you'll be looking at IPC measures focused on the robot alone. But before the robot, you are looking at like 100 health workers whose support maybe you do not have. Think of innovations that can deliver supplies. or deliver samples from the community to the reference laboratories. These drones, we have drones. Drones can be used to pick a sample from Kabuyanda and is delivered here at Mbara Regional Referral in a very short time and minimizing the human resource needed and as well as ensuring safety. If you need blood urgently in Kabuyanda and it is not there, a drone can deliver blood from our blood bank here. Within minutes, the blood will be in Kabuyanda. You've minimized on the resources you need to do that. You are protecting your thin structure of the staff that you already have. Yeah, but that mentioned, I think also at a national level, we need to think of how we broaden our structure, and I'm sure this revision has been done. Probably the implementation has already started. We need to have critical staff cascaded down at several levels. We don't have to be responsive all the time. We have to really prevent. Let's look at ways of preventing this from occurring. The issue of financing options. I think from the room, we have gurus from the economic area who can really guide people to come up with innovations that can use minimal resources and importantly, look at our locally available resources. Small things usually can bear big impact. Like what we are going to do, there may be small ideas, some of you may underrate them. Even as we speak, you have some ideas, but you are saying this may not do anything. Those small ideas are the ones that will cause a big impact. Let's think of innovations to strengthen the intersectoral approach. One Health has really, as I told you, before COVID, it used to be a bit of underrated, it was in its junior stages, but now it has come up to prove that it's one of the best approaches. Let's have innovations to allow several sectors, people from the animal sector, they need to know that they have a role to play in the human sector. Human sector, you have a role to play in the animal sector. You had in the news recently, when they published a research showing that most of the chicken we consume on street has a high concentration of what? ARVs. That puts at a high risk of resistance. When you have resistance against the available technologies, what results are you going to get? But if we have innovations like I remember Dr. Grace mentioned, which can quickly detect concentrations of drugs. First she mentioned concentration of pesticides. But we can also think of concentrations of drugs. We have pharmacists in the rooms. I mean, we just consume these things. It's not me alone, it's not you alone, not your parent elsewhere. I remember someone said in the village they eat safe food. No. Situations have changed. Even in the village, the food we used to grow is no longer there. Actually, they look for food in what? In town. So we are not safe anywhere. So we need to come up with those innovations in a simplified version, which is cheap and affordable. Thank you.
Thank you, Dr. Peter. A round of applause for him. Yes, Dr. Peter.
Yeah, thank you. This is where the discussion gets very interesting. Everything that we do in health, even in your homes, rotates around money. So the question I'm asking is, if we're going to improve health financing, where is the money? We must get this money. Now, who has the magic bullet? The project that is going to bring in money. And that's why you see the government, that's why you see this country, we have tried so many things. We started with the Operation Wealth Creation. And operation went on, and we are yet to know what proportion of the community are now wealthy. From Operation Wealth Creation, we went to Emioga. But we are doing all these things to look for a magic bullet to put money in the pockets of Ugandans. We are now thinking that the parish development model is the final bullet. People are going to get money in their pockets. God gracious, let's hope that it's going to do the magic. But where is the money in the pockets of Ugandans? Where is the money in the pocket of the Minister of Health to make sure that the money is available for all these resources to be procured and processed and brought into our health facility? So innovators here, Professor Kazoba, I know you're a money person, and I know you are listening. How do we get money in the coffers of the health facilities, in the universities? We need to get that money. Leadership and governance, we have learned at that time, the president dubbed us commanders, that the DHO and I think we were two, DHO and RDC. If you don't do what you're supposed to do, I'll come and fire you. And we said, now we're in trouble. We were not sleeping. And so we learned that even for communication, there must be an authoritative voice. During outbreaks, not everybody talks. Our first case in Mbarara, I remember vividly, and I wish I could play the WhatsApp messages for you. It was myself and Dr. Rose Muhindo, who was the leader of the case management team at the Regional Referral Hospital. So we came to the media to communicate. I stood on the right and Dr. Rose stood on the left, and the RDC communicated. And you people, you look, even the whole DHO cannot communicate. It is now the RDC speaking. And I said, oh my God, look at them. They don't understand even the science of communication. That by me and Rose standing next to the RDC is speaking science provided by the technical teams. And you are standing by him to say, that is the truth about what we are saying. So that science needs to be cascaded across. When the president was talking about the cytokinin storm, for goodness sake, President Museveni is not an immunologist. But when he explained and spoke it, people understood immunology. I said, the president says there was a storm. It is this storm that kills. Please be careful. That is the science of leadership and governance and managing scientific information. It's not for everybody. So these structures have been established, but they need to be maintained and sustained for us to get better. In the other pillar, medicines and medical supplies, commodities. You saw, I am proud to be affiliated to MAST, and I am proud of MAST. To date, Professor Ogwang is still called Professor COVID out there. Why? At the time of need, he had an answer. He said, you guys, look here, this thing works. And the president came up and said, yes, this science of mine, these professors, they have what it takes. They have the guts. What they have done is right. Support them. The support came forth. And when you say those things, the community is watching and they are listening. That affects the way they respond. Covidex sold. Covidex is still selling up to today. But there were many other products. When COVID died down, they also died with it. But Covidex is still here to stay. So as we think as innovators, we need to think of new medicines, new technologies that answer the need of the time. Now is the problem. What is the answer to that problem? If we don't do that, then we will remain archaic. And our things will be looked at as science. That's how scientists think. But now science, we think and we do things. I think that spirit must continue. There are so many other things that have been said for time. Yes, the structure. The newest approved structure for health workers is a long time thinking. Somebody, some politician, said, oh, now you're going to put doctors at the health center 3. What will they do? My brother, my sister, it's not just putting a medical officer there. We are saying a medical officer will go there. And now they begin to think and plan for NCDs we have been talking about. They begin to plan and draw strategies to prevent the next outbreak. They begin to plan and see that every other person is vaccinated. We used to, Professor Mulogo, you remember when you were teaching us about disease prevention, and you said immunization or vaccination is the gold standard. Yes, it still is. And because of that, the country now has revised our immunization program. It's no longer the childhood immunization diseases. No, we are saying we are going to immunize, we are going to vaccinate individuals as the need arises and as there is a problem. So that now we must have these vaccines in place. Somebody asked me, vaccines take long to be made and then finally approved. How come the vaccine for COVID-19 took only 3 months? I tell you, and like I told them, it took only 3 months because it was riding on an old technology, which was developed many years and now was waiting for application. So when the need came, the messenger RNA technology for making vaccines was already there and it was simply brought on board. What other technologies can we think about to prevent disease in the context of Uganda, in the context of Mbarara, in the context of Africa, so that now we develop it today? When issues come up, when outbreaks come up, tomorrow we will simply pull out this technology and apply. I think that's the way we need to think, and that is the way to go. Innovators in the house.
Thank you. So I had already highlighted some of the challenges in contact tracing, and I had pointed out that innovators need to think of ways in which to do a tracing of these contacts. And so maybe someone can think of a contact tracing app so that you minimize the human resource involved, but also you shorten the duration within which these contacts can be traced. Then in terms of case management, the DHO highlighted an issue about IPC, where health workers do not stick to the standard infection prevention strategies. And so one approach that Dr. Kaunges mentioned is using robots, but there are other innovations we can do to remotely monitor these patients so that the risk to those who are involved in provision of care is reduced. Then we have been told that the country has prepared a number of personnel in terms of responding to these pandemics. And so it is important that there is always a pandemic preparedness plan, and this should be updated routinely so that in the event of a pandemic, there is something to begin from. And these plans should be at all levels so that in case there is a pandemic in one region of the country, the teams know exactly what to do, which protocols to follow, and where to report. And that way, identification of such pandemics can be done within the shortest possible time. And so some innovators in the house could think of ways of coming up with pandemic preparedness plans. which could be an app based on different pandemics, and then these, like I said, could be updated routinely. Then there is an issue that the DHO hinted on about the supply chain management. Quite often there are shortages of the basic commodities, PPEs. Are there innovative ways in which we can ensure that the supply chain is kept up to the standard, especially in times of need, when there are pandemics or epidemics? In COVID, some of the centers had shortages of basic supplies, especially in terms of PPEs, and that greatly affected the way cases were managed. And so, amidst the financial challenges, is there ways in which our supply chain could be stabilized to help better manage these situations? And lastly, one of the cornerstones, like my colleagues have already mentioned in the management of pandemics, is the ability to diagnose. So as a country, we need to better equip our labs. We need to make sure that the people who are employed in these labs have the capacity to run the different diagnostic tests. And in addition, we also need to invest in research so that better diagnostic procedures are thought about, better treatment strategies, and then development of vaccines that are locally developed to minimize some of the perceptions. Deep down in the villages, some people think that maybe these vaccines had a different intention. And so if vaccines are locally developed here, maybe that could change the public perception about some of these vaccines. And lastly, there is need to put emphasis on health education and creation of community awareness, like the DHO had emphasized, so that the community understands the science behind these epidemics, and that will greatly influence their involvement and the kind of interventions that they do. Thank you.
Yeah, Prof, one thing that I didn't mention at the beginning, you highlighted all these pandemics, of the old, of the recent ones, but also the outbreaks. In this country, in East Africa, but in Africa, one thing that is common about these outbreaks and pandemics is that they are associated with the seasons, climate, and environmental changes. And right now, it is the talk of scientists and politicians across the globe. Now, innovators about this climate change, about the environment. Dr. Andrew earlier told us about the pollution of the air that we breathe in. But this pollution is coming from the environment, from the things that we do. If there is one innovator in the room with a gadget that cleans air that enters my house, I would pay. I would gladly pay for that gadget and stick it on my gate. So that I'm sure when I enter, or whether on the gate or on the ventilators or wherever, so that when I am sleeping and resting, I have clean air. But you see, I'm saying it simplistic like that, but it's a big challenge. How do we make sure that our environment, our climate, our forests, our rivers are safe, and they keep us safe in that ecosystem that is well balanced and maintained?
Okay, thank you, the panelists. A round of applause for them. So we are a bit constrained on time, but as I said before, you can interact with them during the lunch break. So at this point in time, I would like to invite a few questions from the audience. I see Dr. Andrew's hand is up. You could give him a microphone. I see Dr. Grace's Hand is up.
We ask at once and then they answer at once.
Yes.
Because we are behind time.
Thank you so much, panelists. Thank you for talking about those brilliant ideas. I was part of the COVID management teams, and one of the biggest challenges we had was oxygen. I literally published a paper, and one of the biggest predictors of death was not having oxygen. If a patient required more than 15 liters of oxygen, they were 15 times more likely to die. And the problem was we did not have devices. I am still looking for an innovator who will make for us an oxygen machine that is Ugandan made. I still see this. Unfortunately, many of you don't see COVID, but me, I still see the scars of COVID. I treat patients with scars from COVID, and they are suffering, and they are looking for someone to help. Again, I want to ask a question to all of us. Who said we should use water and soap to wash hands? And who said so? And there are alternative ways of cleaning our hands. Honestly, because I see it's cumbersome, it's cumbersome, and innovators should think there are other ways that we can use to clean our hands. And maybe as I conclude on this issue, our panelists, many of you are policymakers. The problem with infection control and pandemics is lack of consistency. Right now, if COVID comes back, we are done. Nobody washes hands at the gate anymore. Everything else has, we need something to continue in the process. And then finally, we need AI involved in what you do, artificial intelligence. We need messages contextualized for my grandmother in the village. There's no app right now I can click to that can give me information on COVID in my local language. Is it there, DHO, right now? Is it there? So we have a long way to go. And thanks to innovation, I hope we shall shorten the way.
Thank you, Dr. Andrew, for those issues. Dr. Grace?
Thank you so much, the panelists. Mine goes to the innovators. Oftentimes in hospitals, we are improvising. We do not have all the resources we need. And when epidemics or pandemics or outbreaks occur, it takes us by surprise. Can we have an innovator who is going to come up with something that when a patient comes, is screened first and warns me as a healthcare provider that you need to take extra precaution? Thank you.
Thank you, Dr. Grace.
Thank you, the panelists. I can't stand. My name is Francis, and I'm a microbiologist in the university. I've really enjoyed the discussion about pandemics and epidemics and what we can do. What I note, and it's been of concern to me, is that all the recent past pandemics or epidemics have been of viral or bacterial cause, and nothing of fungi. Fungal, you know fungal? Yes, I'm a mycologist. I deal with fungal. And of recent, I've been looking at a documentary by the BBC about a fungus called cordyceps. That is, it's a documentary, just imagine it, infecting an insect, and this insect goes like a zombie, and then by the spores. And then the spores proliferate from its head, and then it dies. It becomes a substrate for this fungus. It's been so much intriguing, and I've been thinking the next pandemic could be of a fungus. And yet, in my practice, I don't see as many innovations in the detection, diagnostics, fungal detection, diagnostics. Fungal diagnosis takes really a long time, up to 21 days. That's when you are getting results. Can there be innovations in that domain? And indeed, you rightly said that epidemics require diagnostic approaches. And for now, challenges. Now, just 2022, end of 2022, October, it must have been, the WHO released fungal priority pathogens, 19 groups of fungi. And of the 19, we're already dealing with 15. Here, just around. So it's a gray area where we need serious innovations. Thank you.
Yes, good afternoon, everyone. Thank you so much, our panelists. My name is Collins Joshua Kabogoza. I am a biomedical engineering student, my final semester at Ernest Cook Ultrasound Research and Education Institute in Mengo. Now, there are some questions and a few points of concern and also few points of solutions. In 1991, CDC started working in Uganda, and in 2000, they opened an office. CDC Center for Diseases Control, and it's an organization for the United States. It's for the United States, not for Uganda, not for any other country, but for the United States. My point is, through United Nations, through World Health Organization, all which are headquartered in the United States, organizations fighting, mostly NCDs for the United States, for the people of the United States, but mostly outside of the United States. So the US is at a point where they are fighting these kinds of infections, wars and every other thing, but the kinds of infections from outside. We have those branches here in Uganda. We collect samples for them. And I feel we are not utilizing the resources, some of the resources we are having, especially the IDI. I had an opportunity to do internship from there. And this place has refrigerators. I don't want to call them refrigerators because they are -80 fridges, like freezers. And they can go up to -80 degrees. They are very expensive. And I literally agree with Dr. Peter, we do not have money. We don't have that kind of money to buy such freezers because they are very many at IDI, they are very expensive. Sustaining them, maintaining them is very expensive. And we collect samples for them. We have samples that are going back to 2003, still in the freezers. This is 2020, 20 years. And we talk of AI. AI is about data collection. We want to start from scratch when we have these resources. I believe we need to collaborate more with WHO. We do so, but we do not fully utilize that capacity. And through these things, at least we can have some little fund to set up servers, because AI runs on servers, data collection servers, and through that, applications in our local languages can come out. Everything can literally come out. Predictions can come out because through AI, data collection, we predict. And most of the innovations can really land or have a platform or a foundation from these data collection centers. But the data collection centers cannot happen if we are starting now to collect data. They can only happen maybe 20 years later after we have enough data. But there is data at CDC, Uganda. There is data at IDI, Uganda. And IDI is centered in Makerere University. That is for Uganda. So I believe we have some resources. They may not be financial, but we can start from there. I honestly have...
Collins, could you really wrap up your submission?
Sorry. As per COVID-19, Uganda was one of the least affected countries in the world, considering all considering our state of poor or low resource setting. So I really believe, like one of the colleagues said, there are other ways of washing hands, because not all of us washed hands with soap. There are other ways, and we can try to implement that. There's a lot I would love to say, but perhaps I would engage in the after sessions. Thank you very much.
Dr. Peter, pass on that microphone, otherwise Yaka will be impounded by the phone.
I think this is the last.
Thank you so much. I'll speak while standing. Protocol observed. I am Assistant Inspector of Police, Arinito Christine, currently attached at Kashaka Police Station along Mbarara Bushenyi Road. During COVID, I witnessed something which was very touching and painful about the AIDS patients, victims. Someone would travel from Bushenyi to Isinjiro to pick the drugs. And it was a total lockdown. You find this person is stigmatized. In most cases, we could impound these riders, carrying them on the road. And of course, it was a directive. We had no option. But someone would find it difficult to come and explain to you that honestly, I am a patient and I get my ARVs in some other district far from where I stay. Now, as innovators, how can this be incorporated? How can these people be helped in case there is any other pandemic in future, so that these people can be helped from where they are? Because someone would explain with pain, would cry, and would reveal secrets to a different person who could otherwise not have known the sickness, the status of the patient. Thank you so much.
Thank you. There is a hand. Okay. We can have this last
let's
comment.
have the last one.
Yes.
Thank you. I liked the presentations, and what can I say? Basically, innovation needs research. In Burundi, for example, I see that research, the level is low because we need laboratories. I think that it is the same in the whole Africa. And what the solution in this research, when we need now laboratories. Laboratory of anatomy pathologic. How is the situation in Burundi? I think that we were zero, almost zero. So I see that innovation is impossible or is a problem. What do you think?
Thank you very much. So I'll invite the panelists to give comments on the various reactions to the presentations that have been made, but we will try to keep these as short and brief as possible because we have an opportunity to engage during the lunch hour. Thank you.
Yeah, thank you, Prof. Most of the comments actually were additions to which areas we need to critically think about, but I want to draw emphasis to what AIP Christine has raised. I think it is very important that we develop innovations to ensure continuity of care, especially for chronic diseases. She has mentioned HIV/AIDS. I will use that as an example, but we also have other chronic diseases. The NCDs we're talking about here, people who had hypertension, people who had diabetes, people who have cancer, these are chronic conditions that need ongoing care. During that pandemic, the initial measures were really to stop movement without considering those other additional things. Then later we started saying, okay, now let's look at the special categories. Let health workers move, let these people move. Then they realized that, okay, even lawyers have to move. But I think there is a category that had been forgotten of these people with chronic diseases. However, I have my chronic disease, but I also have another dangerous pathogen that can even kill me within a short while. So what safe measures can be put in place for me to continue keeping away from exposure, but as well accessing my medicines And also, my condition is being monitored. That is something that innovators really need to think about. It also showed up in Ebola. We had challenges with these people with chronic conditions. Thank you.
Thank you, Dr. Peter.
Yeah, thank you. Dr. Andrew, yes, we need the devices. And the earlier we thought about these devices, the better. Recently, I had my grandfather had a prostatectomy and needed to move. You have to have a urine bag and a catheter in situ. And where we were, I discovered that there was a small gadget that they gave to us to replace for use as a urine bag connected to a catheter. And then there was an interpiece between the catheter and it was not the ordinary catheter that we're talking about. And when we were discharged, the man was comfortable. He was even able to drive at some point, but with his gadget fixed on his thigh. And I said, wow, it is expensive, but it is worth it. So we need to think to have these devices brought on board. Collaborations, yes. I think that's the way to go. Innocent, Kabogoza Collins. But we need also to be mindful because it is a give and take. Those guys are not here just for just. The interest is not, because they love Ugandans so much and they want to protect Ugandans. Actually, they are protecting Americans but away from America. But we need to take advantage of that collaboration. Now that you are here, you want something that I have. I also have this need. Can we get better? Collaboration, yes, will help us. And Professor, research is the way to go. Research is the answer to many of these questions we're talking about. And that's why we're inviting now the innovators to think with the researchers. If a researcher like Dr. Data has thought about an idea and they have put it in black and white, through collaborations, through networking, invite the innovators, create a team. Let's make teams. Let's make teams with Burundi. Let's make teams with Rwanda. Let's make teams with the people who matter instead of people who gossip around you. Team up with the people who are going to improve your science and get you better. Then these networks will improve and take us to the next level of innovation. Thank you.
Okay, thank you. Dr. Andrew mentioned something about lack of consistency in IPC. Quite often, health workers actually practice IPC, especially hand washing, if they think they are at risk of contracting infections from the patients. Quite often, that's when they do the washing. So I think we may need to look at innovative ways in which to improve risk perception among health workers as one of the ways of improving the consistency to IPC. Otherwise, we may only remember to wash hands when we are in trouble. And the microbiologist mentioned about pandemics of fungal causes. I think this is an interesting area to think about, especially in terms of diagnostics, so that innovations can begin in this area, and by the time maybe a fungal pandemic comes on board, you have where to start from. Otherwise, the turnaround time of 21 days may not be very good for us in the event of a pandemic. Thank you.
So thank you, the panelists, once again. Ladies and gentlemen, we have come to the end of the session. There is a lot of food for thought for the innovators because you've had a lot, and the demand for innovation as far as pandemics and epidemics is concerned is quite high. So we expect you to see you pitching different ideas in order to find solutions to some of the things that have been highlighted throughout the session. I would like to thank the panelists here. They are available to you for further engagement over the lunch break. Let's give them a round of applause. Thank you very much, and we close the session at this point. Thank you.
Thank you so much. Another hand clap as they... Thank you, Professor Edgar, and the panel on pandemics and epidemics. Yeah, they are trying to scratch something in our head such that tomorrow and Sunday is fruitful for the hackathon teams. Okay, so some of the questions are best answered as you start working on the dreams, as you start working on the things that you think are going to be solutions. So thank you so much. So I know many people, innovators, are already thinking of how to do apps and medical technology for detection, response, and reporting of pandemics. So let's keep them at the back of our minds. And we have all the people that have been here, even for the previous panel, are available for discussion, for any further discussion. We are 30 minutes late, so I'm really sorry that we have to fast track our time now. Let's welcome our last panel. That is the panel on mental health. With the hand clap, let's invite Dr. Scholastica Shaba, the senior lecturer in the Department of Psychiatry. Is one of those great researchers you want to be attached to for mentorship and for good workmanship. And you can invite your team and constitute your panel. But just before I leave, Kaunge has just said that you told them that if you have a brain, you are a candidate for a psychiatry candidate. So tell us how we can use our brains better such that we can delay psychiatry. Thank you so much. A very good panel discussion.
Thank you so much, Peter. Good afternoon. I just hope you're still awake, that we can go through this session as well. But I believe that my work or our work has been made easy. You know why? Mental health is intertwined in everything that people have been talking about. So our work has been made easy, and we shall be repeating the same things. As they said, I'm Dr. Scholar Ashaba. I'm a psychiatrist and a senior lecturer in the Department of Psychiatry at MAST. And with me, I have a group of specialists. Some of them are my mentors, and I believe today we are going to understand mental health and how we can innovate and improve these things. But before I proceed, I'm going to let each of them say something about themselves.
Thank you. Yes, I'm Godfrey Zari Rukundo. I'm a psychiatrist and senior lecturer in the Department of Psychiatry. So I'm here, and I'm glad to be here to talk about mental health. I think in the previous session, Dr. Mtekanga said there were 4 main NCDs, and he forgot mental health. Yes, mental health is not infectious, and yet is a very big burden.
Good afternoon, everyone. I'm Samuel Maling. I have been working in the field of mental health for a little over 20 years. So thank you very much for inviting me to be a panelist this afternoon. Thank you.
Good afternoon, everyone. I'm Grace Nambozi, Senior Lecturer, Nursing Department. I'm a nurse, psychiatric nurse, so I'm here to blend with psychiatrists so that at the end of it all, we should be able to get the innovation that we can offer in the area of the forgotten NCD. Thank you.
Yes, the forgotten NCD. So our talk, we're given a title that says 14 million Ugandans have mental disorders or they have mental illness. And the question is, what has gone wrong? I'm not so sure the number is that high, and neither can I say it is lower than that, but we are somehow there. So the truth is, we have a lot of mental health problems in Uganda, and either people don't know where to seek care, or they are not sure that they have a problem, or they don't know where to go. Neither do people know how to innovate and improve our well-being. You're going to realize that most cases, or Dr. Mtekanga talked about diabetes and other things and so on, cardiovascular diseases, but mental health problems are some of the leading causes of disability. Not mortality, but disability, and disability is those years you live, you're not healthy. You're not dying, but then you're not healthy. So mental health problems are those conditions that cause that unhealthy life, what we call disability. So it's worth that we talk about them. It's worth that we work around improving people's lives because of mental health problems. And depression is one of those common conditions. Some research is going to tell about 7.2% of Ugandans have mental health problems, but it could even be higher. A recent study by one of our colleagues, says about 35% of young people, children, are actually abusing alcohol. And that's a big issue. Then, of course, you have other people who are, using other substances, including cannabis and other things like that. And then we have depression. People talked about COVID. COVID came with a lot of stress. People got traumatized and people got mental health problems. So do you know how to cope with the challenges of life, to overcome or to prevent us from getting mental health problems? Is there a way we can come up with innovations that, despite the challenges of life, we actually don't break down, we don't get mental health problems? So I think that's what we are to talk about here. And I'll let it now go to my panelists who are experts in that area. So, I'll start with Dr. Rukundo. What has gone wrong? Is this that we have all these mental health problems? Is it this myth that people think that's what it is? What can we do? What has gone wrong? Doctor?
Yeah, thank you very much for that question. I think there are like two ways of looking at this problem. First of all, I'm not sure if anything has gone wrong. I think actually things have gone right. I think now mental health has been exposed. People are now more aware of their mental health than before. I don't think there are very new things, apart from COVID, which came to complicate things. Other than that, I think people are now more aware of their mental health challenges than before. Mental health or mental illness, let me just use mental illness, has been forgotten for a long time, especially in the developing world like Uganda. And the Vice Chancellor was talking about Burundi. Burundi also has problems of mental health challenges, but with very few mental health professionals. So I think now when COVID came, people became aware because now they were stuck, they were at home, they were not able to work, they were not able to spend time somewhere else. Now they had time to think about themselves. And that's when they were like, okay, I think mental health now is an issue. But before COVID, even our health ministry did not know that mental health was a big issue. To the extent that when they looked for where to put patients with COVID, they thought of psychiatry units. And they sent out patients with mental illness to the community. And later on, during the pandemic, they realized there was now more psychiatric illness with COVID. And that's where now they started looking for where else they could put patients with mental illness. But When COVID came, the challenges increased, as the other groups had already talked about it before. But I want to remind us that there is a statement which says that there is no health without mental health. Mental health is part and parcel of health. And mental health affects almost every aspect of life. Even, for example, choosing a partner, you need to be mentally well. Okay? Being able to study, you need to be mentally well. Choosing a course you want to take, you must be mentally well. So mental health is part and parcel of everything that we do. They talked about feeding. For you to say, I feel like eating chips, but chips are not good for my health. Let me leave them. You must be mentally well. Otherwise, you will eat everything that comes before you, or everything that tastes nice. So mental health is very, very important. It affects our decision making. And of course, you know that all the decisions we make are associated with consequences, whether they are negative consequences or positive consequences. And they can be biological, psychological, or social consequences. So mental health is part and parcel of everything that we do. And again, even when you have a physical condition, you need to be mentally well to reason that I need to go and seek care. Even for diabetes or hypertension or even COVID. So health-seeking behavior is also affected by your own mental health. And I thought about, for example, how mental health can affect some other areas like road traffic accidents. For example, what may cause a road traffic accident? We have Christine here, she was talking about issues with the traffic. For example, when you think about a road traffic accident, you need to think about the mental health of the driver. How is he? Is he depressed? Is he manic? Is he suicidal? Does he want to kill himself by driving very fast? You need to think about the mental health of other drivers, even as you drive. When you're driving and somebody wants to overtake in a corner, what do? Is he okay? Are you going to refuse that, I have the right of way, I must stay here, or you have to give him a way to pass? You need to think about the mental health of the border riders, the cyclists, the pedestrians. So you have to think about mental health of all those people. And then, of course, there are many complications of accidents. But you can see that if you don't integrate mental health in all that, you are going to miss it out. You may just think we are looking at road safety, but have you thought about how mentally stable the road users are? You must think about all that. And they talked about substance use, alcohol. When we were growing up, we had specific alcoholic drinks that we knew. But now there are others that have come up. Akandi, Embogo, many other things, Ntungasas, other things. And they are not locally known as alcoholic drinks. They are known as juices or just Akandi. They don't say, give me that alcohol. They just say, give me a candy. But all those things are complicated. Yes, they have other names. And of course, somebody was talking about cannabis growing. You may want to have it at Chumro, looking at the oil, but what about those who are going to steal it and smoke it? Because we already have issues in our psychiatry unit with the alcohol use and cannabis use. So there are so many things that we can talk about. We need to be able to recognize mental illness. How do you know you are mentally unwell before you reach a point where you need to be tied? How do you know? What are some of the things that you can use to assess mental illness before it becomes very serious? Things like depression that Dr. Ashaba has talked about, it comes in slowly. By the time you know that you are depressed, you already have the disease. How can you be able to identify maybe the risk factors, or how can you be able to identify the
the symptoms that may come first before you become very sick. And what about the stigma? How can we reduce stigma of mental illness so that whoever has the symptoms can be able to seek help, even among health workers? Because mental illness is not immunizable. You cannot immunize against it. And as Dr. Kaunge has mentioned, as long as you have a brain and it is working, meaning you are not dead, you are at risk of having a mental illness. And therefore, we need to be able to think of innovative ways of identifying it, but also treating it. Thank you.
Yes. All of you have a brain, so take care. Prof. Mali.
So, yesterday at about 10 o'clock, I received a phone call from the LOC1 of my village, that's Bukedia. He says, the 2 workers in your farm have committed a very serious crime. They beat a woman, beat her badly, dragged her to one of the houses for workers, locked her there. And the LOC1 went to rescue the situation. And they got her out, took her for treatment, and the woman claims, have not yet gotten the facts properly, that the 2 boys raped her. Now, since then and now, I've been undergoing periods of anxiety. Every phone call that comes, you say, what is it about? Okay? So, as long as you have a brain, like Godfrey and other people have said, the challenges in life happen. And it is your capacity to overcome those challenges and go back towards normal that makes you mentally healthy. If you fail to do that, then you gravitate into a mental disorder. And hence, mental illnesses are generally regarded as common. First reason is because of what happens to us as we do everyday things. We get stressors in life, and so you cannot operate at 100%. If you assess me now, I'm not at 100%. But despite of the lack of sleep a little bit when I was wondering, how about if that lady dies and the policeman took her to CPS, they call it a capital offense, you know? Attempted rape or rape is a capital offense. So, and because these guys are working for me, I am affected as well. So, that's a challenge. So, coming back to why we are here today. So, what has gone wrong? Ladies and gentlemen, in Uganda, let me use Uganda as an example. Today, we are probably 50 million people. They project that over the next maybe 30 to 40 years, we shall be 100, and after that, the population goes up. Therefore, the scramble for resources is very high. Why was this woman beaten? She had gone to collect firewood from my forest, and the workers also were eyeing at the same firewood, and so they beat her. That's an example of a scramble for resources. The land is becoming a scarce commodity. Many people graduating from school do not have jobs now, and that's a very important resource. Climate is changing, and water is becoming scarce, so people are stressed because of access to water and food. So, resources are getting worse. Those days when you drive through Kampala streets, maybe 15 years ago, you would just go at a normal speed. You go there now, borders, taxis, and everything. So the level of stress is extremely high. So the whole change in the environment is making the prevalence and the burden of mental illnesses to be worse. Secondly, because of improvements in technology and so on, we live longer. But as your brain ages, you are predisposed to neurocognitive problems, the main one being dementia. So as you click to 65 and you go up and you go up, the risk actually increases. And so the people who are young now in Uganda, our population, 50% is less than 15 years, I think. Give it time, and the number of the elderly population. So I think there is a point at which each country will reverse being a young population and the older one being the same. And that's where problems will start. And we're not ready for this. So we need innovations for that, like other countries have done. So in terms of statistics, we need to be very careful when we're looking at statistics that is portrayed outside there. So using the example that Dr. Sikol has given, so these people went to a community of primary school children, and they're looking for the issues of alcohol abuse. So the question they used was, have you ever used alcohol, even once? Isn't it? So out of that question, 35% of the children said, oh yes, I've ever tested. So that's a wrong statistic. Because in this room, if we use the same question, we probably get 95%. Because there are even people who are good Catholics and good Christians, when they go to see the priest, they dip the bread in wine. So you have ever tasted wine, isn't it? But you don't have the problem. So we need to look at the statistics properly, because the media portrays things the way they want. They want the 35%. But for us, we say, okay, so how many people actually have a problem of drinking? Then we come back to 10%, which is reasonable. How many people have depression as a disorder? It ranges between 10 and 20%, depending on the population that you're studying. How many people have schizophrenia? The population at risk, maybe 13 years and above, then you come to about 1%. So we have correct statistics. So we should not play to the gallery of the media to portray mental illness in a terrible way. So concerning innovations, which is a part of this meeting. So colleagues, this is a fact. To be innovative, you need to think outside the box, okay? For instance, for you to believe that you can get a message on this phone without wires, that is thinking outside the box, isn't it? Yes, that you can send a message and it reaches there quickly, you have to think outside the box. So it's also a fact that for you to think like that, you need a little bit of mental illness to make those discoveries. But it is not so much as to disrupt what? Your thinking. So these people exist, like Charles Darwin, who went to study evolution. He had obsessive compulsive disorder. You know, it took him there. Crick and his teams who describe a DNA that we are using today to look for solutions for mental illness. He also had a little bit of mental illness. The Wright brothers, who thought that human beings could fly like birds, the people said, but that is, if there is no other form of madness, that must be the real one. Today, you can live here and reach London in 8 hours, courtesy of people with a slight bit of mental illness. So, innovators, if you have a little bit of it, it's not harmful, as long as you can work productively. Thank you very much.
Thank you so much. As we talk about mental illness, I want to start by making a fundamental statement to the innovators. While they have said that if you have a brain, you can be a victim, but I want to start by quantifying it, that all of us in this room have 99.9% degree of mental illness. So we only have 0.1%. So that's where we should really work hard and come up with innovation that will enable us to preserve that 0.1%. Why are we interested in mental illness? The question has been put to us, what has gone wrong? Surely mental illness per se does not only affect one person. When an individual has a problem with mental illness, we know the family is affected, the nuclear family, irrespective of who is going to take care of that person. We know the community where the person is coming from and the country, the resources that are needed to take care of this person. Most importantly, there are challenges in caring for our patients with mental illness. Why? Because the degree of relapses and so forth, especially if they don't adhere to treatment. So I'm looking for innovators who are going to help us come up with a way of helping our community members to come up with something that will make our patients adhere to medication, that will help the community people be supportive of these people. My colleagues here have already mentioned that when somebody has probably gotten into an accident, for example, you look at the mind first. In courts of law, we know people have been taken and the lawyers have said, was that person, did the person do the act in the right mind? Okay? So the mind is assessed first. So what does this mean? It simply means that our people today are faced with a lot of challenges, and the biggest one is the financial stress. People are looking for money left and right, but they do not want to do what? To work. Even when you give them the job, they will not work, but they want the money. And that is putting stress on people. It's putting stress on the employers. And what does this lead to? Again, it pushes them to emotional trauma. I'm looking for money, I can't get it. And the people around them, they are equally stressed. Like Professor here, please, am I safe? Okay, because he said he was not in his normal state. So we need to be careful here. So these things are affecting everyone, the behaviors of people with mental illness. We need some innovation that is going to help the healthcare workers in coming up with appropriate approach to these patients so that they feel they are also being considered as patients. A colleague here has just mentioned that they are at times being stigmatized, not by even the community, but by us, the healthcare workers. And that creates a barrier. Because if I know I'm going to come and even in the hospital, they will say, that one with mental illness. So it means they will not look at me as a patient living with mental illness, but we label them as patients with mental illness, not living with. So this labeling affects the care and the outcome of these patients. So we want to look for innovation that can address those gaps that triggers mental illness. We want those innovations that can help us to guide our drivers on the roads so that people drive safely. Oftentimes, people are driving and they are overtaking anyhow, as my colleague has just mentioned. Could we come up with an innovation that if I'm driving at point X, I am able to determine that when I move to point B, before I overtake, there is danger there already. Okay? Even if I'm not in the best mental state, surely something here will warn me that please don't. Don't join the road, don't cross the road because the train is coming. We know how people have, perished in just situations which could have been prevented. We need innovation to address the challenges the healthcare workers undergo in treating this patient. For example, if a patient comes and the patient is aggressive, is there a way the healthcare workers also can be protected in advance so that if I'm alone on the ward, I'm not going to struggle and maybe fail to care for this patient, but I will have a way of handling it systematically and the patient comes down. We need that innovation. Mental health illness is one of those conditions that you'll die with. But yet we know on treatment, you can live a normal life like any other, especially. We know there are some people who have big, big jobs, but they are on their medication. And they are doing good job for us. So it is very important that we treat it with due attention because we only have 0.1% colleagues. So as we innovate, we are also innovating for ourselves. The cost of care, I've already mentioned that, needs a lot of attention so that we can prevent our patients from being, stigmatized. And then we need also to change the behavior towards our patients. And then lastly, we know very well that the government has come up with other ways of trying to address road traffic accidents. They have talked of seat belts. They have talked of proper use of highway code rules and so forth, education in schools. Can we come up with an innovation? Because all these have been put in place, but there is no sustainability of this. They put a law, I don't know what is wrong with us, especially here in Uganda. The challenge we have, government comes up with good ideas, it is practiced in a week or 2 months, we go back. Can we have an innovation that will keep us, put knowledge into practice and change the behavior? Because if seat belts was, I think, practiced for 1 month, helmet for 1 month, and so forth. Is there an innovation that will make us stick to what we've really come up with to make things work for us? They have put in place tests for those who are driving maybe when they are drunk, but why are people still drinking and driving? Is there an innovation that can make people adhere to the law? Because that is a big gap. That is a big mental illness we have, that we do not adhere to the regulations that are put in place. If we do it by force. If you see a policeman, then you know I should do this. When the policeman or policewoman is not there, that's the end of it. So I'm looking for that innovation that will put everyone, all the citizens in this country, to adhere to the regulations. Thank you.
Thank you so much for those ideas. We agree that we have challenges as far as mental health is concerned. We also agree that we need to improve access to care. And then Dr. Grace talked about economic challenges. So now I would love to redirect the panel to talking about prevention of mental health problems, but also improving access to care and a little bit of economic challenges and mental illness. Thank you.
Yeah, thank you very much. I think prevention, as it has been said before, is better than cure. And but I told you in the beginning that currently we don't have immunization against mental illness. So we need some people that Professor Maling was talking about, those with a little bit of mental illness, who can come up with immunization strategies against depression, against ADHD, against anxiety. I believe it is possible. It's not yet possible now, but I think it is possible. Because if they can immunize against COVID, which was killing people, what about depression? What about anxiety? So I think we need innovations on how we can prevent some of these conditions, including coming up with immunization strategies. But also we have issues with investigations. Sometimes we get patients and they complain, but you have not done any test. How do you know I am sick? Because largely we depend on talking to them and understanding their psychology and so on. So can we be able to come up with a test to say, yes, you are depressed, because according to this blood parameter, you are depressed. Can somebody come up with something like that? John Ngatu, you in laboratories. Can we come up with one of those parameters and say this one is pointing to depression without going to the the cerebrospinal fluid? So then the other one of the issues that predisposes somebody to mental illness is the way we are brought up. The way you are brought up, parenting. So can we be able to maybe to innovate and come up with something which can help the parents to identify mental health challenges when the children are still young, but also to know how to deal with children with mental health problems without making them worse. So there are many disorders in children that need to be identified early. And as somebody has mentioned before, early intervention usually improves the outcome. So can we be able to come up with some of those? And in Uganda, we use maids, housemaids, to take care of the children. But those maids are also children most times, or they are women without children who have no idea about parenting. But also remember, there are no schools for parenting as such. You just learn on the job. And you may make things worse. They come, the children are born, they are brought up by a maid or a young mother. When they are 2.5, 3 years, they are taken to school. And they think the school will do magic to bring up people who are mentally stable. And then when they are able to be in boarding, they are taken to boarding school, because the good schools are boarding. So you find that there is a high rate of mental illness now among the young people because of issues to do with early childhood development. And then the other thing that has come up is the use of technology, social media, video games. Children spending a lot of time there and they cannot think. They don't know how to cope with stress because what they see is from cartoony, or they are just seeing things which are made up to occupy them, so they don't know how to solve their problems. So can we come up with something maybe which can regulate social media use among the young people, but even among ourselves? We have seen some of the adults coming and say they cannot stop using the phone. If he has forgotten a phone in Kampala, he has to go back, or it must be put on the bus now. Otherwise, the day will not end well. He will not sleep, like Professor Maringo was saying. The phone must be here today. He cannot live without a phone. even when there is no business on that phone apart from making phone calls. So then, coping with stress. How do I know I am stressed before I break down? How do I know the level of stress? Can we be able to come up with some innovation to say, I think when I'm this level, I need to calm down. Or if I am here, I am at risk of now breaking down. And we are able to do that at home. And then lastly, I just needed to remind you that mental illness is broad. When Professor Maling and Dr. Grace were talking about the seriousness of the issue, you may have laughed thinking this is, they're just joking. But I want to mention that mental illness is broad. It is big. But the ones you know, or the ones we see in hospitals, those are just a small portion. In fact, the ones we see in hospital, they are about 10%. The ones who come to hospital, they are about 10% of the burden. The rest are in the community. They are not being assessed and they are not being treated. And even if we are to assess among us here, some of you will meet diagnosis seriously for mental illness. A good number actually, especially around anxiety disorders and depression and substance use. I'm sure we'll be able to get a good number here. And mental illness or poor mental health is also associated with other physical conditions. For example, peptic ulcer disease. There are so many people with ulcers. From what? From anxiety, from depression, from alcohol use. People with the diabetes, you see them. They are going to find many people who have either developed diabetes because of mental illness or have developed mental illness after developing diabetes. People with cardiac illness. So there are so many conditions that are associated with mental illness that we may need to address mental illness if we are to address the burden of those other non-communicable diseases.
Thank you, Godfrey. So, in my view, an innovation should bring in reduction in cost of doing business. It should make things faster and less expensive. So, in relation to mental health, one of the big issues we have is the gap, treatment gap. In other words, there are many people who require mental health services, but out of those, only a very minute proportion is able to access care. And there are many factors ranging from knowledge about the availability of the services, community and individual attitudes towards mental health, like Godfrey talked of stigma. It could be a geographical disadvantage because you stay so far and yet the services for mental health are available somewhere else. So bridging that gap through innovation would really be very helpful. How can we make mental health services accessible to as many people as possible in a quicker way and using less resources or utilizing resources which are already available? So, where do we direct ourselves? First of all, in the African setting, we have resources within our communities that we can utilize. I'm going to give you 2 successes of that nature. There's what they call the grandmother program in Malawi. So grandmothers and grandfathers are respected people in the community. And somehow they offer counseling services in their own capacity. So the modern healthcare system trained them to structure their psychosocial support to address mental health issues in the communities. That's a huge success. Another one, friendship benches in Zimbabwe. So when you go to the hospital, you find there either people who have suffered from the same condition, or people who, through other means, have experience in dealing with what you're having. The word bench means when you go to the communities and you're offered a seat, you're likely to get a bench, okay? And when you're sitting on a bench, you're sitting side by side. And so then you talk. I'm looking at a time when the senior lecturers, the professors, and so on will have this type of friendship benches with the students in universities who are stressed and cannot learn properly. So that would be an innovation. In Ghana, they trained traditional healers, whom, by the way, are very acceptable to the communities. They know them. They trained them to offer mental health care. And they also trained them not to offer the bad side, which they sometimes practice. So those are the innovations I'm thinking about. Now let me take you to DRC. So this is where technology could help. In DRC, when you're drinking, they have drawn a line near there. And at a certain point, everybody is supposed to do tandem walking. And when you have taken a lot of alcohol, you can't do that. And when they notice it, they say, now you go home. The remainder practice the same thing. Until the last man goes what? Goes home. So, can we develop a wearable gadget that as you are going to Susu, it says, my friend, continue from here, don't go back, go home. Yeah? You're already tipsy, eh? Yes. And we can also use technology to detect mental illness early so that I can administer it to myself, and if the score is a certain level, I go the professionals and then they assess me. So we have a chance to use technology in other issues like telemedicine. So if you're geographically disadvantaged, but you have a phone, we can reach you, okay? And then we can discuss on phone what you can do. Or the hospital can liaise with the lower health centers using technology to provide care. Then within our communities, there are what they call village health workers. We can innovatively train them, give them access to technology, and reduce the treatment gap that you heard me talking about. So that would be a very good innovation. Then beyond that, there is need to look for individualized personal treatment. The dose of an antidepressant for everybody here varies. Can we find that specific one for you? Okay? And that's where science is going. I think in cancer treatment, that's what it's going. We look for your own responsive medication and a dose. So we should be able to find that for mental health as well. So then if we do that and reduce the side effects, you'll improve the response rate and so on. So collaboratively, the mental health specialists like us, together with the IT guys and the people who do marketing, I think we can make provision of mental services more efficient, more widely available, and at a less cost. I thank you.
Thank you so much. How are we going to prevent mental illness? We need to tackle the cause. There are various causes, as we've already seen, and some have been already mentioned. I just want to emphasize here that we need to come up with innovation that can make our family stick together. Breaking the family has been a challenge. Can we have an innovation around making the family stick together, support one another? Because that's where the problem starts from. And an innovation which will prepare people for eventualities. For example, if one has lost a job or you've retired without preparedness, Oftentimes, mental illness sets in quickly. The level of stress, as Dr. Godfrey has said, increases. And then people fail to know how to handle that. So that innovation in that area will be really most welcome, because everyone will be looking at their own level of stresses, and they would know when they can go to seek for, support and care. We want to promote community involvement in mental health. We want that innovation that is going to empower the community members so that they are able to come up with an idea that this person needs an intervention in the hospital, rather than having superstition around the case, taking the person to the witch doctors, and so forth. Because in mental illness, oftentimes people are taken to the witch doctors, they think somebody has been bewitched. Then you find families fighting. It is so and so, it is so and so doing this. But if we come up with an innovation that can educate the community to be able to identify this at an early stage, and we need role models that people can follow and, try to do as they are handling mental patients, so that the community can also appreciate that actually these people are not as bad as we think. And lastly, we also need to address the area of how one can be able to face the challenges they are facing. Oftentimes, people fail to handle the situations around them. They feel overwhelmed by the problems, and so they seek advice from wrong groups. Can we have innovation around that problem, that especially the youth, the adolescents, and so forth? If there is an app that tells you, if you feel like this, it could mean this. You need to do this in order to overcome that. That would help most of our young people who are getting wrong information. That's why they end up drinking, they end up socializing with wrong groups, and so forth. They end up taking marijuana and so forth because they are overwhelmed. They cannot handle their own situation, but that app will be guiding them. And on that app, there should be an arm, which has maybe like a counselor and so forth, that continues to give them right information. When you experience this, this could be this, you need to do this and that. And so when we do that, we are going to help our people, and we are going to address this mental health problem. And lastly, I want to emphasize also that mental health problems is as a result of empty nest syndrome. Oftentimes, this is not anywhere among our population. A person delivers, even if 10 children, but at one point they have all left. Now we have a challenge whereby all elderly people are left alone in the community. All the children have migrated to urban areas. Can innovators come up with an innovation that is going to prepare people that at any one point in your lifetime, you are going to remain alone? How are you going to cope with life? Yes, and this is really very serious. It is very serious, and this is a source of stress, depression. And now with the aging, Professor here mentioned that the brain also does what? Gets tired. Now you go into dementia because you just don't know how to cope, because you were never prepared. Innovators, please, do something before we all end up with dementia. Thank you.
Thank you so much, the panelists. I believe they have given us information. If we didn't know something about mental health, I believe we are a little bit informed. One, that we get to know that as you age, the risk is higher, but also the environment we live in may affect how we respond to the situations around us, and we may have some form of mental illness. Dr. Rukundo talked about parenting, a very challenging thing, because there is no manual or there is no recipe. We just get into it and we think we are doing the right job. But then, as much as people are recognizing that now we are aware we have mental health problems, we also realize that there are challenges in accessing care, or maybe also accepting that they need to seek care. So in that case, you think about stigma. So in short, there's a lot that we can talk about mental health and mental illness, and we can't exhaust it in about 45 minutes that we are given. So we are going to wrap our talk at this point, but we are going to request some questions from the audience.
We'll start with this side. We've not given them the chances.
Good evening, good afternoon, I think. My name is Dr. Arman from Burundi. I'm Deputy Dean of the Medicine Faculty at the University of Ngozi. My question goes to Dr. Rukundo. You know the situation of Burundi about psychiatrists. I don't know to pronounce very well. Psychiatrists. We have maybe few health provider for mental health, and the few people we see, when we see them, also how they like, how they do things, we think also they have mental health. So what's wrong? Is it the same case as here in Burundi, in Uganda? Also, I would like to ask about healthcare providers. Because we are in the low middle income countries, and where we don't have universal health coverage is not available. The example in Burundi, some doctors can diagnose an illness, and the patient cannot have access to the treatment because he don't have his financial difficulties, and he sees that the patient dying because he cannot do something for him. I think that can affect health providers. If you diagnose and you see that people cannot get treatment. So have you done any research about health providers, mental health of health providers, so that also we can think how to prevent mental health for them?
I think we can have questions and then we respond at once.
At once, yeah. Let's exhaust these, then one here, then we'll go this side, maybe two, just to.
Thank you so much. Thank you so much, our panelists, for the presentation. My name is Joseph Labalpin, fourth-year medical student at MAST, doing psychiatry currently. I'm so much humbled to listen from our professors. Now, this is my question. We realize that mental illness is almost everywhere, and everyone is a candidate. Now, I want to ask, we're also told that some of these mental illnesses are genetically caused. Now, is there something they're doing for that specific cause of the mental illness, or there's nothing we are doing for that? Because you realize, being genetically predisposed, there might be nothing that they can do. Perhaps we can also think at that as well. Otherwise, thank you so much for the presentation.
Yes, thank you, panelists. This topic is really interesting, and I associate with it because I have a brain. Mental health, I think it's really something that we live with, yet we neglect it. To an extent that even if yourself, you realize that you are not okay, you still don't accept. So I think in this room, really, we need to think, how do we innovate to quickly identify people? Because for me, I look at this as holding a lighter glass. You know, I can pick a glass, it's light, and hold it up. But if I keep holding it up for a week, that glass will gain weight to an extent that I can't even hold it anymore. That is mental health. You have a simple thing, you get home and something has disturbed your mind, but you keep it yourself. That thing will keep growing, growing, growing. And by the time they get you to the psychiatry unit, it's beyond repair. But if we could actively look out for these cases, we have churches, we have markets, we have mosques, we have, all communal areas where we can meet people and have applications that can quickly alert people that, something is not right. Seek care on time. I think would avoid even those other complications, things like suicide. The issue with mental health is if you don't receive treatment, you can get a solution for yourself, and that solution may be bad. You can decide to kill yourself. We can avoid some of these things. So before they get to those levels, can we look for innovations to look out for them? And even within hospitals, I like the comment my colleague made that, sometimes health workers are neglected the population also. They look at you and they think you know everything, you are okay, yet you have bigger issues with you. So in hospitals, can we have innovations that can inform health workers that, something is not right, and they receive attention? We have lost health colleagues. In my class, undergraduate, I lost a colleague who committed suicide. But when we used to go for rounds, he would command professors on ward. And as students, we would say, this guy has a lot of zeal. But yet the guy was sick. But no one picked that. Until when we went to Tabika for our rotation, and we got our colleague in the ward. But 3 years after, we heard that he committed suicide. So health workers, I think, are a neglected group in terms of mental health, and we need to have innovations to pick them up. Then health patients on ward, they come with other conditions, but we neglect the mental health bit of it. Until when they have obvious symptoms, then we call for psychiatrists to review. Before psychiatrists come into review, could we screen them and identify that this patient is at a high risk of mental health or they have issues of mental health? Thank you.
One question and two here, and then we are done.
Thank you very much. My name is Moses Ochora. I'm a pediatrician. I'm a bit concerned that everybody is talking about the adults. We are speaking for ourselves and we've forgotten about the children. So I want to add my voice to Dr. Rukundo, who has hinted about children. We advocate for them. We are making a lot of decisions as adults to keep children in school till 6 p.m., primary school children. We are exposing them to all sorts of technology because we want to make them happy. They are on TikTok and recording videos. And eventually all this affects their mental health, and they will tell you that most of the illnesses that we get as adults probably began around the time we were in teenage. So I want to challenge all of us here, including the people on the panel, that what solutions can we get to protect children from the decisions that we make as adults, to keep them in school, to expose them to social media, to deny them things or to overgive them what they would otherwise not need at that time. So I think everyone here needs to think about that. How do the things, the social construct, education, religion, and finance, how do we protect children from the detriments, the dangerous effects of all this? Thank you.
Thank you, our panelists. Mental health. The first statement you'll tell that patient is, well, you need help, and they'll say, do you think I'm mad? So it's defensive mode. But like someone said that, what if it's genetic? And speaking on behalf of campus students who have gotten maybe, not most students, others, who may get challenges. We're ignoring, we're saying all these things, but these kids are going through a lot in terms of relationships, not partner, but even with colleagues. And it has let them down in terms of, they think they're too big to be disappointed. And could it be, not everyone has a chance to come to your ward. Like people challenging each other. Can each faculty try to see that this is incorporated, maybe in the first or second year is where they usually get problems. And then they are thinking they are adults, and then they think they have to live like adults, and then confusion just comes in the head, and when you're helping them, they're like, do you think I'm mad? So that is my take on that. Can we have it in the curriculum of universities? Thank you.
Two questions this side. We can continue the interaction. There was a hand there, this side. We can continue the interaction later because we have very little time. And tomorrow.
Good afternoon, everyone. My name is Elia Twinamatsuko. I am a data scientist at NITA Uganda. It is unfortunate that we have to wait for one full year to have such discussions, but someone said we don't have money, so we'll take it. My question really is on public health data. I had a chance to interact with an Indian friend of mine, and the state they were coming from, there was a challenge. So I was asking, but how did you guys come up with such a solution? He said, there is data, you can visibly see it on websites. So I was thinking, as a resident of, or as someone who comes from Isinjiro, where do I even access data about mental health from? For example, if there's maybe an outbreak and there was research done on it, maybe Ebola. Apart from us seeing on news on NTV, there is Mubende, can we actually see, can we actually ask anyone in the room now where your data is made public? Because I think we don't have to write people's names, but we can expose and say, Isinjiro has maybe the worst cases of this and this disease. It can jeer us as innovators. As a student who comes from that district, I can say, but how do I help this? That is from asking from innovators' side. Then, of course, as a support, as NITA Uganda, we have a program running, and I think the next 2, 3, 4 years, we plan to cover connectivity in I think most of the districts in the country, if not all of them. We plan to cover them. The program is UDAP. You will probably hear about it or you have heard. So we encourage the innovators in the room. If you come from a further district, not Mbarara, we are going to bring connectivity to those districts in maybe 4, 5 years. 3, 4. The program has started, surely. Some of the districts like this one are already connected, but we are going to even further those districts that are not connected, so we don't have issues of, we don't have infrastructure, we don't have internet, we will cover that. But the question maybe that I would want an answer on is, can we get public health data exposed to the public? Because again, under NITA Uganda, I think there is a public data protection office now in place, and the act is in place. By the way, the innovators here, do not get worried. There is now, you can have protection over your data. If you're a data collector, a data controller, there are responsibilities, there are guidelines now, and I think the Ministry of Health is coming up with a framework around personal data protection. So that should not be a worry anymore about how safe is my data. Someone talked about it. We are doing away with that as well. We have an act in place. So it is now your responsibility. Can we have public health data exposed to us so that we can see where we are lagging behind and innovate more? Thank you.
Are you going to give free data to people?
Okay, thank you so much.
My name is Esther Bewa from Nursing Department. My concern is about school-going peoples, because we've been going to schools and we found they have social challenges. For example, one time we went to visit a certain school, and then we found when two boys were planning to commit suicide. They wanted to jump from a height. They were staying in what? They have a school with what? Storage. So they said, okay, it is good you've come and you have saved us. But otherwise we were planning to kill ourselves. So we went further to ask what the problem was. So they said the problem is from our parents. Because you know, parents, they have no time for us. When they come, they just go on their what? Phones, as we are talking about phones. And we try to tell them our challenges, they don't want to listen. Now we feel we are tired of life. So I am asking the psychiatrists, what measures can you put in place? Maybe to help. And you send some counselors in some schools at least to give them some talks, and maybe if there is a general meeting in some of the schools, so that they talk and they see how they can create relationship between parents and their children. Thank you so much.
Thank you so much. Let's give them the opportunity to answer those ones. And if time would allow, we can add on.
I think we'll have to continue these discussions outside here because there are many questions. But I thank you so much for this. First of all, the Dean from Burundi. At least now the number of psychiatrists in Burundi is increasing, as had we discussed earlier. I think this year you may be having at least more than 4 coming back. So, but that may not change the attitude towards the health workers. The health workers are stigmatized, and they stigmatize themselves as well. And as we said earlier, mental illness does not fear you. Whether you're a professor, whether you're a vice chancellor, whether you are the dean, whether you are the head of a department, it will come to you. Whether you're a doctor, mental illness will come. But I think we need to be able to identify, if you identify a colleague who is having an issue, maybe you can take a step to say, man, are you able to sleep? It's as if your eyes are red. It's as if, like you have to come as a friend, as a colleague and say, I think, as if you are having an issue. How do you address other issues which you identify in colleagues? So I think we need to be able to break the silence and reach out to one another. Otherwise, the small human resource is going to be depleted with issues that could be prevented. Dr. Kawunge has talked about carrying a glass. Even if it is empty, you cannot actually carry it for 5 hours. The arm will be tired already. Even if they just say, put up your hand like this. When we were growing up, this was one of the punishments. Kneel down and put your hands up. In the next few minutes, you are asking for mercy. So it may be something small, but health workers are facing it and they are breaking down. And unfortunately, health workers are poor patients. They are not good patients because they have, in Luganda, they would call it lugezgezi. They think they know, even when they don't know. So we tend to treat ourselves. And of course, when you treat yourself, you are likely to undertreat or overtreat and cause other problems. So, then the other issue, somebody talked about genetic counseling. Not genetic predisposition. If you know that this person has depression, and I have also suffered from depression, it's better not to get married or to produce a child because the risk increases. If you have had schizophrenia, it's better to marry maybe somebody with depression to reduce the risk of schizophrenia. Because if you are having the same disorder,
and you get married, the risk of reproducing that disorder is high. And in Runyankore, they used to have a saying, Oashwera abuza, that you ask before you get married. Take some history. If you have sickle cell disease and another one has it, it's better not to marry the same person who has it because the risk increases. So I think there is need to ask a few questions before you make the final decision, even if you don't go to the labs. Somebody asked what the role of artificial intelligence in fighting mental illness. These are some of the innovations that have come up, and we can still use artificial intelligence to assess, even to manage, even to come up with a possible medication that may be appropriate. Because there are those who, you know, if somebody is like this and has these features, is likely to have side effects on this medication because they have had a side effect before on another medication similar to this, like with similar properties. So we can still use artificial intelligence to come up with the diagnosis in some way and also monitor treatment, but also be able maybe to provide the appropriate treatment. But now those, we leave them for the innovators to think in those areas. Dr. Ochora talked about children. Indeed, children are forgotten in many areas. Usually when you are thinking of a child, you think you need to divide the doses to fit the child. And in mental health, we generally forget children when you think about mental health. For example, when you lose somebody in a home, everybody will be coming and saying sorry to the widow, or the brothers, and the children are just there left alone. And if they get other children to come around, they just play around, they play. But don't think they are stupid. They are thinking, but they don't know how to cope with it. They'll be there playing, but when they go to sleep, they think, what's going on? Is daddy coming back? And sometimes we deceive them. He's coming back. We are going to find him. Huh? And yet you are telling lies. And the children have issues with that. So I think children, we forget. And he said, how can we protect them from our decisions? You want a child to go to Ntare school, for example. And the child says, I want to go maybe to Chisubi. Those are secondary schools in Uganda. And then you are like, this is the one I have chosen. You must go to the school I want. But sometimes the child doesn't fit in that school until maybe they become depressed or until you hear they have now gone into alcohol use. So can we be able to involve the children in some of the decisions that we make to avoid the negative consequences? So I think, as Dr. Ochora mentioned, we need to involve them. We need to think about them. We need to plan for them and planning for the right things. But Esther talked about, I think it is also Ochora and Esther, they are talking about school mental health. Most teachers are not educated about mental health. They know how to do mathematics and social studies and English and so on, but they don't know how to deal with a child with autism. They don't know how to deal with a child with depression or anxiety. They are likely to beat them as children who are badly behaved. And yes, children are having issues. So this issue of saying that a child should go to school at 7 and come back at 7 with homework to finish at 9, that's not good for mental health. Even for you as an adult, it's not good. So I think those who have voices or those who can innovate, maybe we need to show people that this is not right. Some of us, when we were in school, we never did those things. We would finish school at 3 and play until 5 and you go home and no homework. No homework until tomorrow. And we made it. So what has happened now? Are things more difficult? Or now people are aiming at passing exams and making more money in schools other than taking care of the children? So I think we need to do something around there. Nakato talked about students. Indeed, it is difficult because in students who are coming from secondary schools to university, they have been under a controlled environment. There are rules, clear rules. You don't go out, you don't do that. You must be sleeping by this time and so on. And then they come to university. University is freelance. You can choose to go to class or not. They can only catch you maybe at the time of exams. But they don't know how to cope. I don't know whether we should put this in secondary school to prepare them for university, or we put it in first year as part of orientation. I don't know. Maybe we need to see what needs to be done. The innovators can think about that. Public health data. It has been a very big challenge. For a long time, mental illness was not included in the health information management system. Then later when they improved, they just put mental disorder as one of the things to enter in the system. But mental disorder, there are so many mental disorders. So when you say mental disorder, what can you plan? What are you going to plan for? Is it depression? Is it anxiety? Is it autism? Is it what? So even now, we don't have many entries for mental disorders. Their register does not have, like at the health center, they don't have entries for mental disorders. They just have one line, and I think epilepsy. And then what happens? So when they are capturing information at the Ministry of Health, they think mental illness is not a problem because it's not captured in the system. And yet, it is very big. And as Dr. Sevtine mentioned earlier, we are depending on the paper files. So whatever they put in the system there is a summary. So they are going to say mental disorder, this number. But you cannot plan for that. And yet for HIV, they specify this is HIV. For maternal death, they specify this is maternal death. But for mental illness, they just put one block figure. So it is difficult to plan for that. So I think, let me just say that, and the rest can add.
Yeah, thank you, Godfrey. I think you've really touched almost everything. So let me just add maybe two things. If you know that you have a genetic predisposition to mental illness, it's like you being aware that your car is a DMC. You don't go at a terrific speed because yours is not like other cars. So you take care, okay? So if you know you're predisposed to alcohol use because of your parents and so on, don't even try, because then for you, you have the risk. So, but just be assured that having the genetic predisposition is not a guarantee that you will develop the illness, but you have a fertile ground for it. Okay, so you must work hard to make sure that you don't start. Then in terms of AI, how do we know that someone is mentally sick? We look at the emotions. You can see emotions on the face. You can know how people communicate through their voices, how much they say, or you can track conversations through WhatsApp. So you can put in AI to detect those things and be able either to warn the health workers or family members or even yourself that something is not right. So that's the innovation that we're talking about. And then I think lastly, in terms of prevention, many people in this room are in middle age, the young people. Now, the prevention of many of these mental illnesses for later in age happens now. If you miss it now and you begin engaging later on, it's not as good as if you started now. So, for things like dementia, exercise, eat well, sleep enough, get educated, that one I think is okay here. You need to be cognitively engaged, things that stimulate the mind. Music is a very good therapy, so once in a while, listen to music, you can even dance. So when you do those things, then later on, you reap the benefits in terms of prevention.
Thank you. Thank you so much. I just want to emphasize that we need to confront the challenges of mental illness and we get the right innovation. I also want to just quickly say that relationships among young population is really something that needs to be properly addressed because people are copying and pasting. If somebody is with so-and-so, somebody is with so-and-so, what of me? So that copy and paste, do it carefully, okay? Because at the end of the day, if things don't go well, that's the beginning of mental illness. And yet, when you try to warn somebody, will say, maybe for you, you are ugly. Nobody talks to you. So come up with an innovation that captures those kind of words to warn people who might be caught, unaware. I really thank you, and I believe the innovation we shall get will answer most of our mental problems. Thank you.
Thank you so much, the panelists. I believe and I know that you have done justice to this topic. So the audience, please give a round of applause to our panelists. And mental health and mental illness, it's a wide topic that we can't complete in 1 hour. But the majority of you know these people, so they are available. Continue engaging out of here. And then Dr. Rukundo said that prevent mental illnesses in the future, especially dementia. You young people, please go to church and pray as well. Yes, so let's keep engaging. There's a lot to innovate around mental health so that we can prevent these things from getting worse. In the beginning, we said people are getting aware that these challenges are there. But it's not enough just getting aware. We need to find a way to prevent, access care, but also improve outcomes among those who have got these problems already. Thank you so much. I hand over to Peter.
Thank you so much. Thank you, the panel. Let's give a hand clap as they go back. And thank you so much for making mental health so palatable. So easy to talk about. Sometimes it is really hard, because they have done good promotion of mental health and made all of us candidates. So it becomes very easy to talk about, and that's how it should be. Thank you. They have made our work easy as innovators. Remember, we can innovate around reducing the cost of treatment, making the treatment faster, bridging the treatment gap, okay? Easing access to mental health services. Those examples of the Professor Maling, you call it the grandmother project. Yes, where you line grandmothers and fathers to give support. That's amazing. The government has started giving money to, you call it, no, the money for the elders. Yes. Above, I'm told they have now brought it to 60 years. They are going to start giving allowances to people. So getting old is going to be a little more, will not be so poor. Yeah, thank you so much for, that benchmarking is very, very important for us tomorrow as we start the hackathon, thinking through what is possible. And then I loved the friendship benches and the alcohol red line. Okay? So that when they see you're starting, they actually don't have to see. You tell yourself because you have to do the tandem walk. Okay, amazing things. Thank you so much. Yeah, we are on for lunch. We are going to have 30 minutes of lunch. We have 2 serving centers. One is downstairs. The other one is just where we had our break tea. The coupons are out there. There are ladies that are giving out coupons. We need 70 people down and 70 people up. So make sure that you don't congest the walkway. Get the coupons and go to the different serving centers. We have 30 minutes. We'll be back here. We have an amazing presentation by Camtech in the afternoon, which is going to set us up for tomorrow's hackathon, okay? And then we have closing remarks. So let's have someone pray for our lunch. Any other volunteer? Yes, John. Ngati, you may need to pray for our lunch.
Colleagues, let's pray. Father, we thank you so much for the discussion so far. We thank you for the amazing people you have brought here. We commit you the lunch break we are going for. Bless the food and drinks we are going to take so that they may energize us for the next session. Through Christ our Lord, we have prayed.
Okay, thank you so much. Make sure that you come back in the afternoon. Make sure that you're up for tomorrow and Sunday for the hackathon. This weekend, we must think innovation. We don't want anyone to go back the same you've come. So let's have our lunch. Let's use this time. The questions that are yet to be asked, you can ask over lunch. Enjoy your lunch. Thank you, the media team. Our guests and panelists, the moderators, help them to get to the serving centers. Thank you so much. I'm told that our gadgets are safe in this room, but if you can afford to go with your gadget, you're safe. But yes, the hotel says that the gadgets are okay.
Yes, as the world evolves, so are the very many innovations that are being created. So as it evolves, so is everything to do with technology and solving the the prevailing conditions or what is transpiring apparently at the moment. Yes, we are at the ninth Medtech Hackathon that is being hosted by Mbara University of Science and Technology, Camtech Uganda, and we are doing this generally. Camtech is sponsored by First Miles and the Global Health Collaborative, and this with partnership with MUST, they are trying to empower the society with entrepreneurial capacity, how to solve the challenges that are prevailing within their nations. So today we talk innovations, we talk ideas, we talk co-creation, we talk acceleration. Yes, people have always talked, people have found solutions, but they never stop. Yeah, they never stop. So that means it is an everyday thing. Each and every day is a day of creating new ideas. Yes, some solutions have been given, but there is still a gap. Who knows? How can we solve this? These are the people that are going to solve this today. So we have found out from the different panelists that have been here. They gave their own expectations. What exactly would they want to be done? They gave it in all the four spheres, the thematic areas that I had told you earlier. These four thematic areas were on non-communicable diseases, they were on mental health, they were on road accidents, they were on the pandemics and endemics. So they were giving different ideologies and expectations. They would love the participants to come up with ideas to bridge the gap on on treatment, the treatment gaps, to bridge the gap that is on depression. Maybe if you can find an innovation that can help detect depression, if you can find an innovation that can really tell that this person is sick, or this health worker is yet to have maybe a mental disorder or a sickness, because most of the times we believe that for the health workers, they are always fine, and in case of any challenge, they can easily get signals, if I can term it like that, or they can easily know that, yes, I'm yet to get sick, because they know the signs, they know the symptoms, which is not the case. So today, I just got it. So if at all these participants could come up with such ideologies on how to manage stress, or if at all I know that anything bad is yet to happen to me, or any problem is yet to happen, and I just go on an app and I'm like, how can I solve this? So that I can get a solution before it actually occurs, then that would be the best. So that is all about innovations, that is all about new ideologies, and that is all about this clinical summit that we are here for. So starting with tomorrow up to 30th, that one will be the main session, the main pitch session. People will be pitching their own ideologies. They will be showing us the prototype that they have formulated for the different challenges that they will have presented. And all will be about thinking ideologies and talking innovations. So, talking about that, I want to bring to you one of the people that is the mind behind this great ideology of the clinical summit, of the ideas. And this is none other than he is a champion. He championed the creation of the innovations ecosystem. This is none other than Dr. Data. He will be here to tell us more about the event. You are welcome. So Dr. Data is the Uganda country director for Camtech Uganda. Hopefully that is so.
Yes.
So you are live at AET TV, that is empowering youth in technology. But to start with, what is the whole idea behind the innovations ecosystem? Innovations ecosystem? Yes.
Right. So the whole idea about innovations ecosystem in Uganda is really to prepare us to respond more decisively to the problems that affect us. Okay? Because if we are to solve our problems effectively, we are the people who have experienced these problems the longest. So we are, by the virtue that we've lived these problems, we are more likely to be able to develop the right solutions to actually solve them. Yes.
What could be some of the main challenges that really made you feel like you should champion the creation of this ecosystem?
So personally, I believe that problems that affect humans are for humans to solve. So, I mean, growing in Uganda, studying in Uganda, I've experienced quite a lot of challenges. And I thought it was high time for us to really respond to the challenges that we are experiencing in a way that goes beyond complaining about them. Yes, because if we complain about a problem, it doesn't go away. But let's change the way we look at problems, because problems are actually opportunities. Yes.
How are they opportunities?
So let's look at a common problem of hunger. So if there are many people who are hungry, it's an opportunity for the farmers to grow more food to supply. So I think the mental model for problems should change. We should look at problems as opportunities to grow, opportunities to be of value. Yes. So really the innovation ecosystem is to give a platform to be able to identify problems and see how we actually maximally benefit from the fact that there are problems.
All right, thank you so much, Dr. Data. So to come back here, what is the hackathon? What is the Medtech Hackathon to someone who has never heard of this word out there?
So the Medtech Hackathon, the word hackathon comes from two words, to hack and then to marathon.
First to hackathon.
No, it's actually from the word marathon and hackathon and a hack. So we have these problems and we want to develop solutions to these problems in a way that is fast. So we pretty much have 24 hours to go from a problem to develop an idea and actually build that idea. So it's like a marathon of the mind. Yes. Mm.
So how many people have you registered? How many people applied? And which criteria did you use to select the people that are going to participate tomorrow in the hackathon?
So we had over 400 applications from more than 5 countries.
Wow, which country?
We had applicants from Uganda, Kenya, Nigeria, Burundi, Tanzania, and this weekend, at least we've confirmed attendance from Uganda, Burundi, Kenya, and Switzerland. So 4 countries are going to be represented in this this medical technology hackathon. So how do we come up with the selection? So one, we have an application form, and once people apply, we believe that to be able to solve a problem sustainably, we need a multidisciplinary team. So one of the criteria is to be able to solve problems in health. We need people from the humanities, we need engineers, we need health workers, but also we need business people in the house, because charity does not scale, but sustainable business models that are built around solutions will have these solutions spread and go to the ends of the world.
Actually, when I just read the word medtech, I thought that this is to do with technology and medicine. I didn't know that it was just open to everyone. I don't know how maybe in your application form you are making it clear for other fields, for other sectors.
Right, so in the application form, when you fill the application form, you will know that it's really open for everyone. Because if I'm developing something that my wife, who is not a health worker, is going to benefit from, she has to have a say in it. So health affects everyone, and if you're a patient, that patient may be from the humanities, may be from health. So we need to have the potential patients even in the room to be able to say, okay, this is the experience I'm having in the what? In the hospital. How can that experience be better? Because if we don't improve the experience of the health workers, of the patients in the hospital, they are going to choose to seek for healthcare elsewhere. Yes.
Okay, so the participants are here. I heard there are 200, right?
Yes, we are going to have 200 participants.
So of the 200, what, if at all, I am the winner? Yeah. Which award do I take home, or what are they? What should we anticipate as the biggest awards that will be awarded to the winner of that day?
So there are cash awards. But I really want everyone to look beyond the cash awards, because the hackathon is just the spark. The greatest things that relate to the hackathon is what happens after the hackathon. So the cash prizes are just there to create spirit of competition. But the greatest value is what comes after the hackathon.
So are there post-hackathon benefits?
Yes. So we believe that not the best ideas necessarily get to win. We believe that the judges may make errors. So after the hackathon, we actually invite all teams to be able to work with us and start the journey of innovation with us. So we take your idea, we welcome you with your idea from the hackathon, and then we take you through this process called the CamTech pathway for innovation. And what is very surprising sometimes is that some of the teams that won in the hackathon actually quickly realize that sometimes their ideas are either not as impactful, or they may be having potential for impact, but they are not technically feasible or commercially viable. And teams that did not win sometimes come to the innovation lab and totally pivot and change their idea and end up a really successful innovation at the end of it all.
Amazing. So it has been 9 years, right? Yes. This is the 9th annual Medtech Hackathon. Have you followed up with the people that maybe made it on the in the first year, the second year, or even just the last year in the 8th CamTech Medtech Hackathon?
Right. So we follow them up. So just in a snapshot, over the last 10 years, we have technologies that are in the market now. For example, some of our technologies that have come up in use in Uganda, Kenya, Tanzania, and India. We had one of our technologies for newborn care just get approval for research deployment in Tanzania just a few months ago. And a few weeks ago, you had teams that have been working with us over the last 2 years win continentally. So there is an Africa-wide call for innovations, and that was the Africa Young Innovators in Health Awards. And for this year, out of the total 4 awards that were given out by the funders, we are so happy to actually see the announcement that 2 of those were people whose ideas were hatched from the CamTech Medical Technology Hackathons and have been part of the CamTech innovation ecosystem.
I must say congratulations and thanks for the great work.
Yeah, thank you so much.
We shall be engaging more for as long as we are still here. We are still together. See you soon and see you here.
Thank you so much.
All right, thank you so much. That has been Dr. Data, but what about some of the participants? What do they have to say? I have another participant just at the right there at the back. He also has to tell us, how is the event so far? This is the first day. What are his expectations? Yes, how are you, Jeremy?
I'm fine, thank you.
Who is Jeremy?
I'm basically biomedical engineering student. Yeah, I'm in my 4th year now. Yeah, and I'm here for the clinical summit.
Is this your first time here, or you have been here like for more than 2 times?
Actually, this is my 2nd time. Yeah, so it's my 2nd time coming for this kind of conference and waiting for the hackathon.
Okay. So exactly what has been that most, the triggers that really brought you, what were the triggers that forced you to come for this hackathon?
Yeah, personally, I'm so passionate about innovations and solving problems, basically in the biomedical sector and in the medical world in general. So every time and every year, we find challenges in the medical field, and most of these challenges are affecting those in the low and middle income countries, people are calling it low resource settings, and that is where my passion lies. So this time, I was caught by the theme of the hackathon, that is leveraging innovation to achieve equitable and sustainable healthcare. And one of the areas is non-communicable disease, which is in line with the projects I like doing.
Okay, okay. So what if you maybe you are the winner, but do you anticipate yourself to be the winner of this competition?
Actually, that's my target. It's why I came here this time round. In the previous hackathon, I got a bit of experience. I knew the do's and the don'ts. I met a wide diversity and uh, very many experienced people from different universities, and that gave me the motivation to come to this hackathon, and I look forward to being one of the winners this time round.
Wow, I wish you the best. And since you have worked with various people, that means you are very okay and free with teamwork because it has to be a team.
Yeah, I'm actually a team player. I've worked in many teams. Even at campus, we have a group of people and we help other students do their projects. So it's a really diverse team of people.
Okay, okay. Thank you so much, Jeremy. And all the best.
Thank you so much.
Yes, it is actually lunchtime. That is why you see maybe most of the people are not around, but they just went out to have their lunch and then finally come back so that we can proceed with this great hackathon, which is focused on leveraging innovations to achieve sustainable and equitable healthcare. Healthcare is broad, but just stay on to know more from the experts, from the facilitators, from the mentors, because it is day one, but a lot has to be said today so that we can prepare for the 48 hours tomorrow. I cannot wait for tomorrow.
before we receive closing remarks from the Program Director, Global Health Collaborative, and the Camtech Country Manager. So let's take this opportunity and invite Martin to take us through the next session. Martin is one of those engines behind Camtech. Let's celebrate him. Let's give him a hand clap.
Thank you so much, Dr. Peter. Good afternoon, everyone. You're sounding like you didn't have lunch. Good afternoon, everyone. So the afternoon session is going to be an interesting one. Yeah? We are going to learn about user-centered design thinking, yeah, which is the process that we use in the lab to actually come up with most of our innovations. So it's a very key component to really building very powerful innovations. And I want to introduce the team that I'll be having. You can please come forward, the team that I'll be working with to make sure this is a success this afternoon. Okay, I'll give them an opportunity to introduce themselves before we start, and then I'll walk you through the agenda that we are going to follow. Let me start with my left.
Good afternoon to you all. My name is Nambogo Noriat. I work with Camtech as the Research and Grants Manager and also coordinating the program activities. So I'm happy to be here and thank you so much for coming.
Thank you, Noriat.
Good afternoon, everyone. Protocol observed. Assistant Inspector of Police, Arinito Christine. I'm the OC Traffic, Kashaka, Busheng, Mbarara Road, and then I'm a dedicated traffic officer. I want to thank you and thank the organizers of this clinics summit for having thought of Uganda Police and me in particular to come and share with these important people. Thank you so much.
Thank you so much. So you can please take a seat. So we're going to start by grouping ourselves, okay? Because this session is going to be practical. And the challenges that we are going to be addressing are geared around traffic accidents. So we want groups of 10 people. How fast can we do it? We just do a count? Okay. So we are going to start from here. So 1 up to 10, then when we reach 10, we again go 1, okay?
1, 2, 3, 4, 5, 6, 7, 8.
Okay. So this is 1. Four. Okay. You're 4. Number 4. So 10. Madam Annette. 4. 7. Okay. Let's sit in our groups. So group 1 can sit around here. Group 2, yeah? So members of group 1, please come to this table. The last group will have about 7 people. So group 1, group 2, group 3, group 4. So let's have 5 groups on this side, okay? Then the other 5 on this side. So starting from group 6, we should have them this side. Okay. So all the ones should come here. If you're in group 1, come here. Okay? So if you're in group 2, join this group. Group 2 should be here. Group 2. Group 2 members, join this group. So group 3. Where are people of group 4? So, join here. No, 5 can be the last one here. Hello. Good to see you. So group 5. Let's have group 5 here. Group 5 here. Let's have group 6 this side. Group 6. If you're in group 6, they had shifted there. Okay. 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 Where is group 6? Members of group 6? Where? Okay, you come and sit here. So group 7, you'll be here. Here. So group 6. Let's first organize ourselves. So group 6 here. So where's group 7? Is this group 7? So group 8 here. Group 8. Hey. So where's group 7? Where's 7? So 8, you're there. So you organize yourselves well. You do a circle so that we identify you with ease. So group 9, you're 8. 8, so use this space. So group 9, where's group 9? This is 10. Okay. So 9. Group 10. 10 is here. So you can look for a seat and join them. All right, let's settle down very fast. So there are some people that came in late that have no groups. By show of hands, if you have no group, we stopped at 7, so you're 8. You join group 8. Which other person has no group? You had assigned yourself. Now I'm assigning you to 9. Please join 9. So you're 10. Join group 10. Join group 1. Group 1 is here. Who else has no group? Who else has no group? Oh. So, Nuriat is going to help me give you sticky notes, enough sticky notes for each group, okay? And what is going to happen next, we are going to have the police official give us a talk about road accidents, okay? And as she gives her talk, make sure you note all the challenges, okay? You discuss them as a group and you pick the best challenge that you want to address, okay? After her talk, we shall do another presentation on design thinking and then let you work. You'll work for about 20 minutes and do a presentation. So make sure you're attentive as she's giving her talk. Is that okay? So allow me invite the AIP to give her talk on road traffic accidents. And you can applaud her as she takes over the floor. Thank you.
Thank you so much, Martin. For the interest of time, I had already introduced myself, so I will not repeat that, but still my name is on my chest. So, we can proceed. I will take you through the traffic road accidents. One, we have to know what is an accident. An accident is any unintended occurrence or happening that can result into death, can result into bodily injury or damage of property. That is an accident. These accidents have got effects or the results. What happens? What are the outcomes? What happens in the case of an accident? One, we have physical effects. Those are effects, like I told you, that affect a human being. Let's say you have lost a dear one, that one has died. Then you can get a permanent injury, or you can get disabled. And then the property can get damaged. We group these accidents into three. We have fatal accidents, that is where we lose lives. If a life is lost, then that is fatal accident. We have serious accidents, that is when a human being is injured but has not died. Then we have minor accidents. This is a damaged property. For example, a car to a car, that is minor accident. Even if it is an animal to a car, it is minor. Some people have called us, there is a fatal accident. When you reach there, you find it is an animal, a cow, and a vehicle. So that one is not a fatal accident, that one is minor accident, because no life has gone. I mean, like we talk about human beings. So animals, they are different from human beings. And then we call that one minor accident. I talked about the effects and what happens in case of an accident. We have emotional effects. Let's say, of recent, we witnessed a certain scenario where a parent was driving, man was driving his family, the wife died, the child died, and he remained alone. He was the only one who survived in that accident. So just imagine that torture, that stress. It will remain in you, and this is what they talked about. It is actually a mental disorder. It can result into a mental disorder. Because losing a dear one, you witness an accident, just imagine that trauma. You're traveling with someone, you've been chatting, and all of a sudden, this person is gone and you remain. So those are negative impacts, and they can result into emotional or mental disorder. Then there is economical factors, effects. When I talk of economical effects, you who work in the hospitals, you're my witnesses. In the hospital, we bring victims of accident, we bring dead bodies, and those ones, it is not just working on them, you have to spend on them. The government spends a lot of money on those people, it spends a lot of money on the properties damaged. Say if it's a road, guard, it is damaged, the government will have to come and replace it. So those are economical effects. And recently, the accidents have gone high. The number of accidents reported have gone high. The lives have been lost. We have seen people getting injured, people losing their backbones, losing their bones. So we have gotten such incidents, and therefore accidents are on rise in our country, and that's why this summit of innovators, with time we shall look for way forward, possible ways how best we can reduce these accidents. And then we go to causes. What causes these accidents? The first one is there are very many, but they are human errors. When I talk of human errors, I talk of overdriving, overspeeding. You're having a car, you're driving beyond the prescribed speed limit. If you ask me about prescribed speed limit, I'll tell you that in Uganda, we drive at 80 kilometers per hour. It is known, it is by law. And then those who drive beyond, those ones are driving beyond the prescribed speed limits. We have other places where we have the speed limits signs. You find like a signpost, it is indicated 60. It is in red. For you, you are now driving 80. So that is beyond the prescribed speed limit. So overspeeding has caused accidents on our roads in Uganda. And then we have mental disorders, like they said. Mental disorder, when someone is, the brain is not settled, that means this person will not be safe on road. Say you have come from home, your wife is sick, you have quarreled with your wife, you've quarreled with your daughter, your husband. So what do you expect on road? That means you're not mentally upright and anything can happen. You can cause an accident because the mind is not settled. So those are mental disorders that can result into accidents. And then we have very many causes, as I talked about, human errors, and we have drink driving. People drink and drive. We are not saying you should not drink. You can drink alcohol, but you cannot drive when you're drunk. A vehicle needs a sober mind. So the moment you mix your mind with alcohol, then that means you're not sober, and these are the causes of accidents. We have witnessed many of them. People drink from the bar to the steering. As you reach the steering, your minds are different, you divert. So, and then you end up either losing your life or lives of others, or you injure yourself or injure others. And then we have dangerous mechanical condition of our motor vehicles and motorcycles. You're driving your vehicle, there is no oil in it, there is no water, the tires are like watermelon you get. You see that your vehicle is not in good condition to be on road, but you still drive it. What do you expect? You expect to be involved in an accident. And like I said, an accident can be fatal, can be serious, can be minor, but all those are accidents. So vehicles being in dangerous mechanical condition can result into accidents. Then distracted driving. Here we have a challenge. People, they carry children. Someone carries a kid and drives. Very well. He thinks what he's doing is very okay. The madam, what she's doing is very okay. So you find you're driving when you're having a child and the same steering. What do you expect? It will cause an accident. The child is too young. The child cannot decide for you. You are supposed to concentrate on driving. So when you bring in a child and then a child sits next to you or whatever, this distracts driving and you end up getting involved in an accident. We still have, like in distracted driving, we have people who engage on phones. You're on phone, and I think it is very common here in Mbarara. People drive as they are on phone, others are WhatsApping. Someone is busy on WhatsApp and is driving. You really see this person is likely to get a problem. So at the end of it all, this person gets involved in an accident. Then we have people who drive while eating. You are eating. You have your biscuit. People, when you ask, why are you driving while you're eating? I don't have time. I am just here. I'm rushing. I'm late. So I have to eat as I drive. That is very wrong. We're supposed to drive as we eat. So that is another cause of an accident. Then we have careless driving or reckless. You are overtaking in a corner. Others, they don't know the road marks. They don't know. There are lines. Find this line means you overtake. The other one you don't overtake. But someone, because we have automatic vehicles, someone can accelerate and drive, then he drives without due care of other road users. And this has caused accidents. Blind corners. You overtake in a blind corner. You're not seeing where you're going. You're not making use of your mirrors. You see? You are just standing from nowhere. And if we take an example of our city here, people are not using indicators. And if they use them, a border will not see. We just come and knock you. Now, what is the use of this indicator? You have all the parts on your vehicle. You should know that an indicator means this. The headlamps are for this. Every part of your vehicle must be functioning, and you must know what it does, its function. Then people are not aware of highway code. Highway code. People are not aware. What is highway code? People are not aware. These are guiding laws that help you to drive safely on road. Like they say, fasten your belt before you set off. Someone wants to fasten the belt after 3 kilometers. So these belts are supposed to be fastened before you set off. Before you switch on the engine, first fasten your belt, and then proceed for the journey. And then there are very many causes. Others are infrastructure, road infrastructures. You find the roads are not in good condition. The potholes are too many. You find actually there is a problem whereby even some engineers, the marking of the road was not professional. So the infrastructure has also contributed towards the accidents in our country, in Uganda. And then I go direct to the work of innovation. What do we have to do as innovators? We have challenges whereby we get accident victims. Accident victims say they are in Kashaka, but to get a vehicle to reach there is an issue. So as innovators, we can look for a way forward. We can see how best we can help here. And maybe say, let's advocate for this, and let's have an emergency or a response team that can work on this. Some victims are injured on the way to the hospital. They just get injured more just because the ones handling them, they don't know the first aid, they don't know how to handle the victims. So someone is injured, maybe the arm, but in the due course of taking this person to the hospital, you injure him the more. And this has happened because like in Uganda police, we are not very many. So when an accident happens, the person who comes first is a civilian. is this person, at least for us in the police, we are trained first aid, but there are these other persons. So like innovators, we can equip these people and say, maybe every stage or whatever we identify some black spots and say, at least let there be this so that it can help in case of an emergency, in case of an accident. That will be our work as innovators. Then we can also intensify on community policing. We can go on ground and talk to people, invite people for workshops, teach them, tell them, train them, and that will be of great purpose. You will be saving life because we are saving lives of very many Ugandans, and which is a global concern. Then we can improve, like I told you, on emergency response and enhance post-accident care. In case of an accident has happened, which care have you given? So we can do that. We can enhance on that as innovators. Then we look at ways of reducing accidents. We look at road safety awareness. This can be done by all of us, by police, by all the stakeholders, us who are here inclusive. We look at being careful as we drive. We make use of our parts on the motor vehicles. The parts, I mean, side mirrors. As they drive when the side mirrors are folded. You'll find someone is driving right from Kampala to Mbarara and he does not know that the side mirror is not in the right position. Honestly, let's look at that and let's take the gospel outside there so that the accidents can be reduced or can save the lives of very many Ugandans. I know as we are here, majority of us, if not all of us, we have been affected. Our relatives, our friends, our OBs and OGs, our readers or what, in one way or the other, the accident has affected you. So we need to all come in and do what it takes to make sure we reduce accidents, or we can even fight them. And then we develop a smart helmet for two-wheel riders. The riders, those are motorcyclists. Smart helmets. Let them put on helmets. As innovators, we can say, let's look around and get helmets and give these people so that we can do what? We can avoid accidents or can reduce them. And then we look at, of course, this one is also part of, I think we can do it as innovators, enhancing road design and construction. You know, some zebra crossing, those ones are faded. We can go and innovate and paint the zebra crossing and the like. So, as innovators, I do call upon you to join hand and do what it takes to make sure we reduce the accidents or we fight them in our country. And then, lastly, I want still to encourage and emphasize that the battle against road accidents is a shared responsibility. Don't look at a police officer and say, Christine, where is Christine? She's there. Let me drive slowly. After the checkpoint, I will increase the speed. No, be responsible. Don't leave the work for police. Don't drive a police officer. If a police officer is not there, you go on indicating, are they there? If they are not there, then you'll drive the way you want. No, that is not right. Let us share the responsibility. We all do what we're supposed to do. And I do believe that this team that is here, the innovators team, will do what it takes to make sure the lives are saved. I thank you for giving this opportunity and having interacted with you. Thank you.
All right. Thank you so much, Fande Arinitwe. Let's applaud her again. So we are going to take the next 5 minutes to look at a presentation on design thinking. I know Afande has talked about a couple of challenges, but you as a group, when that time comes, you need to pick a challenge that you want to focus on and apply some design thinking to it, okay? And then we'll be picking on different teams to do a presentation. Is that okay? Is that okay? You don't sound sure. All right. You. All right. So, by way of introduction, my name is Martin Mukama. I serve in Camtech Uganda as the Innovations Lab Manager. So, I'll be talking about design thinking. There are two simple English words, design and thinking. Yeah? What do you think they mean? Just by show of hands, if you want to give it a shot. Simple English words, design thinking. No one wants to try? All right.
Think as you design.
He has just interchanged the words. Okay, let's proceed. So, design thinking is about, you're thinking about the design you want to create for your innovation, but it has a process, yeah? You don't just start by thinking about the design. There are a couple of things that you go through before you arrive on what you want to do, okay? And there are several reasons why we do design thinking. One of them is that it offers you a systematic approach for delivering innovation, as we shall see from this presentation. You can also be in position to create product specifications that are very clear, yeah, when you follow the design thinking processes. You can also identify opportunities. Actually, when we are doing design thinking, sometimes you might not know all the possible causes, yeah, but when you start the process, there are some things that we call latent that you cannot see. Yeah, but when you're doing your research, you can be in position to observe them. Even when you talk to the people facing the problem, they might not tell them to you. But when you're doing your processes, you can be in position to catch those bits. You can be in position to identify customer needs and user groups with ease. And you can also be in position to understand the entire design thinking process. All right. So there are three dimensions that we look at when you're thinking about the design. One, the first dimension is called the people dimension. You know, when you're designing these things, when you're developing these things, you're developing for people, isn't it? Yeah? So we think about the people first because they're the ones facing the challenge. And you want to understand how people are facing these challenges. Because at the end of the day, if you do a product which is not solving the people's needs, then you'll probably use it yourself, isn't it? Because you're not solving the need of anyone, okay? So that's the first dimension, and it's an important dimension. Because when we are looking at innovations that have commercial viability, people are very important. Because for as long as you have built it for people, then it becomes very easy. Because I'll need it, so I have to pay for it, okay? So that's the first dimension that you look at. The second dimension is the technical dimension. So now that you know what people are facing, you know how to solve it. Can you be in position to do it with feasibility? Some people tend to do things that are not feasible. You're trying to create an innovation, but you're taking more than 5 years before it comes onto the market. And someone who is very clever and smart, they do it in about 8 months, they launch it into the market, and they take all the money. Okay? So as you're thinking about the things to build, make sure they are technically feasible. That's the second dimension. Now, the last dimension, and it's the most important one, by the way, unless if you're developing for charity, yeah? The business dimension. So once you've thought about the problem and you know what people are facing, you can be in position to build it. The next thing is how do you make money out of it? So you have to position yourself to be in position to make money out of the work that you have done. And the three dimensions actually encompass what we call innovation, isn't it? So when you're innovating, you're thinking about people, you're doing something that is technically feasible, and something that has a what? A business model behind, yeah? That is all around innovation. All right, so the phases of design thinking. The first phase is the exploration phase, and that's what we are going to concentrate on today. Yeah? First, you have to first explore. Some people tend to start with the solution. Even when they are pitching, they want to do a solution first, then they align it to the problem before understanding what problems people are facing. Okay? So the exploration phase is an important phase because it helps you to identify different things that people are facing, the challenges which people are facing, the solutions that are actually in the market that are not solving the needs of the people, and then you can be in position to understand how you can position yourself very well and build an innovation that people will want. The second one is the creation phase, and that's where we start brainstorming and trying to put things together based on the what? On the challenges, on the things that we picked from the exploration phase, okay? And the last phase is the implementation, which will be so fun actually if you consider phase 1 and phase 2. If you pay a lot of attention to it, implementation will become so easy. Because we will find that there is a lot of willingness from people who are going to take up your innovation because you talked to them from phase 1 and phase 2. Okay? All right, you can move to the next slide. Next one. You just go all the way down. Go down, you keep going down. Go down. Go down. All right, so we are going to focus on the exploration phase. And I'm going to request Nuriat and Mackenzie, I'd seen Mackenzie around, to distribute the questions that we are going to focus on, okay? We don't want to think about the solutions today. We want to be in position to see how you actually explore the problems. Are there any questions before I proceed? Questions? Is it interesting? How have you been doing it? You start with the solution and you align it to the problem. All right, so we are going to take the next 15 minutes. We have tried to expound on some of these questions that we have listed here. So we are going to take the next 15 minutes to work in our groups, okay? And be in position to talk about the challenge that you have chosen to address, yeah, and align it with all those questions. And after 15 minutes, we shall be picking on any group, because we know that you're done. Be picking on any group to come and do a presentation. So you have the flip charts, you have the markers. So start thinking about your design. So we have 15 minutes, and after 15 minutes, presentations will commence. Thank you.
Still on the event, still on talking innovations, still on talking ideas and recreating solutions, recreating ideas to solve the challenges that are transpiring within our communities. We are at Silverback Hotel, and as the participants are taking part in different activities because they have been engaged in groups, they are discussing about road safety, road accidents, the effects, and they gave them a question to do with design thinking. What do they think would be the best solution for such challenges? They have a lot to say because I see them, they are thinking, they are thinking in groups. They all have to come out with different ideas. Maybe, who knows, some of the groups will come with very similar ideas because after all, it is the same challenge. But what about the lady here? What does she have to say? Because she took the people into the session of road accidents. So she has to also tell us something very small so that we get to know more and more from the source. Yes, hello, good afternoon.
Good afternoon, madam. How are you?
I'm fine. We are live at ATT.
Thank you.
So I would like you to introduce yourself to the viewers, the people that are seeing you, so that they get to know you, the whole profile.
I am Assistant Inspector of Police, Arenito Christine. I'm the OC Traffic Kashaka, that is in Mbarara, Bushenyi Road. Yeah, and we're here for this great cause, for this summit, of clinical summit, to talk about innovation, and my part was on road accidents. Yeah, we've shared with the participants, and we are looking for ways of reducing road accidents. The best input innovators can put in so that we can reduce road accidents.
What do you think people can do, especially like our innovators, in integrating technology into the road safety, maybe rules and regulations? If I can tell you.
Yes, the innovators here can can as well come in. For example, if we improve on technology, if we are our vehicles, the motor vehicles we drive, they use it to have speed gun, speedometer. Yeah, now they don't have speed governors. So the innovators can come in and then we still talk about that technology so that we can reduce accidents, most especially those accidents that are brought about by overspeeding.
Okay, previously we used to have accidents, and we have seen you as a team. You've tried to control accidents on the road, but we are still having a very big percentage of accidents happening annually. What do you think could be the major cause apart from what you are telling us here before?
Yes, the major cause is human error. people are not minding about driving, they are making mistakes. For example, if someone drives when he's drunk, that is a human error. So human errors are the major causes of accidents. And for us police, we are trying. And secondly, people have left the work with police. It is only police to do this, to protect people against accidents. The other stakeholders have not come in to play their part.
So everyone, it should be like teamwork, and everyone should be knowing what to do and how to do.
Everyone should be involved, and then we fight against road accidents.
Indeed, that is true. Thank you so much. Road accidents are there. They have been there. But how different can we be? How different can we be? What can we do to make sure that they really reduce, or we exclude them completely and we live in a world that is free from accidents? What about the ladies here and the gentlemen? What do they have to say? I could talk to one of the ladies here. She could also tell me, have you? Hello, how are you?
I'm fine, thank you.
We are live at AET TV.
Okay, I'm humbled to be here. You're talking to Bob Ramtaire.
What do you have to say about today's clinical summit?
Actually, this is my first time and I'm humbled to be here. I can say it's an opportunity for me to be here because I'm passionate about mental health. So the discussant that talked about mental health really touched my idea. I've been doing most of the things manually, not being innovative, but whenever they were talking about the things that we should do, so far I have very many ideas, innovative ideas. So trust me, by the time I leave this place, I will be having great innovative ideas. I will have developed something that is going to help people there in Chana Mkaka, deep down in the village, because you see mental health affects all of us. But most people who are benefiting, who can access services, are the people in town, Mbara town, for example, Mbara city. But how about someone who is in, with where deep down there? They're going through the same challenges, but they don't know how to solve them. So I believe this is a great opportunity for me, and I'm happy for Must and Camtech as well for this great opportunity, because we are not paying, it's free of charge, and I'm getting ideas and knowledge for free of charge.
Okay, we are getting knowledge. And you said you have very many ideas that you have been thinking about. Do you mind sharing them, or you do not want to share them?
No, it's okay. I can share because I'm looking at the founder of Okara Mental Health Services, and I've been looking at youth being affected mostly when it comes to mental health. And I've been thinking of having discussions like clubs in schools. We have interact clubs, we have got different clubs in schools. So I realized that mental health has also to have a club in schools. So far I've done most of the clubs in Orengo district. I've started Shema district, but I realized I can't visit all the schools. So this innovative clinic summit has really opened my eyes that I should do something whereby even if I don't go to Gulu University, for example, how are universities going to benefit from Okara, what Okara does? So far, I'm not going to share what I'm going to do, but that's what I had in plan of forming clubs, which I did. I started already last year, and they are working, but I noticed I'm not giving it, like it's one region, yet mental health is affecting all of us in different regions. Yeah, so really, that one, really grateful, and you wait for it. You're going to hear, hopefully you're going to be here till...
I'm here.
All right.
I'm waiting for you. All the best. So, I could talk to also one of the other people, maybe a gentleman this time around. They could tell us how they are faring. Can I talk to you? Hello.
Hi.
Hi.
I'm alright, thank you.
How is the hackathon so far?
Yeah, it's so far going on well, and we're really meeting our expectations, and we like the way people team up, and the whole environment is so conducive, and everyone is jolly and so welcoming.
So tell me, how did you apply for this?
I applied for this. Well, I got a flyer, which was advertising for the hackathon, so I had to wait for the actually, I got a flyer for last year's hackathon, but it was late. Then I had to wait for this very time, and I was really on time. I had to apply before the deadline. I applied, I just placed there my problem statement, It was kind of simple, but it really worked out, and I was so excited that I was selected among the people who are going to participate in this hackathon.
So apart from being excited, which other feeling do you feel like? Do you feel like a winner already?
Well, I feel like a winner, but the winning does not only belong to me, it belongs to a team.
It belongs to a team, and I believe
The people to whom, like people who are going to benefit from these innovations or the prototypes.
okay. So you've been working in groups even before?
No, I'm just going to get my groups from here, but I believe with all this guidance, we are going to get the best groups and we are going to really hack and come up with the best prototypes.
How free can you just jump onto a new idea and adopt it and manage it as though it is your own? Now, for example, when you're going to get a group, I have a feeling maybe you could take up a new idea. So how do you get into that and adopt it?
Well, first of all, it depends on the group and the like the teamwork in that group, and also the problem that we are going to solve. Of course, you shall have to start with a different ideas, then we do down selection where we come up with one single idea that we're going to solve, and perhaps if it's familiar, maybe if it's familiar to my field of study, then I'll be a star in that team. Maybe I'll have to contribute a lot in that team, and I just believe it's going to be easy to adopt to that group and the whole innovation.
Okay. Are you from Must?
No, I'm not from Must. I'm from KIU Western.
You're from KIU.
KIU Western. I do Bachelor of Science in Civil Engineering.
I wish you the best. I have been seeing Nita.
Our PR person.
His name is Nathan. Okay. Nathan, to start with, what is Nita Uganda?
NITA Uganda is a government entity that is responsible for IT in government, IT services and infrastructure. So we offer support to government entities and in all different ways relating to IT. Yeah.
So what brings you for the hackathon? Are you in a competition or you are partners or you I saw your partners, right? But you also have to compete or you are here as partners?
We are here to support the hackathon. We're with Camtech. We're excited to be here and we are looking forward to a fruitful engagement in the period of the hackathon.
Okay. Apart from that, leveraging innovations for equitable and sustainable healthcare, what does it speak to you?
It speaks to the opportunities that is available through the different innovation. We look forward to seeing the new tech solutions that the young people are coming up with in order so that we can see where we can come in as a government entity. We are so big on innovation. We like innovation. We want to support innovation. So we are here to see and also to be part of this amazing journey of seeing the young people build solutions that can sustainably help improve the healthcare services in the country.
All right, thank you so much. I can let you do your work. As I also proceed, I see very many people, they are just focusing on exactly what they were asked to do, and that is creating a design thinking or a solution for the road accidents. Accidents. Way back in January, I think from December to January, it was overwhelming. There were accidents each and every day, and actually just got to my mind and I was like, oh. Every time I used to travel, I would be like, God lead, because it had become like a song. It was an anthem, accidents everywhere. But then today, we have very many people here who are ready to find new solutions. having people from all over the world. It is a global event, and they are all here just for a competition, which is the Camtech Uganda Medtech Hackathon. We've been talking to the participants. We have talked to one of the facilitators. We've talked to the person from the police. We've talked to the organizers. But what about the mentors? What do they have to say? Yes, each and every group that will be selected tomorrow, yes, people will be grouped in their teams, and then they can start on with designing prototypes and also finding solutions and stuff like that. But then every team has a mentor. And this brings me to one of the mentors here. I can say hello to him. Hello. He seems to be so busy, but I will get to him, and he will be telling us, as the mentor, what are the health challenges that really that have been a driving force for this hackathon, and how are they going to find solutions to these challenges. He will be telling us more and more. I see many people in the building, but I will be talking to one by one. As the mentor gets ready, I will be taking you through to some of the other people. They can also speak to us. Hello.
Yes.
We are live at TV.
Yes. Bosco Triamereba, Camtech Uganda.
Okay. So Camtech Uganda, what has been your driving force to this event? That is the Medtech Hackathon.
Our driving force is definitely to come up with new solutions for the challenges we are facing in health. And as Camtech, that's our pride. See young innovators coming up with good ideas that can be put into practice and address the key challenges. As you know, our health system has very many challenges. So we know that the young brains have the capacity to think beyond the current solutions.
But what are these main key health challenges that we are talking about?
We are talking of now the traffic accidents. We are talking of mental health challenges, which are increasing day by day. We are talking of upcoming pandemics in our health care system. So we believe that by the end of this hackathon, we should be able to have good solutions. Yes.
And we pray it be so, as you say. So I want to know, what is the solution that can help me notice that there is an accident ahead so that I do not drive so fast? Or how can I know that an accident is yet to happen so that I can secure myself even before I start the journey? We are at AET TV. Keep on. We are still here.
So shall take a total of 30 minutes to run through everyone. Okay? One presenter, but the whole group can be represented. Group 3, please start coming forward. Are you going to time? Are you going to time for me? Let me first take a picture of the groups. Wait. I want to take a picture. Yeah.
time won't be enough. Someone will, yes, someone will be illustrating. So maybe leave this one for me here. I have to use it. Someone should be illustrating.
Okay. Let us listen to our first group. They're having only 3 minutes to present. I am the timekeeper. When the 3 minutes are done, I'll clap them off. And you join me in the clapping. Okay. So the floor is yours.
Okay. Good afternoon, everyone. This is Group 3. My name is Baja Uthman. I'm a fourth-year nursing student at Mbara University of Science and Technology. So our problem is dangerous mechanical conditions. And then, why does the problem exist? There are a number of reasons as to why the problem is there. One being financial constraints. Some people are unable to take their vehicles for repair. Then there is ignorance. There are people who never mind about that regular checkup of their vehicles every morning before they take them on the roads. Then still inappropriate operation of these vehicles. There are people who are unable to drive, and in the process, or those who are in the learning stages, there is certain information they are unaware of. Then how has the problem been solved? So there are some traffic checkups that have always been there to check on these vehicles to see their functionality. And then some awareness has been done on TVs and radios, encouraging people to check their vehicles before they drive. And then there are some mechanical checkpoints that were put, but still they were not effective. Then how have those solutions worked? Yeah, these solutions have fairly worked. However, there are a number of reasons as to why they have not fully worked. One being corruption, and then language barrier, and then for the language barrier comes in the creating of awareness. Not everyone understands English, so you may find that these adverts for awareness that were created, some people are unable to understand this. So what needs to be done is, as we are making these awarenesses, we need to consider a number of factors. One being the groups we are addressing the information to. So we can consider the language bit of it, maybe putting it in local languages as we are advertising. Then the laws are there as far as these mechanical conditions are concerned, so they should just be improved. Maybe more action should be taken. And then using of CCTV cameras on the roads to detect them. Thank you.
Time is up. Let's have one question for them, then they can leave the stage. Do you have any questions? Okay, can we give them a big hand clap again? Thank you. The second team is Group 5. Let's have an innovator's walk. You have 3 minutes to present.
Okay, thank you so much. This is Group 5. The problem we identified is increased physical disabilities. And we say that these disabilities are caused by very many factors. But answering number 2, we saw that among them we have increased road or traffic accidents. And this goes to all road users, the motorists, the vehicle users, the pedestrians, the cyclists, and every other person who uses the roads. And then under the measures that have been put in place, we have seen the government putting road signs, we have road marks, we have traffic officers and traffic posts along these highways. We have laws that have been put across to make sure that road users move safely. But then, how have they helped? We are seeing that they have indeed helped to direct these road users on actions to take. However, we see that the level of adherence has been very low because we still have people driving while they are drunk, motorists are riding without wearing their helmets, people are crossing roads very carelessly. So we see that the adherence is very low. And what do we think should be changed about this? We think that there should be more sensitization campaigns in our local communities. We want smart helmets for motor riders, and we make sure that they have awareness on how to use these helmets, because these days we see I was saying that these days motor riders do not want to use their helmets because they find it uncomfortable. So you find that their lives are at risk and the lives of the people they are carrying. So we are saying that there should be more awareness campaigns to these riders to make sure that they know the importance of using these helmets. Thank you.
Any questions for Team 5? Okay, let's clap them off the stage. Thank you. The next group is, please come forward. Group 6. You know it's not easy to present. Can we clap for them as they walk to the front? Okay. This group, Okay.
Hello, everyone. I'm Leo Kinyera, doing biomedical engineering at MUST. So as Group 6, the problem that we discovered was the lack of quick emergency response mechanisms at the site of accidents. Now, where does this problem exist? There is lack of awareness and training of the public on who to call in case of any emergency. And then also there is lack of a proper communication infrastructure. And then there is also uncoordinated and collaboration in terms of the governments around, the local governments and the people around that. So now, how has the problem been solved? We've had information going to the wrong people, especially when the first people who see the accidents that have happened, they tend to call the wrong people instead of calling the right people like the police and the hospitals. And then there is uncoordinated attempts to save victims, especially for people who just tend to carry victims whom they think that are badly off, yet there are other guys who have internal bleeding, and those are the people who are left there and they die. So how has this solution worked? These approaches really have not been systemic and therefore have not solved the problem. We lose lives in the system of doing that. So what needs to change? The poor response emergency mechanism needs to change to a more focused and quick response. Thank you very much.
A very big hand clap. Any questions? Any questions? Okay, let's clap them off the stage. Thank you. My microphone. Next group, Group 10, please walk forward. Can we clap for them as they come to the stage? Yes. You have 3 minutes.
Good evening, everyone. So this is Group 10, and our problem was delayed response time. And why the problem exists is that because of the poor road networks. And anyway, when someone is going to attend to someone with an accident and the roads are rugged, like it also delays their response time. Then lack of proper communication channels. People at the road, people at the accident area will usually lack the right people to call, and irresponsibility, negligence of the community. For example, recently, if you all see news on Twitter, there was an accident and everyone was passing this person instead of helping them out. And then the late night accidents especially, you will not call a traffic officer when they are sleeping. Most of them might not respond. And then the lack of first aid skills in the community. People are not skilled about how to give the quick first aid to these people on the accidents. Yeah, so, and then how has the problem been solved? There is an ambulance system, but this is really centralized in Kampala and we don't see it in Barra. Yeah, and then there are traffic police has been digitalized, like tracking speed and all that. And then how has the solution worked? Calls to the traffic polices, maybe these have increased because of the digitalization of them. And then the calls to the ambulances, which are, okay, these are working in central places and not in the places like this side. Then what needs to change? We need to decentralize our systems and make them, yes, decentralized and then skilling the community. People need to learn how to give those initial things, the first aid, and not be scared about them. Then the numbers of the specific traffic police should be really in all places. Yes, thank you.
Let's have the next group. Please walk forward. We clap for them as they come to the stage. That is group 8. Group 1, okay. Three minutes. Yeah.
Thank you. Well, the problem we figured out was drunk driving. You know, these border riders at night, they be drinking while they're driving. These taxi drivers, sometimes they drink while they're driving. And why are they drinking while driving? Firstly, some of them are having stress, so they believe by drinking, the stress will disappear. Some of them are just careless. They don't care about their bodies, about the people they are driving, you know. We are also having the issue of corruption. You are caught drinking, you are in fact drunk, but you pay the officer, you go. We are having peer pressure. 6 people are in a car and someone comes up with an idea, let's buy some drinks while we drive. And yes, false confidence, people be like, well, I've drunk a little, I can drive. You know, they end up crashing, killing people. Inadequate enforcement, well, when these patrols are on the streets, at a specific time they leave. And these drivers usually have communication, like taxi drivers, they can communicate to the other through the lights, there is no one there. Someone proceeds with drinking. And the solutions, firstly, we are having the traffic patrols. These guys leave at some time in the night. Awareness campaigns, okay. They are trying, but, you know, people are still big-headed. We have the breathalyzers where you blow, but these people pay and they bypass, they leave the traffic and they continue. The strict legal penalties, okay, I could be having a friend who is maybe he's in CMI, I just call him and he orders the officer, let him go, and I'll leave. How have the solutions worked? Yes, well, to a less extent. Yeah, and what needs to change? Firstly, we need to increase penalties on these offenders. Have you been caught drinking? Instead of paying 150K, you pay 300K. So next time you'll be afraid to drink while driving. More sobriety checkpoints, as I told you, these traffic officers leave at some point in the night. So there should be more checkpoints to counter the issue. Ignition interlock devices, have you been caught a victim of drunken driving? This machine, once put in the car, while you ignite your car, you first blow into the machine, then it will give you a go-ahead literally it will let the car to ignite, to start up. If you are drunk, the car won't start up literally. You'll remain there. Ride-sharing services, we are having the Ubers. For example, you can call the Uber driver, he picks you up, the guy takes you home. Community partnerships, let's say there was a party here, people have been drinking, it's like 10 p.m., maybe the LC of the area can call the police, inform them there are drunkards here, people are drinking, they are having vehicles here, and maybe the police can intervene to counter the issue. And lastly, designated drivers. You've gone to the bar as a group. You've gone to the bar as a group. Look for someone who is not drinking, he will drive.
You will drive. Thank you. Okay. Sorry about it was a joke. Thank you so much. Let's have the next group. Please come forward. Group 4. Group 4, group 4, group 4, group 4. Okay.
Good afternoon. This is group 4. The problem we identified is fatal accidents due to border. Yes, and why does the problem exist? Majorly lack of protective gears and also lack of driving permit and riding skill, lack of driving and riding skills, and also knowledge and experience, but also mental illness. We also said human errors, especially overspeeding, and also distracted driving, and also lack of knowledge on highway code. And how has the problem been solved before? Before, we've seen the use of helmets emphasized, and the use of late, there was an introduction of reflective jackets and also heavy fines. How have the solution worked? Yes, in a few blind spots, accidents have been reduced because of those reflectors. However, people are still not wearing helmets, and even the ones who wear are still at risk of fatal accidents because the helmets protect from head injury, but it doesn't protect from spinal injury, which is equally severe. So what needs to change? We thought that we have helmets to alert users that maybe they're over driving, and then also helmets that protect both the head, the neck, and the spine, and also enforcement for wearing these helmets. I thank you for listening.
Group 2, please come forward.
All right, thank you. This is group 3 and group 2. And our problem is using phones while driving and distracted driving. Yeah. And the main cause of the problem is ignorance. Some people just don't care, in that they feel it's okay to use their phones while driving. They feel they have enough data to use to TikTok, to reply WhatsApp messages, and others are just proud. They are just proud because they feel they can multitask while driving. They feel they can do anything, 2 tasks more than once, and divide the concentration of driving and chats. And then our third problem was some people really have many responsibilities. You find you have a Zoom meeting and you're still driving. Maybe you hadn't even prepared your children back to go to school, and then you just have to attend the meeting, and it is an option. So how the problem has been solved? There's been setting up and implementing of traffic laws, and then sensitization through media or social media platforms, yeah? And how the solutions have worked, I would say they have fairly worked, because we are still seeing people stop doing what they are restricted from doing after seeing maybe a police checkpoint. Yes, and most people do not follow this. There are people who don't care about the road signs because they literally don't know how maybe to read, or they can't interpret, maybe children crossing, or this and that. So, and yes, what needs to change? It means after seeing all this, it means there is need to increase monitoring by installing monitoring devices in cars that are directly connected to the police stations. And then we can set periodic notifications to drivers and other road users. Thank you.
Thank you. Let's have the next team. Second last, that is team 7. Group 7. Please come forward. Group 7.
Thank you so much. Good evening, everyone. Yes, so this is group 7. Our problem was overspeeding. So why does the problem exist? One, we have weak laws and they're being poorly implemented. You're not supposed to overspeed, traffic will get you, you bribe them, and you're good to go. So the laws are not being implemented. What is the other problem? Inadequate training. Everyone is driving. Who is licensing them? So the people on the roads, not everyone is in the know of what they're supposed to do, because your father will teach you how to drive, you will drive, but you don't know the laws. What is the other problem? Limited access to information. We do not know the traffic signs. Some of us have no clue of what is actually supposed to be done on the road. We actually don't know the speed limit, so you just drive. It's a free country. What else? Mental illnesses, like they alluded to in the previous presentations. When you're not mentally well, you will not even know that I'm driving over the speed limit. So how has the problem been solved? One, in the past, we have had speed governors, we have had the speed guns, we have had traffic checkpoints on the road, and we have had the road humps. So how have those solutions worked? Well, as some of the solutions that you've had, probably some are non-existent. The road humps, you'll see, sometimes when you're in a vehicle, people will reduce the speed once they approach the road hump. So some have worked, but not effectively. In countries like Rwanda, some of the solutions, like the use of the cameras, have worked. People are able to reduce the speed. So what needs to change? Geomapping. With geomapping, you are aware of the terrain, the geography of the road you're driving. So if you're approaching a corner, you reduce the speed. If the terrain is rugged, you reduce the speed. So it helps you to be aware of the road you're driving on. 2, AI control of traffic. If you're overspeeding, cameras are able to note you, they note your number plate. The next traffic checkpoint, they pin you down, and the next time you do better. Thank you so much for listening.
Can we give them another big hand clap? And finally, please walk forward. Okay. Group 9. You knew you were presenting next. You're waiting for me to call. Group 9, okay. Okay. Who's presenting?
Good afternoon, ladies and gentlemen. I'm Patrick Luguza. Our problem was dangerous mechanical vehicles, and it is caused due to shortage of funds. Some people don't have the funds to service their vehicles. Another problem is late vehicle servicing. Some people take long to service their vehicles. Another problem is unqualified mechanics. some mechanics are on the roadside. Another problem is fake spare parts, like some parts from China. Not a disclaimer. Another problem is mostly we import second-hand vehicles, which are usually faulty. The existing solutions we have, we should get memorandums of understandings with service providers for servicing vehicles like Total, Starbucks, and so on. Banning importation of second-hand cars and old cars, certifying the mechanics, and putting police patrols. So those are some of the solutions which are in place. And how have these solutions worked? In some cases, when you take a car for servicing, they give you that sticker which shows that your car is serviced. And there are technical institutes in place, like you can see them everywhere, technical institutes which train mechanics. And there's another solution of the SGS, Service General the Service, that thing which they used to check cars whether they are fit to be on the road. What needs to change? Mechanics should be given certificates, as you can see with they do with clinics, so that people to take your cars, you take them to people who are certified. And another one is enforcing the policies which exist, like to put a car on the road, it should pass the SGS test. Thank you.
Thank you so much. Let's have the last group, Group 8. Who is presenting?
Good evening. So the problem was overspeeding. And why is it that they overspeed? Some people are rushing to their work, caught up by programs. Some people are drunk and they are driving. Others, we also have corruption because some officers allow the bribes. And then how has the problem been tackled in the past? So we have had road signs for a very long time. Humps have been put on roads. We also have the traffic officers there, and as well speed governors in some vehicles for some organizations. How have those solutions worked? They indicate the road signs are indications for some of these. And then we have speed reduction by the speed governors. Then the officers monitor the road activity. As well, the speed governor also participates in intrinsic speed reduction, as I had said. So what needs to change about these things? We need to have things like the driver alert systems, which are in the countries abroad, but we don't have them here installed in many vehicles. We also need the road mapping terrain system, which is followed by the driving alert system. Like when you're driving, it notes the cars in front and it tells you there is a car coming, so don't overtake. Or it checks on your mental stability. Are you able to drive by some prompting questions? Also, the point of cameras, we didn't note there, but we have cameras, so we can also increase the number of cameras on roads. But our main focus was here, the driver alert system, because here in Uganda, we don't have this in many of the vehicles, and yet it is important. It reminds and prompts the driver to either stop or reduce the speed or even prevent overtaking, which would be unnecessary. So this is where we would lie in the innovating. This needs to change because we don't have the driver alert systems. That's our submission.
Thank you so much. Let's give a very big hand clap to all the teams. Wow. For some people are seeing this for the first time, how to identify a problem in such a short time and design a solution. It's amazing. Let's give a hand clap to Christine, our AIP. Thank you, Christine, for causing all this think tank about the problems about road traffic accidents. Thank you so much. Thank you, everyone. We are coming to the close. We have two closing remarks. No, for teachers, microphones are aids. They just aid. So I want to thank Camtech. Thank you so much, Martin and Nuriat, I think this shows what is going to be happening tomorrow through to Sunday. And already for those who made it for the clinical summit, which is this, you have the privilege now. You've been able to touch some of the things that are going to be happening the entire remaining 2 days. Yeah, but our time is fast spent. Let me take this opportunity to invite our country manager, Dr. Data Santorina. Yes, is the reason we are here, is the reason we've been here for the last 9 years, is the reason he's moved out, is largely the reason why innovation has taken root at Mbara University. Let's give another hand clap to Dr. Data Santorina. You're most welcome, Dr. Data. Yes, you can kindly come and make your remarks and take us through the last program. Thank you so much. You have been a very good audience. We meet tomorrow and Sunday. I wish you good day preparation.
Okay. Thank you. So I will go. Okay, you're running somewhere. Okay. Thank you so much.
Good evening. When I look at your faces, I see people who are loaded with problems. And that's a good thing for a pre-hackathon event. So in the first place, I would like to thank all of you for the active participation today. Before I proceed, I really want to recognize our partnership with very key institutions and organizations. And one of these long-standing partnership is with the Embassy of Uganda in Burundi. Whenever Camtech and Mbarara University goes to Burundi, we feel at home. So, Stawafula, thank you so much. And the Embassy of Uganda in Burundi has maintained their participation in the hackathon over several years. And I wish that you continue this partnership. The second organization we would like to recognize and appreciate is University of Ngonzi. Father Apollonia is the Vice Chancellor and Rector of University of Ngonzi. And every year, he makes it a point to come himself and bring students and staff to participate in the Medtech Hackathon. And every year, we also go to Burundi to participate in similar events. Thank you so much. And we hope that our partnership with the University of Gonzi will continue to grow. I would like at this point to also welcome a very important guest to us. And she has just joined us. She has probably traveled the longest distance, and she wins the award for traveling the longest distance. Miss Nadine, you're most welcome to Uganda, and you're most welcome to Mbarara University. Ms. Nadine is from the World Intellectual Property Organization based in Switzerland, and they have been supporting us over the years, and we are very glad that you could be able to come in person to join us. Karibu Uganda. So, this evening I just wanted to make the connection between the three events that are interconnected. One is the clinical summit. The second one is the get-togethers event, the cocktail that's going to happen this evening. And the third is the medical technology hackathon. So the clinical summit was designed so that, one, you could be able to listen to the people who are in the tunnels and solving and struggling with the problems in healthcare. And as I said this at the beginning, your faces look laden with problems, and that's a good thing. Now, take these problems to the cocktail. You heard the people who are talking about these different problems, engage them. Dive deep into the root causes of these what? Problems. And overnight, dream about the what? The solutions. And tomorrow morning when you come, put your best foot forward. Describe what you really want to, the problem you would like to work on, and invite the kind of talent that could join you and solve this problem. We believe that multidisciplinary innovation shortens the innovation pathway and ends up bringing the best in everyone. So thank you so much. I want to wish you a great interaction at the cocktail. The cocktail is going to happen at the Ajip Motel in town, and we have been told that they have given us a special gate to enter the Ajip premises. So please use the gate that is opposite gas petrol station. That gate is dedicated for you and you only. All right. So at this point, I would like to invite my good friend, my mentor, and also my boss, Dr. Annette Kembabazi, to make her closing remarks.
Thank you, Dr. Data. Good evening, members. All protocol observed. My name is Annette, as Dr. Data has mentioned, and I work as a senior program manager for the Global Health Collaborative. We work as a link between Mass General Hospital and Mbarara University of Science and Technology. And part of the things we support is basically the hackathons and Medtech. So I'm very happy this evening to be here to witness one of the outputs of the programs that we support under the First Mile program. Thank you so much. So I would like to thank the panelists who have just gone. I think they did a wonderful job. Majority have gone. The moderators, the MC, Medtech Uganda, the Global Health Collaborative, people from different institutions for the active participation. I think I was telling Dr. Data that I've been here, I think the longest. I have participated in all the hackathons, but I had never attended a clinical summit. I would always be busy in the office. But today, so I said, today let me come and be in class and see what these people are talking about. So whatever they were talking about was leveraging innovation to achieve equitable, sustainable health. So why are we here? We are here because we are talking about health. It is health. There are so many gaps, as you've seen in all the sub-themes they talked about today, the NCDs, the emerging pandemics, mental health, the accidents, and all these are there. There are so many gaps that are pending, and we need these gaps closed. People are always saying, publish or perish. So it is either you live a healthy life or you die. One of the doctors said, if you don't live a healthy life, your days to the grave are very near. So, and I think all of you innovators in this room, we are going to work hard and make sure that we don't go to our graves. Make sure we say no to NCDs by coming up with innovations that will address those. No mental health issues, no driving badly, good enough the traffic person is here. So let's do whatever it takes to do what needs to be done. And then I was just looking at the time when Medtech started. We're back. Me to go. So we're back in 2013 when they had like the first cocktail, the first clinical summit. I was telling Dr. Data, people would go out and look for clinical challenges. But because of the resources, we have not had like a sustainable kind of investment that can move these hackathons. Now people no longer go out, they come here and discuss. I asked Dr. Data, I said, Dr. Data, when was your first time you came to Kampala? He said, after senior 6. I said, when was your first time to go to the US? He said, in 2006. I said, how was the experience? He said, you know, it was different. So I'm just imagining if you went out to the field, or for the people who have been out to the field, and you saw all the challenges. I don't know how many people are clinical. How many clinical people do we have? Can we put up our hands? So these are the only clinicians, clinical, nursing, ABCD. So the rest are like you and me. So you can imagine, you've never gone out, whatever people are discussing, we are just imagining. We don't know what actually happens. I'm just hoping that maybe in future, you could also still continue to go down and get all these challenges finished. So I remember the very, very first time when Martin Mukama was busy talking about prisms and so many things. It's like we had just started, but now you come here and Medtech that started in 2019. This is the 9th hackathon. So that means 9 years, more than 9 years, because there was COVID time when it was missed. They have at least 7 products that are out there in the field, medical products. I think that is really a very big achievement. And I was asking Dr. Data, from the time First Mile started supporting, how many do you have in the pipeline? He said 12. And that is a very big achievement. So we can't take this for granted. And I'm hoping that from here, we're in the programming phase. My job is to basically go work as a partnership between MGH and MAST and other institutions, talk about how important Medtech is, especially for those who have never attended, emphasize the importance of these clinical summits, emphasize the importance of the hackathon, and see if we can get the next round of funding so that we have several innovations that move up and down. So I'll lastly end by delivering apologies from our program director, Dr. Stephen Asimwe, who is on his way from the US, as well as the executive director for the Center for Global Health, Professor Louise Ivers. All of them are aware, and our principal investigator is actually Professor Celestine Oboa, who is also out of the country. They all know that this is happening, but I wish you all the best in all your endeavors. Let's meet tomorrow. I'm also going to hack. I already developed an idea, so I'll see you tomorrow. A blessed evening.
The mix and mingle starts now and departure is at will. So let's meet at Ajip Hotel at 6. Thank you so much.
Integrating artificial intelligence in the 4 thematic areas will be an amazing and a great experience for these 3 days. It has started today, the 27th of October 2023, and it is closing on the 29th of October 2023.
Bring your event to life with our live streaming services. From parties, workshops, conferences, AYEDA TV will make sure your audience gets a memorable experience. Contact us today on 0789 000 492 or 0705